মিটিং হা আচ্ছা তাৰপিছত এতিয়া মই ইয়াতে কৰিব লাগিব
Hello.
Sir.
System को लोग mute speaker off act on रख. Actor speaker on rugby. अन्वाले headphone use को.
check. बस
अगला
बढ़िया
कैमरा आ गया
फिर तुम्हारा ये हुआ नहीं ठीक करो उसमें
नहीं
ये इधर देखना पड़ेगा इधर ओ इधर लगा नहीं हाँ लगा इधर सब करना पड़ेगा हेलो हेलो करो हेलो है ना हाँ
जाएगा ना?
बढ़िया ये बैनर बैनर बॉक्स पर
वो आ जाएगा पहले उसको सेटिंग करते हैं वो सेटिंग कर लेगा वो सुगुटे बचे बस यही है ना आज कोई लगा के रख दिया है ना इसी में नहीं आ रहा है
नहीं आ रहा है वो लोग स्क्रीन शेयर कर रहा है
ये वाला एवी मैट्रिक्स कोई भी बैठेगा तो एवी मैट्रिक्स करके रखेगा ठीक है इसका
म्यूट करो
एक साउंड इसका क्या है
कल क्या था
एवी
हेलो मैम
Check. Hello. Samsha.
Sound give up, okay?
Hello. 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 Hello.
Yes, you will audible, audible.
ऑडिबल ना
Audible and no echo.
Great.
Clear sound.
क्या साउंड ना
Yeah,
ओके
better than yesterday.
या
Sanghamitra. Hello. Sanghamitra, can you hear me?
Amurish, are you dear?
Yes, sir.
Okay. Have you informed the quiz participant like for joining in the preliminary round?
Yes, sir.
Okay.
They have been called.
Okay. Just ensure that they log in at time.
Okay, sir.
Okay. They will log in through the same net login link or like this one, the CSI Ne Cardiology Update 20 EC Live. That is the link that they will go to, or there is another link for that?
Same link.
Same link. Okay. You have informed them, na?
Yes, sir.
Okay. আমি গুনি আছো বাবা ঠিক আছে বাবা हाँ तब तो अच्छा ही है इसीलिए तो नहीं लगाने से भी होगा देखते हैं अभी ऐसा रहने दीजिए लगेगा तो आई लेट यू नो, चलेगा। हाँ एक बार चेक कर लीजिए। हाँ हेलो मी टू कंप्यूटर्स वर्क मालूम डेलीगेट मोबाइल और कोई डेमो करने पड़ेगा साले का डेलीगेट we took that class তুমি ফ্যাকাল্টি লিংকে জয়েন কৰা তপন যে তুমি ফ্যাকাল্টি লিংকে জয়েন কৰিলে মোক কবা। Ambarish,
Yes, sir.
you can hear me, right?
Yes, sir. Loud and clear.
Now, my voice is not echoing.
No, sir. Absolutely not.
Okay, thank you, thank you.
Yes, sir.
কৰা নম্বৰটো বৰ্তমান ব্যস্ত হৈ আছে অনুগ্ৰহ কৰি কিছু সময় পিছত চেষ্টা কৰক
सर कल ही का टाइम रहेगा 8-10 बज जाएगा
Very good afternoon, everybody. We are about to start our preliminary quiz round in 3 to 4 minutes time. I hope the moderator are ready, the organizers and the event management are also ready for the preliminary round. Dr. Ritu Porna and Dr. Amit, are you there?
Sir, hello.
Are also ready
Hello.
for the, yeah.
Sir, there is a auditorium which is open in the
Dr. Ritu Porna and
background
Dr.
on your side
Amit, are you
that
there?
needs to be closed. Sir,
Which one? Which one is open? Hello, can you hear me? Where is the auditorium? This one.
yes, auditorium, normal login, delegate login which is open.
Okay. Can we view that or we cannot view it?
I can only hear that, sir.
Sir, quiz participants have started joining.
Okay,
Once sir will give us green signal, I'll be posting the link there. Okay. So they have started joining. They have started sending me personal messages also when the quiz will start like that. Okay.
Okay, very good, Sangamitra. And what about, can I view the question from this faculty link or I cannot view it?
Right. So, and sir, we are live. We are live on screen. You are visible.
Now, what about the quiz question? Is it visible to us or it will not be visible to us in the faculty link?
Dr. Rituparna Bodua and Dr. Malvia will conduct the quiz, right?
Yes, yes, yes.
They haven't joined yet. So we'll have to wait for some more minutes.
Okay, okay.
Yeah. Sir, can you hear me?
Yeah. What needs to be done? Hello.
Yeah, I am connecting.
Yeah, Dr. Rituparna. Good afternoon, Dr. Rituparna. So you are live now. Dr. Amit is there, or you will start the preliminary round.
Okay, fine.
Hmm.
Am I audible clearly, Dr. Farid?
Yes, Dr. Rituparna, you are audible. You can go ahead. You can start the preliminary round. Dr. Amit is there, or he?
Sir, 1 minute.
Dr. Farid, for the preliminary round, how much time will be given for each question for the participants? Dr. Farid?
No, you can take your time. You complete the preliminary round by 2:30. It's up to you how much time you want to give.
No, there is give 1 minute time each question.
It's okay. It's okay from my side.
So put a timer there. Once 1 minute finished, then we'll go to the next question. Should I give the answer immediately?
Yeah, I don't know exactly how to go ahead. You just, Sangamitra, can you help Dr. Rituparna?
As it is the preliminary round, I think we'll move the questions first, and then answer will going to show at the end of the preliminary.
Okay, that can be done. Yes.
Sanghamitra, please put the timer for 1 minute each question.
Sir, 10 questions for 1 minute.
Your voice is not audible.
Sir, 10 questions for 1 minute.
No. Which questions? 1 minute for each question.
Sir, we have prepared one Google form, like single form with 10 questions.
Okay, should I share my screen, or you will display these questions?
No. What we have discussed, sir, can I call you? I'm calling you, sir.
Okay.
Sir, I'm calling you.
Okay.
Program start hol neki?
Start hobble hoise Rituparna conduct communicate kori ase.
আচ্ছা ঠিক আছে মই খুলি আছো আচ্ছা মোৰ স্লাইড খিনি মই ইয়াৰ পৰা কৰিম প্ৰেজেন্টেশনটো শেয়াৰ ইয়াৰ পৰা শেয়াৰ কৰি দিম হ'ব ন
আপুনি ঘৰৰ পৰা দি পেলাই আহিব পাৰে তাৰ পিছত টাইম আছে তো আমাৰ
মই এইটো কৰিম ঘৰৰ পৰা দিম মই দি পেলাই পিছত যাম
ঠিক আছে ৰাতি আহিব খালি
ওকে আহিম যাম যিমান একদম 7:15 গৈ পাম আৰু ঠিক আছে ওকে
আগলৈ
Okay.
ऑप्शन देगा ना क्लिक करना
Dr. Farid, are you there?
Yes, Dr.
Yeah, we can start the preliminary round.
Okay. You go ahead.
What we'll do first, I will officially start it, and then Chandramitra will tell all the instructions for the
Okay.
participants.
Okay, very
So
good.
we will wait for another 5 minutes because some participants are calling me that they are joining. They are requesting for 5 minutes more. So we'll wait for another 5 minutes, then we'll post a link. So please, who have already joined, the rules for the quiz is we will be posting a link in the chat box. Kindly stay connected to the chat box. The link will be in Google Form. So you'll have to click the link. You'll have to put your details like name, mobile number, and email ID, and there will be 10 questions MCQ type. We will be giving 5 minutes from posting the link. After 5 minutes, we'll be stopping taking responses. Okay, so you have 5 minutes for answering 10 questions, and this is the preliminary round. Once you qualify in the preliminary round, you will be selected for the final round. Final round will be from 4:30 p.m. to 5:30 p.m. and you will have to join through the Zoom link. The selected candidates will be receiving the Zoom link post the selection. Okay. So we are waiting for another 5 minutes. Then we'll be posting the link in the chat box.
So Chandramitra, once we officially start the preliminary round, then after that you please tell the instructions again, and then you start the preliminary round. Fine.
can probably start the preliminary round. Sangamitra, can you hear me?
Yes, sir. One more minute. 5 minutes. खत्म होने में एक और minute है. So I'll be posting it after 1 minute.
Yeah, you explain to them once more the preliminary round rules and regulation once more. Okay.
Yes, yes. Before posting the link.
Yes, yes.
Sir, approximately 30 participants joined in the audit. So we are posting the link now. Once again, I'm telling describing the rules. We'll be posting the Google form link now. You will have to click the link, type in your details, name, mobile number, email ID. Then you'll have to answer the questions. 10 questions are there, MCQ type. You will be given 5 minutes. After 5 minutes, we will be closing, taking responses. Selected candidates will be qualifying for the final round. Final round will be there from 4:30 p.m. to 5:30 p.m. We will be sending Zoom link to all the selected candidates. So I'm posting the link now. Wish you all the best. Amen. Link is posted. Kindly check the chat box. We are starting the timer now. Time's up. We are closing the taking response. Preliminary round is over. Thank you for participating.
Dr. Rituparna, you can give the answers, you can explain to them. We have some time.
Yeah, so I'll try to share my screen. So slides are visible, Dr. Farid.
Yes, please go ahead.
The first question in the preliminary round, the most common anomaly associated with coarctation of aorta, and the answer bicuspid aortic valve. So in 50 to 60% of the patient with coarctation of aorta, bicuspid aortic valve is involved. The second question is that which of the following receptors are known to mediate having Brewer reflex? So the right answer is pulmonary stress receptors. The third question is, which among the following is a systolic event? So this is JVP, and here A wave is the systolic event. Next question, what is the Duke treadmill score for a patient who exercised for 10 minutes of total 12 max and had a 1 millimeter of ST depression at peak exercise without angina? So there is definite formula for the Duke treadmill score, and the answer is 5. Because the angina is here 0, so the last part of the formula will be 0, so the answer is 5. Next question, what is the predicted maximum heart rate for 60 years old male on beta blocker? The crux of this question is that patient is on beta blocker, so there is a definite formula. And in the note section, you can see that it is the formula is 164 minus 0.07 multiplied by age, and the answer will be A. Next question, which feature favor RCMP over CCP? So restrictive cardiomyopathy, how to differentiate it from chronic constrictive pericarditis? And the answer is elevated pulmonary artery pressure. All are true about this spontaneous coronary artery dissection, except. So the answer is the question is except. So the answer is C here, because the intracoronary imaging shows accordion sign. It is basically a fluoroscopic image whenever a wire is inside the coronary artery, and in the tortuosities, and there will be accordion sign. So this question's answer is C. What is the drug combination recommended to avoid? Include all except. So answer is D, beta blocker and dihydropyridine calcium channel blockers. Most commonly the amlodipine can be added with beta blocker. So the answer is D. Next question, asymptomatic 45-year-old male with an new-onset atrial fibrillation and normal echocardiography who actually refused cardioversion. So what will be the next strategy? So the answer is C. So the next strategy will be rate control of atrial fibrillation. In a patient without structural heart disease, a wide QRS tachycardia of right bundle branch block morphology at heart rate of 160 beats per minute, and the QRS axis of -40 degrees, and there was definite heavy dissociation was noted during the palpitation, and the diagnosis is answer is B. So it is left posterior fascicular VT, because there is a left axis deviation along with right bundle branch block with definite evidence of ventricular tachycardia shown by heavy dissociation. So that's all. So these are all the questions in the preliminary round. Farin, over to you.
Thank you, Rita. Wonderful.
So you are
Sorry.
muted.
Yeah. Any participant want to ask anything to Dr. Rituparna regarding the questions? You have some query or you don't agree with him with some questions, you can just post it. On the
So
chat
we have
box.
received 12 responses. We are shortlisting the answers as per the number, I mean timing of the receiving number, and I am sending it to you, sir. Okay.
How many participants?
Saying is that if the
We have
participant
received, yes. So
is query regarding, suppose whatever answer Dr. Rituparna is giving, somebody is not agreeing or they want to clarify certain thing, then he can post it in the message box and Dr. Rituparna will be glad to answer that or clarify it. Or so I'm just giving 2 minutes time if somebody wants to post, otherwise we close the session and we'll move ahead with the next session. Rituparna, what is your plan? You want to take 6 of them for the final round or you want to take 8 of them for the final round?
We consider 10 final participants.
Since we have only 12, so you decide according.
How many participants so far in the preliminary round?
Sangamitra?
so we have received 12 responses. 12.
12.
Yes. We'll be sending you the list along with the answers. Give me some time. We are shortlisting it. Okay.
Okay. Let us first see the responses.
30 participants were there. 30 participants were there live. We have received 12 response. Okay.
I think we can close this session and I call upon Dr. Dinesh Kumar to start his presentation. Dr. Dinesh, are you ready with your presentation? We'll have a short, easy presentation from Dr. Dinesh Kumar and Dr. Rajat Agarwal. They will have their presentation for 15 minutes each, and then we'll move ahead with the free paper presentation at 3 p.m. Thank you, Dr. Rituparna. Wonderfully done. Thanks a lot.
We'll meet in the final round. See you.
Dr. Dinesh, are you there? Please proceed with your presentation. Sir.
So should we play the video? So should we play the videos of the sponsors now?
Please go ahead. Please go ahead.
Okay, okay.
Good morning, everyone. So, and respected teachers, I'm going to speak on the topic of ambulatory blood pressure monitoring.
Share screen. तो सुनाई देगा इधर से ज्यादा.
Dr. Dinesh, you need to share your screen.
Hello. Can everyone can hear me now? I'm going to share my screen now. Hello, am I audible now? So today I'm going to speak on ambulatory blood pressure monitoring. So as we know, there are 4 approaches to BP measurement. The first is conventional, the second is automated office BP, the third is home monitoring, and the fourth is ambulatory blood pressure monitoring. So the ambulatory and the home BP measurement have stronger association with hypertension-related target organ damage and clinical severe outcomes compared with the office-based BP. So we start with the conventional office BP. We take it by an average of more than equal to 2 readings taken at more than equal to 2 office visits. The BP measured is after 5 minutes of rest. Patient seated in a chair, back supported, an arm bare and at heart level with an adequate sized cup, and the patient having avoided tobacco and caffeine for at least 30 minutes before the BP measurement. The BP is measured in both the arms after 5 minutes of standing to exclude fall in BP, especially in patients of elderly age and diabetics and Parkinson's disease. So the staging of the office BP is normal is less than 120/80. Stage 1 is 140/60. Stage 2 is 160 to 180. Stage 3 is more than 180/110. And the isolated systolic is more than 140/90. The automated office BP is taken by oscillometric monitor, taking 3 readings at 1 minute intervals. the patient is unattended by medical staff and family members for at least 5 minutes, which minimizes the white coat reaction and correlates better with the home and the awake BP, ambulatory BP. On average, automated office BP is around 15 or to 10 mm mercury lower than the conventional office BP. The home BP improves medication adherence by actively involving the patients in their own medical care. The patient is rest quietly for 5 minutes in a seated position with back and arm supported on table at heart level and takes 2 readings in the morning and 2 in the evening for at least 3 consecutive days, preferably 7 days. The first day's readings are discarded as being partially elevated and all other readings average to make the clinical decision. The monitor with sizable memory storage eliminates the reporting bias. So by definition of the conventional, automated and out of office BP levels are the automated BP is more than 135 by 85, home BP is more than 135 by 85, and the conventional is more than 140 by 90. In the ambulatory BP monitoring, the daytime hypertension is taken as more than 135 or more than 85, and the nighttime is taken more than 120 by 70, and 24-hour ambulatory is taken as hypertension is taken as more than 130 by 80. The ambulatory BP monitoring is the gold standard as it measured during the 24-hour and better 48-hour period while patients are engaged in usual activities, including the sleep. It predicts the fatal, non-fatal MI and the stroke better than the standard office measurement. At least 2 measurements per hour during the patient's waking hours and average value of at least 14 measurements during that time confirms the diagnosis of hypertension. It is better and advantages of the clinic BP as it larger number of readings are taken, provide a better profile of blood pressure behavior in the patient's usual daily environment, and allows in identification of white coat marks and the nocturnal hypertension. So as we can see, the nighttime 24 and daytime measurement have better correlation with the patient risk factors of cardiovascular outcomes as compared to the clinic. In ambulatory one, this is the ambulatory BP device, and the method is the cuff is inflated until the pressure of fluids flow within the brachial artery. As the pressure releases, blood begins to flow, causing fluctuation in the arterial level that are detected by the monitor, and the oscillations increase in intensity, then diminishes, and then ceases. The monitor defines the maximal oscillations as mean arterial BP and uses an algorithm to calculate the systolic and diastolic BP. It is performed in a routine working day. Cuff is applied in non-dominant arm, and the cuff bladder end is adequate to encircle at least 80% of the arm circumference, and patients should be told to follow their usual daily activities, and they should not take any part during the BP measurement of the ambulatory, and should preferably avoid driving. Oral and written instruction are given, and a diary card is given to record the time of drug intake, the time of rising and going to bed, and any symptoms that is noted during the measurement. So ambulatory BP measurement can help in diagnosing the dipping status, the morning surge, the blood pressure variability, and the duration of drug effects which are not seen in the case of plain blood pressure or the BP monitoring. The BP load is defined as the percentage of ambulatory systolic diastolic pressure in exceeding 140 by 90 during the day or 120 by 70 during the sleep. The overall BP load also is a determinant of the cardiovascular risk. And moreover, the optimal values during the day of ambulatory BP monitoring is daytime BP less than 130/80, nighttime BP less than 110 by 65, and the 24-hour BP less than 125/75 are the optimal values in a normal patient. And this is the ABP ambulatory BP monitoring chart, as we can see. And during the sleep and the awake cycle, this is the lowest BP and the morning surge that we can see in a case of ambulatory BP monitoring measurement. The analysis and the algorithm for using the ambulatory BP measurement is more than 14 daytime readings or more than 7 nighttime readings, with more than 70% of readings being valid are taken. And then in assessing the ABPM hypertension threshold, the 24-hour average is more than 130 by 80, daytime average is more than 135 by 85, nighttime average is more than 120/70, is taken as hypertension. And the BP load, which is the percentage of readings above the hypertension threshold, ideally should be less than 20% in a normal patient. And to assess the nocturnal dipping, non-dipper, which are diagnosed as having less than 10% dip during the night as compared to the daytime BP, the normal is taken as dipping to around 10 to 20%, extreme dippers having the BP dipping at more than 20%. This is the standard BP pattern in normal patient. This is the normal BP pattern in ABPM. This is the systolic and the diastolic hypertension during the day and the nighttime drop. This is the isosystolic hypertension. This is the isolated diastolic hypertension. And the guidelines recommend ABPM over SBPM for diagnosing white coat hypertension due to larger number of studies demonstrating the superiority of ambulatory BP monitoring rather than home BPM over the office BP. The home BP measurements measures the resting daytime only, and the ambulatory BP measurement measures the dynamic daytime BP, moment-to-moment variation induced by postural, postprandial, and drug-induced BP changes, among others, and the nocturnal BP, including the non-dipping, reverse dipping, and the morning BP surge. The home BP measurement is recommended as an acceptable alternative to ambulatory BP measurement if only the ambulatory BP measurement is unavailable. And as we know that ambulatory BP measurement is largely unavailable to primary care practitioners who manage the vast majority of patients with hypertension. So the indication of ambulatory BP measurement is in absence of target organ damage or the BP more than 180 by 110, use ABPM or SBPM to confirm the diagnosis of hypertension. And it can be used in case of white coat hypertension, marked hypertension, drug-resistant hypertension, suspected nocturnal hypertension, evaluating the effectiveness of drug therapy of hypertension, and when there is a marked discordance between the office and the home BP. And the guidelines recommend to initiate anti-hypertension drug therapy if average awake BP is more than 135 by 85, average sleep BP is more than 120 by 70, even if the ambulatory BP measurement is less than 130 by 85, which is regarded as considered as a marked hypertension. And the patients were considered for high-risk patients, considering initiating the intensifying the drug therapy if average awake BP is more than 130 by 80, sleep BP is more than 115 by 65. And these are the patients who are considered as high risk and which are documented coronary artery disease, MI angina, EGFR less than 20 to 60, and 10-year CV risk of 15% greater, age more than 75, LVH, diabetes mellitus, prior history of stroke or transient ischemic attack, prior heart failure. Marked hypertension is defined by the average awake BP of more than 135 by 85, sleep BP of more than 120 by 70, even if the BP and the office BP is less than 135 by 85. It is associated with a high CV cardiovascular outcome. As we can see, the office BP is less, but the marked hypertension shows raised hypertension in patients, raised BP in patients with marked hypertension. White coat hypertension defined as ambulatory BP. Office BP is more than 135 by 85, awake BP less than 130, and sleeping BP less than 110 by 60, and global 10-year CV risk score is less than 7.5% with no evidence of target organ damage. And when it is so strictly defined by these conditions, it should not be treated. And as we can see, this is white coat hypertension showing office BP high, but rest of the BP is normal during the day and the sleep. And it correlates, white coat hypertension correlates with the normal hypertensive in a 10-year follow-up, and with the normal variability and white coat effect only. So white coat hypertension associated with minimal severity risk, whereas marked hypertension linked to detrimental CV outcome. And in nocturnal hypertension, nighttime, there are 4 categories of dipping. The dipper who are normally it should be 10 to 20% dipping in the BP as compared to the daytime BP in the nighttime. The non-dippers are the ones who have less than 10% dipping in the BP. Extreme dippers have more than 20% of dipping in the BP, and reverse dipper have in fact high BP in the night than in the day. As we can see in this diagram, the rise in non-dipper and the dippers. The independent of the degree of the hypertension, non-dipping is a risk factor for development of left ventricular hypertrophy, heart failure, and cardiovascular complications. Non-dipping has also been associated with diabetes mellitus, nephropathy, and decline in EGFR. So limitations of ABPM is limited availability, discomfort at night, and the cost. In imperfect reproducibility, intermittent measurement in sedentary variability, and inaccurate reading during the activity. So in conclusion, ambulatory can be regarded as a gold standard of prediction of the risk. Therefore, a good case can be made for using this technique in all patients in whom hypertension has been newly diagnosed. Thanks, everyone.
Thank you, Dr. Dinesh, for your wonderful presentation. You have lucidly explained about ambulatory BP.
Thanks.
Monitoring definitely will be useful to all of us. I request Dr. Rajat to kindly give his presentation. Be brief and complete within 8 minutes. Dr. Rajat, please go ahead. Dr. Rituparna, are you there? Please go ahead, Rajat.
Sir, we can't hear you. Dr. Rajat. Dr. Rajat, we can't hear you.
Rajat, you are not audible. The mic to there.
I think Dr. Rajat's video is actually off actually. His
Dr.
yeah,
Rajat is not audible.
yeah, that's why he's not able.
There is some connectivity issue. Let's see.
No, he should unmute.
His video is off actually.
Both his audio and video are off. Kindly make it on. If he is not ready, kindly go to the next presentation, please.
Yeah, probably Dr. Rajat is not ready. So probably we can start with the free paper presentation, sorry, competitive paper presentation. Dr. Rajat, can you hear me?
Just a minute.
Dr. Wasim, are you ready with your presentation for the competitive paper?
Yes. Oh, yes, sir.
Okay. So before that, I would like to introduce our judges for this session. In this session, we will have 4 judges. Professor Csi Ne from Assam Medical College, Dibrugarh, he is the HOD of Cardiology of Assam Medical College, Dibrugarh. Professor, are you there? Next judge is Dr. PC Sharma. He is the ex-professor of cardiology of Silchar Medical College. Dr. PC Sharma, Professor PC Sharma, are you there? And the other judges are Dr. Neil Bordloy. And he is a director of Excelsior Hospital, Guwahati. I believe Dr. Neil Bordloy is here. And Professor Dr. Barnali Doctor is the ex-professor of cardiology, professor and HOD of cardiology, and present professor of cardiology of Guwahati Medical College. I request all of you to kindly
Good afternoon, Farin. Good afternoon, sir.
Good afternoon, Neil.
Have Bornali joined and Dr. PC Sharma. Pravajdas joined.
Actually, he is not joining. PC Sharma is not joining. We are not taking a participant.
Prabhasda is not joining. Bornali is there.
Both of them are not in the list, in the participant list. I think Neil, you can start now.
Prabhasda has come.
2 more minutes. It's 14:50. Wait for just 2 more minutes before we start.
You can start.
Dr. Sharma sir is there.
Hemda Bornali.
Good afternoon, Sharma sir.
Good afternoon. I am on the car now. Just in 5 minutes, I will reach home.
Okay.
Anyway.
Welcome, sir. Welcome.
Pravajda, good afternoon.
Good afternoon. Hemda, welcome.
Welcome.
Start korok. মই গাড়ীতে আছো পাই যাম 5 মিনিটৰ ঘৰ
Sir, start korok. Ulta sir.
Dr. Barnali is about to reach our center. She is on her way, so we may probably start the first presentation of Dr. Wasim.
But how she will mark? Because she has to listen to the topic.
Farin, you can explain. You can explain. Farin, you can explain how the judges will mark. You are muted. Farin, you are muted. Farin, you are muted.
Good afternoon, everybody. So we are having 4 judges. Each judge will judge on their based on their assessment. Will give their marks out of 10, and all their marks should be sent to us to the organizing committee, and we'll compile them, and accordingly we'll declare the result after the competition is over. So we can start with the first presentation. Dr. Wasim, are you ready?
Yes, sir. Should I share my screen at this point of time, sir?
Yeah. With due permission, can we go ahead? Kalta sir,
Yes.
Neil and Mrs. Sharma sir.
Okay, go ahead.
Why didn't you just tell them that they have to maintain the 8 minutes, and you please control the 8 minutes, okay?
Okay. So each presenter will be given 8 minutes for presentation. Kindly stick to time. This is also an art, so you have to complete the presentation within 8 minutes.
And
Please go ahead, Dr. Wasim.
Just 1 minute to interrupt. Whether judges can ask question or not.
Yes.
Okay.
Prabhasda, 2 minutes. 2 minutes are there. 8 plus 2.
Okay.
8 minutes presentation, then 2 minutes. 2 minutes cross question.
Okay.
So, with respect to, well, I'd like to ask, should I start, sir?
Sure.
Good afternoon, everyone, respected teachers. I would like to start off with a presentation which is on comparison of heart failure and hospitalization in patients treated with RNI or ACE inhibitors in a tertiary care hospital in Assam. We all know that RNI consists of valsartan and neprilysin inhibitor, that is sacubitril. And when this neprilysin natriuretic peptides are dysregulated, it causes pathogenesis and worsening of heart failure. That is by neprilysin inhibition, we see that it causes natriuresis, vasodilatation, decreases hypertrophy, decreases fibrosis, and decreases sympathetic outflow tract. The effects which are moderated by AT1 receptors based on uptitration of RAS. So we all know that AHA and ACC guidelines have now given a class 1 recommendation of replacing ACE and ARBs by RNI by further to reduce the morbidity and mortality after the results of Paradigm trial, which showed a significant reduction of cardiovascular death and mortality. So after that, various studies have shown the similar results by improving mortality and hospitalization, but there was a lack of such study in the northeastern population. So that's why we aimed at doing this study. We had the following aims: to decrease, to assess the rate of hospitalization, to assess the mortality status, renal outcomes, and to assess the quality of life and health status by Kansas City Cardiomyopathy Questionnaire. We had the following materials and methods. It was done in Department of Cardiology and started in April 2019 to 2020. The following inclusion criteria of patients age group of more than 18 with a history of heart failure hospitalization last 1 year with an EF of less than 35%, NYHA class of 2, 3, 4, and a raised natriuretic peptides, with exclusion criteria of systemic hypertension or BP of less than 100, EGFR of less than 30, with patients with pregnancy and history of angioedema to ACE and ARBs. Patients were stratified to RNI group when they were on ACE or ARBs. A washout period of 36 hours were given in ACE inhibitors, not in ARBs, and aim was to uptitrate to a target dose of 200 milligrams twice daily. And similarly, in ACE group, the aim was to uptitrate to a target dose of 10 milligrams. It was, the sample size was 30 patients in each group in RNI and ACE inhibitors. It was a single center comparative prospective observational study, and we followed up at 1 month, 3 months, and 6 months. The mean age group of patients in RNI was 50. All the statistical variables were matched at the baseline. The majority of patients were male. The systolic BP was 114, matched with the control group with the ACE and ARB. Heart rate and serum creatinine was 1.05, which was also comparable in both the groups. 20% of the patients had ischemic cause of LV dysfunction with a mean EF of 27%. The mean NT-proBNP was 1,590, which was also comparable. And the patients with heart failure, majority of had NYHA class 2. The comorbidities, majority were the diabetes mellitus, hypertension, and dyslipidemia, apart from stroke, atrial fibrillation, MI, and smoking. All the patients were treated with guideline-directed medical therapy consisting of beta blockers, MRAs, and ACE and ARBs, and RNI. Apart from that, digoxin, iodine were used, and diuretic based on the indication whenever it was indicated. Among the results, the RNI reduced significant heart failure hospitalization over and above ACE inhibitors, which was statistically significant. 36% in hospitalization ACE inhibitors, RNI, and 66% in ACE inhibitors. There was a significant improvement in the Kansas City Cardiomyopathy Questionnaire, and there was no significant mortality benefit as the p-value was 0.276. 3 patients died in ACE RNI group and 6 in ACE group. There was no significant improvement in the LVEF at the 6 months follow-up. but there was significant improvement in the NYHA class at the end of 6 months, improving from 2.4 to 1.4 over and above ACE inhibitors. There was significant reduction in NT-proBNP levels from 1500 to almost 326 over and above ACE inhibitors. Now, based on kidney parameters, there was significant improvement in the serum creatinine levels, and also in eGFR study, this was something which we improved in the form of kidney function test, with hypertension being more common in RNI group. Coming to the discussion with various studies, our age group was comparable with the inter-CHF studies done by Csi Ne et al. And paradigm study, and also in sub-analysis study with main age group of around 50 years, which was not in accordance with Trivandrum heart failure study and the global cohort of paradigm, which had age group of around 63. We had age group of around 59. So males are all common in all the studies, which I have mentioned in the previous slide. The majority of comorbidities were hypertension, diabetes on the slide, and the burden of stroke and atrial fibrillation was also similar, but just the incidence of myocardial infarction was not comparable because we had only 20% with LV dysfunction with the cause of ischemia. NYHA class, majority had NYHA class in all the studies in paradigm and also in Indian sub-study. The ejection fraction was also comparable with 27%. It was similar in all the cohorts in various studies. The NT-proBNP levels were also comparable in all the studies, apart from Csi Ne, which has NT-proBNP levels of 9,000 at baseline. There was similarities in the study, our study with the other paradigm and Indian sub-study with paradigm, with similar parameters. Now coming into the efficacy, the rate of hospitalization was significantly reduced by RNI in our study, which was seen in paradigm also and Indian sub-study also. Mortality outcomes, as it was significantly reduced in the paradigm study, but we did not have it in the our study because it was statistically insignificant. The health quality rate of life, it was significantly improved in our study by RNI and was also comparable in the previous studies. The ejection fraction outcomes was similar. There was no improvement in ejection fraction, but the study done by Csi Ne et al. Showed improvement on a follow-up of 6 months. The NYHO class, there was a significant improvement, which was comparable with study with Csi Ne et al. There was a significant improvement in the NT-proBNP levels by significant p-values, which was comparable with various studies. Now coming to renal outcomes, we had a good renal outcome, and which was comparable with K. Daman et al., which showed that we had improvement in serum creatinine levels and eGFR levels, which was not seen in the paradigm trial. But coming to efficacy outcomes, the paradigm safety profile, the paradigm had, it was safely tolerated with all the patients, but the only hypertension was more in the RNI group, rest apart cough, and the hyperkalemia was more in the NNR group. Coming to the summary, we had 60 patients. They were randomly, simple randomization to both the groups, RNI and ACE inhibitors, with a main age group of 50 and all other variables which were compared in both the populations. We observed significant improvement in various efficacies like heart failure hospitalization, improvement in NYHA class, improvement in the quality of life assessed by KCCU score, and there was no significant improvement in the mortality, along with significant improvement in the renal outcomes in the form of eGFR and serum creatinine. The mortality outcomes were not improvement, but it was safely tolerated in both the population groups. Coming to the conclusion, therapy with RNI can be safely initiated and escalated in our patients, and substantial benefits are evident at a low dose. Since out of 30 patients, we could only uptitrate this medication only in 11 individuals to a level of 100 milligram twice daily. None had a dose of 200 milligram twice daily, and the rest had only 15 milligram twice daily, apart from other studies. But what we saw was significant reduction of heart failure hospitalization, renal outcomes, and also in the KCCU score, that was health-related quality of life. So this is the first study which was done in Northeast India, and it has showed wonderful results that we can start with low dose, and we can also aim to achieve the similar results as achieved with 200 milligram twice daily. But with the limitation that we had only 60 patients, and it was a single center study with low number of patients, so we need further studies to further stratify and implement this observation which we achieved. Thank you, sir.
Thank you. Kolita, sir.
Why did you stick to, am I audible?
Yes, sir, you are audible, sir.
Why did you stick to 30-30 number only? Because we do get good number of heart failure patients, because your study period was probably 1 year.
Sir, I did start off my study.
Wait, please. Did you select those very patients particularly, or continuously whoever coming with heart failure with an ejection fraction of less than 35% you have selected?
Sir,
That is,
sir, I selected all the patients.
that is one question. That is
Yes,
number one
yeah.
question. Second
Yes,
question
sir.
is, did you need to withhold Arnie because of any reason? Or
Yes,
Arnie
sir.
or, yeah, please
Yes,
go
sir.
ahead.
So the first answer to the first question is I selected all the individuals come to our OPD basis for heart failure. But the only question was I had to select those patients which were ready for follow-up and which were able to participate in the study with full authorization, with full, their cooperation from my side. Along with that, I did simple random sampling to divide them into ACE and RNI group. And regarding the other question, sir, I had to stop in 10 individuals RNI when in 10 in the 11 individuals, I could uptitrate to a dose of 100 milligram twice daily with permissible hemodynamics and without any adverse events in the form of hyperkalemia and worsening of kidney profile. But out of 12, the further 12, as 3 patients died, only 10 patients could not tolerate because of hypertension and hyperkalemia. So that's why I could not uptitrate it further. And the remaining could only be given on 50 milligram twice daily. So that is the answer to the second question.
Nobody stopped the medicine.
No, sir, nobody stopped the medicine because I took the patients who were very willing to take the medications. That's why my sample size were less because of this, and also because of COVID pandemic. It was just started when my study was started, sir.
What is the dose of SC inhibitor? It was Ramipril, all Ramipril, or you added some SC inhibitor?
Sir, it was all Ramipril to be started with 2.5 milligram and to be uptitrated to. But interestingly, sir, I could uptitrate Ramipril to 10 milligram in almost 70%. It was not in RNI group, but still I was able to see the benefits of the RNI, sir.
How many ischemic patients and non-ischemic heart failure patients were there in your study?
So ischemic were 20% and 80% were non-ischemic, sir. 6 patients
So these 20 ischemic patients, were there acute coronary syndrome or they were
established ischemic cardiomyopathy, non-acute coronary syndrome, sir.
So you did not take acute coronary syndrome patients?
Sorry, sir, I did not take acute coronary syndrome, sir.
So you are aware of the recent trial Paradise MI?
The Paradise MI trial was done with comparing the RNI and the ACE inhibitors, and acute MI subset population was taken up.
So what was the conclusion of that study?
Sir, the conclusion was RNI does not give any superadded benefit in comparison to ACE and ARBs when started in acute MI population. If I'm not wrong, sir, I'm just know it.
Yeah, basically it was shown that RNI didn't have a benefit in acute coronary syndrome MI patients. It had no benefit over Ramipril in the subset of patients of acute myocardial infarction with heart failure.
Yes, sir.
That was one important thing.
Exactly.
But of course, the molecule used was Ramipril, while in the Paradigm heart failure, the molecule used was enalapril. So do you feel the change of molecule in any way influence the result, or you think it's the same class effect, so it didn't make any difference?
Sir, I think it's just a class effect. So I do not think it should make a difference out of it up based on my knowledge.
So what were the difference in your subset with your findings of heart failure in this Northeast subset with the findings in the Trivandrum heart failure registry?
So Trivandrum heart failure registry, the mean age group was more. So they had a mean age group around 63, and they had it was just a heart failure registry which had to look for heart failure hospitalization. So RNI was not the modality of treatment in
no, of course, we can't compare the two. Yours was just a small, and theirs was a registry. Yeah. But some points are that I think they were female more dominant in the Trivandrum, while whatever patients you picked up, probably in this part of the country, because females may come for medical checkup less regularly, so therefore it could be biased in that sense. And Kerala is a more advanced state with higher literacy, so females and males may equally come for medical opportunities.
Sir.
Thank you.
Welcome, sir. Thank you.
We'll go to the next speaker. Next paper. Dr. Csi Basir, no? Harin?
Yes, sir. Dr. Csi is having some connectivity issue. We are trying to sort it out. I request Dr. Gugu Gogoi to go ahead with his presentation, please. Dr. Gugu, are you there?
Yes, sir.
Okay, please upload your presentation and you can go ahead. You will be given 8 minutes for your presentation. Kindly stick to time.
Okay, sir.
Please start, Dr. Gogoi.
Dr. Bubu, you share your screen. I'm joined by our professor, Dr. Bonali Doctor. So,
Hello. Sorry, I'm a little bit late.
Hello, Bornali. Neil here.
Dr. Gogoi, your presentation is not coming. You have to click on the presentation. Dr. Gogoi, can you share again?
Is it viewable, sir? Now?
You have to
Hello?
share again. You have to share again.
Okay, okay.
Dr. Gogoi, are you using a mobile phone to share?
Yes, sir. Yes, sir. It is in the phone itself.
Irene, anybody else has their presentation ready?
next in line is Dr. Ananya Goswami. Are you ready? Dr. Ananya, are you there?
Yes, sir. Sir, can you hear me?
Yes. You can share your presentation. We'll go to Dr. Bubu later. If you are ready, you can share your presentation.
Sir, is this visible, sir?
You share your screen. Not visible now. You share your screen.
Sir, I have already, so just wait a minute.
If anybody is having issue, you can send your presentation to the event management group, Cubics event. They will upload it if required.
Sir, is it visible now?
Yeah. It's visible now. You go ahead, please.
Good evening to one and all present here, respected judges and everyone. My name is Dr. Ananya Goswami, and I'm going to present a paper on the profile of cardiac manifestations in HIV/AIDS patients. As we all know, HIV/AIDS is a global pandemic with cases reported from virtually every country. A rapid expansion of access to antiretroviral therapy has helped lower AIDS-related deaths in recent years. HIV-infected patients with heart disease represent one of the fastest growing groups with acquired heart diseases, and it may have a tremendous global impact. The disease spectrum can range from clinically quiescent to clinically devastating abnormalities. From the beginning of AIDS epidemic, it was recognized first at autopsy and later by non-invasive techniques that HIV infection can cause cardiac abnormalities. Cardiac causes are also an important cause of death in patients with HIV. The prevalence of cardiac disease in AIDS patients was found to be around 28 to 73%. So this is a diagram showing the major cardiac manifestations in an HIV/AIDS patients. As we can see here, HIV can infect almost any part of the heart, including the heart chambers, the layers of the heart, and the vessels. The major manifestations found were pericardial effusion, left ventricular dysfunction, myocarditis, dilated cardiomyopathy, endocarditis, pulmonary hypertension, malignant neoplasm, coronary artery disease, and drug-related toxicity. The aim was to study the cardiac manifestation in HIV/AIDS patients. It was a hospital-based observational study conducted at Guwahati Medical College and Hospital with a sample size of 303 and within a duration of 1 year. Data was mainly collected by interviewing the patients and attendants by thorough physical examination by relevant investigations and reviewing records in ART Plus Center. Diagnosis of HIV was done by ELISA antibody testing as per NACO guidelines after written consent was taken. To evaluate for cardiac manifestations, electrocardiography and echocardiographic examination using the standard methods was done in all patients. Patients who were included were HIV positive adult patients above 15 years, irrespective of their antiretroviral treatment status. Those who were excluded were all HIV positive children below 15 years, patients with pre-existing congenital heart disease, coronary artery disease, valvular heart disease, and long-standing hypertension, patients with chronic renal disease, chronic pulmonary disease, patients on other cardiotoxic drugs, and heavy alcohol consumers. Now, coming to results and observations, we saw that most of the HIV patients were in the age group of 31 to 40 years with a male dominance, and a percentage of 64.6% were males. In this study, out of the 303 patients, cardiac manifestations were found in 160 patients, which was more than 50%, that is 52.8%, and some of them also had more than one cardiac manifestation. So this is a table listing out the most important cardiac manifestations which were seen in the HIV/AIDS patients. The most common was LV diastolic dysfunction, followed by pericardial effusion, dilated cardiomyopathy, pulmonary hypertension, coronary artery disease, and infective endocarditis. This is a graph showing the same. As we can see here, the patients, maximum of the patients had LV diastolic dysfunction. Another finding of the study was that patients who had a CD4 count less than 200 had an increased incidence of cardiac manifestations. Out of the 174 patients with CD4 count less than 200, cardiac abnormalities were found in 124 patients. And out of the 127 patients with CD4 count more than 200, cardiac abnormalities were found in 36 patients, which was statistically found to be significant with a p-value of less than 0.05. This is a graph showing the same. As we can see here, patients with CD4 count less than 200 had a higher incidence of cardiac manifestations compared to those who had a CD4 count more than 200. Now, coming to discussions, in the present study, cardiac manifestations were found in 160 patients, which is similar to the studies conducted by Csi Ne et al., Marwadi et al., and Isser Hess et al., who reported cardiac manifestations in around 58, 49, and 53% respectively. In the present study, left ventricular diastolic dysfunction was the commonest cardiac abnormality, which was similar to study conducted by Bajaj et al., who reported LV dysfunction to be the most common cardiac manifestation. This dilated cardiomyopathy was found in around 35 cases, which was similar to the study done by G. Barbaro et al. Pulmonary artery hypertension was found in 34 patients, which was similar to the other studies. Out of the 174 patients with CD4 count less than 200, cardiac abnormalities were found in 124 patients. And out of the 127 patients with cardiac abnormality more than, with CD4 count more than 200, cardiac abnormalities were found in 36%. This was similar to study done by Isser, HS et al., who reported that 73% patients with CD4 count less than 200 had cardiac manifestations. Lastly, coming to conclusion, in this study, it was found that left ventricular diastolic dysfunction was the most common cardiac abnormality in HIV/AIDS patients, followed by pericardial effusion, dilated cardiomyopathy, pulmonary hypertension, and valvular regurgitation. We also found that the CD4 count had a negative correlation with the cardiac manifestations. Lastly, since cardiac manifestations were found in more than 50% of the cases in an HIV patient, it is very necessary to screen all the HIV patients at the very onset for the presence of cardiac manifestations with an ECG or an 2D echo. Thank you.
How did you, okay. You have finished, no? How did you diagnose LV diastolic dysfunction? Methods on echocardiography? Do you have any idea? Could you hear me?
Sir, hello, sir.
Yeah, how did you diagnose, what is the method to diagnose LV diastolic dysfunction? Number one. Number two, majority of your patients are 40 plus.
So
There may
around 30 to 40 years, the majority of the patients.
Yeah, in those very diastolic dysfunction patient, what is the age group? Because in elderly person, otherwise also there may be diastolic dysfunction grade 1 or grade 2.
Yes, sir. But sir, some studies have shown that HIV itself can lead to left ventricular diastolic dysfunction by
That you would know, that you would know, provided before HIV you have done an echo and after HIV you have done an echo, because
yes, sir.
this
Yes,
is one-time echo, so you won't be knowing.
Yes.
First of all, how did you diagnose LV diastolic dysfunction? Secondly, how many patients were elderly actually? Did they have any symptoms of heart failure at the time of diagnosis? Yeah, please.
So first of all, in the echo, there will be a reduced ejection fraction, and the volumetric relaxation phase will be decreased. And we'll also calculate the E/A ratio in an echo, where E is the velocity of blood flow during the early diastolic phase, and which is divided by the velocity of blood flow.
Be very specific because time is very limited. So
The
your answer should be
isovolumetric
very specific.
relaxation and the
I
deceleration
think
time.
someone
Mostly
on-
these three
someone
factors.
Any other judge would like to ask any questions, please?
So mostly these three factors are
Okay,
studied
okay.
in the echo.
You wait for
Then-
Purnali, you want to ask something?
Ananya, it's a nice
yes, ma'am.
I would like to know, as you have said that many of patients have pericardial effusion.
Yes,
So
ma'am.
whether presented in tamponade, whether it's a mild pericardial effusion, moderate or severe, or any patient presenting with tamponade?
So, ma'am, tamponade presentation was very few patients presented with tamponade. Most of them were mild to moderate.
What was the outcome of those patients? Is there a separate subgroup analysis? Did you do?
Ma'am, on evaluation, most of them were found to have other opportunistic infections other than HIV, which is most common was found to be tuberculosis. The outcome was poor in those categories.
Cardiology. I'm asking about the presentation, whether it was a cardiac tamponade, medical emergency, cardiac emergency. So any patient presented in your study, any patient presented with cardiac tamponade or not?
No, ma'am.
Were all on retroviral therapy? All the patients?
Some had started, sir, and some were not on treatment. Majority had were already on treatment. With,
Do you think that retroviral therapy could also have a role in causing cardiac manifestations, or they are totally safe?
No, sir. Some of the retroviral, antiretroviral drugs such as protease inhibitors and zidovudine have been linked. Zidovudine have been linked with dilated cardiomyopathy, and some have they are also known to cause dyslipidemia, which in itself is a risk factor for some of the cardiac manifestations, such as coronary artery disease.
Thank you.
This is a one-time echo, or you followed up those very patients?
So,
with some-
I had followed up. So.
Followed up.
Yes.
No, you followed the patient, but did you do a repeat echo subsequently? Suppose somebody is having pericardial effusion, did you repeat it subsequently?
Yes, sir.
Any difference? Not only in pericardial effusion, in LV ejection fraction, because few of the patients you detected to have dilated cardiomyopathy. Did they improve with the therapy or deteriorated with the therapy?
So with therapy, they had improved some.
Okay, thank you.
After
that means you did another echo.
Yes, sir.
That you
So
didn't
after-
mention in your. You didn't mention it in your presentation.
Yeah.
Why did you exclude children? It would have been interesting to see cardiac manifestation in children.
Because mostly the patients were inpatient and outpatient departments coming to the ART center and the medicine OPD. So there were not many children. Thank you, sir. Thank you, ma'am.
Thank you.
So we'll move on to the third speaker, Harin, who is going to speak. Bulu Gogoi, are you ready? Farin?
Dr. Aditya Nore will be the next presenter.
The Bubu is still not ready. I believe Dr. Aditya is ready. Please go ahead, Dr. Aditya.
Hello, sir. Am I audible, sir?
Yeah, yeah. You share the screen.
Hello, is my screen visible, sir? Hello.
Go to
Slides are not clearly visible. Kindly make them in slideshow mode.
Okay, sir.
Raghumitra, you're saying something?
Now are the slides visible?
No, go to slideshow. Click on the slideshow below.
Yeah. You go to slideshow. Go to slideshow.
Yes, sir.
Yeah, go ahead.
Is the slides visible, sir?
Make it full screen, please.
Sir, please
You can do one thing. Shift and F5. Shift F5 together. Shift F5.
Hello. Is the screen visible now, sir?
Yeah. Now you can go ahead.
Okay, sir. Hello. Good afternoon, respected judges. I am Dr. Aditya Narayan Chakraborty, postgraduate trainee, Department of Medicine, Guwahati Medical College and Hospital. I am going to present a paper on risk factor profile in heart failure with preserved ejection fraction. Heart failure is a clinical complex syndrome that results from any structural and or functional impairment of the ventricular filling or ejection of the blood. Based on ejection fraction, heart failure can be classified in heart failure with reduced ejection fraction, where the LVEF is less than 40%, heart failure with mildly reduced ejection fraction with LVEF 41 to 49%, and heart failure with preserved ejection fraction with LVEF more than 50%. Approximately half of the patients with signs and the symptoms of heart failure have a left ventricular ejection fraction that is not markedly abnormal. Epidemiological studies have consistently demonstrated a heightened risk of all-cause and cardiovascular mortality in heart failure with preserved ejection fraction compared with heart failure-free individuals. The high prevalence of comorbid cardiovascular disease and cardiovascular risk factors in heart failure with preserved ejection fraction is well recognized. Because of lack of effective pharmacological targets to improve outcomes and mortality, the emphasis of the management and prevention of the heart failure with preserved ejection fraction should be through control of the risk factors. Therefore, it is of public health importance to know the risk factor profile in patients with heart failure with preserved ejection fraction. Guwahati Medical College Hospital is a tertiary care hospital getting patients from entire Assam and the Northeast India. With this background, this study was conducted. The aims and the objectives were to study the risk factors associated with heart failure with preserved ejection fraction. It was a hospital-based observational study. The study was conducted in the Department of Medicine and the Department of Cardiology, Guwahati Medical College and Hospital. The duration of the study was a period of 1 year from the 1st June of 2019 to the 31st May 2020. The sample size was 105. The data collected was as per pre-designed pro forma, a complete clinical examination and the necessary investigations. The inclusion criteria: patients above the age of 18 years of the age and the patients with congestive cardiac failure with normal ejection fractions were included in the study, whereas patients with rheumatic heart disease, congenital heart disease, patients with heart failure with reduced ejection fraction, with prosthetic heart valves, constrictive pericarditis, anemia, hypothyroidism, ventricular pacemakers, chronic obstructive pulmonary disease, and renal failure were excluded from the criteria from the study. The results. The age distribution. Nearly 93% of the patients were above 50 years of the age. The number of the patients within the age group of 51 to 70 years is 70, that is the 66.66, which is maximum within an age group. The mean age was 63 years. The gender distribution. Out of total 105 patients, 70 patients were female and 35 patients were male. It shows the female preponderance. The addiction profile of the patients. 30.47% patients had history of smoking and 26.66% had a history of alcohol intake. Now coming to the clinical profile. The chief complaints. The dyspnea on exertion and the lower limb swelling. Orthopnea, cough constituted the majority of the symptoms, out of which dyspnea on exertion was the most common chief complaint. Coming to the physical examination findings, pedal edema, which constituted 71.4%, and raised JVP, which constituted 64.76%, were the most common finding on general physical examination. The vital signs. Most of the patients had tachycardia. 19% patients had atrial fibrillation. Most of the patients had hypertension, and out of them, most had stage 2 hypertension. Most patients were tachypneic. Now coming to the risk factor profile of the heart failure with preserved ejection fraction based on this study. It revealed hypertension is the most common risk factor for the heart failure with the preserved ejection fraction in this study, which is 64.76%. It was followed by diabetes mellitus, 33.33%, obesity, 28.35%, and the coronary artery and atrial fibrillation. Summary. The study conducted over a period of 1 year from June 2019 to May 2020 at OPD and the Indoor of Medicine and Cardiology Department, Guwahati Medical College and Hospitals. A total 105 patients from age group above 18 years presenting with signs and the symptoms of the heart failure with preserved ejection fractions were taken for the study. And the results revealed more than 90% of the patients were aged more than 50 years with the mean age of 63 years. Males constituted 35 cases, that is 33%, and the majority were female. The hypertension was the most common risk factors, followed by diabetes mellitus, obesity, coronary artery disease, and atrial fibrillation. Conclusion. At least half of the patients presented with the sign of the symptoms of the heart failure have normal ejection fraction, which is associated with significant mortality and the morbidity. In our study, most frequently associated comorbidities were hypertension, diabetes mellitus, obesity, coronary artery disease, and atrial fibrillation. Due to lack of approved pharmacological therapy, early detection and the prevention of these modifiable risk factors may be the only way to prevent heart failure with preserved ejection fraction till late. The references. Thank you.
What is the method on echocardiography you used to measure the ejection fraction? Which method did you apply, or you applied multiple methods? Secondly, do you know any drug which is recently being, a trial has been recently, very recently being published, which shows prognostic benefit even with preserved ejection fraction, at least up to the level of 65%?
Sir, spironolactone can be used with poor class of.
No, that is being used. I mean, all those drugs which were used in reduced ejection fraction are also tried in preserved ejection fraction, and none of the drug has been shown to be prognostically benefited. Symptomatically, they are benefited. Yes. But do you know any drug which is latest publication? Emperor preserved trial. Anyway, okay. It is SGLT2 inhibitors.
Dapagliflozin.
Not DAPA, it is AMPA, empagliflozin 10 milligram OD. Okay, which method did you apply for measurement of ejection fractions on echocardiography? Anyway, any other? Prabhas, Neil, Bonali, tomorrow.
Was the criteria historic heart failure in your study?
Can I ask?
Infection or anti-proBNP or any other criteria was taken?
Due to financial constraints, the ethical committee didn't clear the NT-proBNP as an inclusion criteria. So based on clinical criteria.
During our study period, anti-proBNP was done free of cost in our hospital because the study was done at KMC. Was it not necessary to go for anti-proBNP other than ejection fraction to diagnose the diastolic heart failure?
Yes, sir. Yes, ma'am. It should have been taken into the inclusion criteria.
The definition says that NT-proBNP
is
there are cutoff values for NT-proBNP.
Yes, sir.
I'm saying that there's a by definition you have a cutoff value for proBNP and NT-proBNP. So to define heart failure with preserved ejection fraction, you should have done the NT-proBNP.
To say whether patient has symptoms that is only because of diastolic heart failure or due to some associated comorbidities. I would like to ask you about how many percentage of patients were having CKD, chronic kidney disease?
Ma'am, CKD patients were not taken into account. The patients were excluded, ma'am.
You found in quite large number of patients there was raised GBP in almost 68% or something like that. Is it that common in diastolic heart dysfunction? You get so many patients having raised GBP and edema also. Then clinically we will think it is with reduced ejection fraction. Is it that common that in diastolic dysfunction you get raised GBP in so many cases?
Yes, sir. Yes, sir.
And in patients of atrial fibrillation, how do you assess the diastolic dysfunction by echocardiography? And method of, assessment of ejection fraction?
The cardiologist did it, I think. He didn't do it. He medicine PG.
Yeah.
I just want to say that you have presented it well, but I think already it's very well known that what are the risk factors for heart failure with preserved ejection fraction are quite well known. We had that screen HF trial. We are very clear. Though we don't know how to treat preserved ejection fraction, we are quite clear about what are the risk factors and how to prevent them. So basically, your study would have been more pertinent if you had said with respect to Northeast also, are there any unique features in the Northeast? So, that type of, when you want to expand your study, whether you can include tribals also in the Northeast and whether there are any type of risk factors unique to this region, which you can identify as risk factor for HFpEF. That would make this study a better study, I think. Thank you.
Thank you, sir.
Yeah, we can go to the next speaker probably.
I'd like to request Dr. Ritu Ponna an announcement for the quiz, who has been selected for the final rounds. There are 8 participants who has been selected for the final rounds. They will have to get ready for the next presentation. Dr. Ritu Ponna, are you there?
Am I audible?
Yes, yes. Yeah, please tell the names and.
Yeah, after the preliminary round, 8 participants are selected for the final quiz round. I am mentioning the names of the participants. Mohesh, Aldous. These are the 2 participants scoring highest in the preliminary round, followed by Bhavani, Dr. Ramesh, Wasim, Likitesh, Kakoli Medi, and the last one is the project. I am mentioning again the names: Mohesh, Aldous, Bhavani, Ramesh, Wasim, Likitesh, Kakoli Medi, and Rajat. Thank you for it.
Thank you, Dr. Ritu Ponna. Congratulations to all the participants and those who have been selected for the final round. You get ready for the final round. It will be starting in the next 45 minutes time. Now we go ahead with the next presentation by Dr. Bubu Gogoi. Dr. Bubu, are you ready?
Yes, sir. Yes, sir. Hello, sir.
Am I
audible, sir?
Upload your presentation now.
The technical team actually upload the slides here from my side. And
Okay. I'll request Cubics to upload his slide. Yeah. And you keep on speaking as they go ahead. And you just say next. Okay.
thank you, sir. Today I am going to present on my paper. Title is Profile of Heart Failure with Reduced Ejection Fraction in Patient with Anemia. Next. Heart failure is a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. Heart failure with reduced ejection fraction is defined as the clinical diagnosis of heart failure and left ventricular ejection fraction is less than equal 40%. And it is also known as systolic heart failure. Next. So heart failure is a global pandemic that affects an estimated 26 million people worldwide and resulting in more than 1 million hospitalization annually in both US and Europe. In India, proper data was not available, but Huffman MD and Prabhakaran D conservatively estimated the prevalence of heart failure ranges from 1.3 to 4.6 million with annual incidence of 491,600 to 1.8 million patients. Next. There are several comorbid conditions which, irrespective of primary etiology of heart failure, contribute to disease progression and worsen the prognosis. One of them is anemia, which is not only common in heart failure patients, but also associated with impaired cardiac function and increased risks of mortality and morbidity. It is associated with a greater severity of the disease, poor functional status, and higher hospitalization rate. Next. In this study, the relationship of anemia in patients with systolic heart failure was studied and tried to find out severity and types of anemia in these patient groups. Next. Methods. This is a hospital-based observational descriptive study carried out in different units of medicine and cardiology department of Guwahati Medical College from 1st June 2016 to 31st May 2017. A total number of 120 patients of heart failure with anemia were evaluated. Data was collected by interviewing the patients and or attendants by thorough physical examination and by doing relevant investigations. Next. Inclusion criteria are left ventricular ejection fraction less than or equal to 40%, age more than 12 years, clinical diagnosis of heart failure, hemoglobin less than 13 gram per dl in male patients and 12 gram per dl in female patients, according to the WHO definition of anemia. Next. Exclusion criteria: pericardial, any valvular disease, congenital heart disease, or pulmonary, and age less than 12 years. Next. Results. In this study, consisting of 120 anemia with heart failure patients, 50 patients, around 41.67%, had mild anemia, that is 11 to 12.9 gram per dl for male and 11 to 11.9 gram per dl for females. And 49 patients, around 40.83%, had a moderate degree of anemia, which is 8 to 10.9 gram per dl. And next, 21 patients, about 17.5% had severe anemia, less than 8 gram per dl, and the mean hemoglobin was 10.12 gram per dl. Next. It was found that the type of anemia was predominantly normocytic normochromic, which is anemia of chronic disease in 88 patients, which is 73.33%, and microcytic hypochromic anemia in 23 patients, and macrocytic anemia in 9 patients, which is both are actually nutritional anemia. Next. And this is the table showing the types of anemia, which are already discussed. Anemia of chronic disease 88, iron deficiency, macrocytic anemia 23 and 9 respectively. Next. Now the degree of anemia in relation to LV ejection fraction, the mean LV ejection fraction was 35.23. The mean hemoglobin was 10.82 gram per dl for the patients with moderate LV systolic dysfunctions and 6.37 gram per dl for patients of severe LV dysfunctions. Next. This is the 30 to 44 is moderate LV dysfunction, LV ejection fraction. Number of cases is 101, which is around 84.7%. And mean hemoglobin of this patient category is 10.82, and less than 30 ejection fraction, which is severe decrease in the ejection fraction, is around 19 cases, which is for hemoglobin of that category patient was 6.37. Next. The relationship of degree of anemia and with the NYHA functional classification also studied. The mean hemoglobin was 8.45 for patient with NYHA classification 4 heart failure and 11.32 for NYHA class 3 heart failure and 12.44 for NYHA class 2 heart failure patients. Next. Anemia in relation to the number of hospitalization for heart failure patients. There is we divide in 4 quartile of the patients according to the hemoglobin range. Less than 8.6, around 30 patients, and 30 out of 30 patients got 100% hospitalization. And number of mean hospitalization is in this group is 2.3. Accordingly, 8.6 to 10.6 group, around 25 patients, which is 83.3%, got history of hospitalization with mean number of hospitalization is 1.3%, 1.3. And 10.7 to 11.7 groups, 18 patients were hospitalized, which is 60% of the total patient of this group, and mean number of hospitalization is 0.75. And more than 11.7, there is 7 patients had history of hospitalizations, which is around 23.3%, and mean number of hospitalization is 0.2 only. Next. Next. Mortality among the study patient. There is around 20%, 24 patients died during the study period of one year, and which is about 20%. And degree of anemia and mortality is also correlated. Severe anemia, around 11 patients died, which is about 52.38%, and in moderate anemia group, 18.37%, and mild anemia group, only 4 patients died, which is about 8%.
You should come to the conclusion because your time is going to get over.
Next.
So we come to the conclusion, I think.
In conclusion, anemia is commonly found in heart failure patients, and anemia of chronic disease is the predominant type. There is an inverse relationship between the degree of anemia and LV ejection fraction, as well as NYHA classification is also noted. Heart failure with reduced ejection fraction patients with lower hemoglobin values tend to have more frequent hospitalization. Next. Patients with more severe anemia have higher mortality compared to those with lesser degree of anemia. Thank you, sir.
Huda, Neil,
What was the cause of heart failure in those patients? It is the anemia or the heart failure of other cause anemia precipitate the heart failure. And the mortality you have said is so high. What is the reason that so high mortality in the anemia of less than 8 gram? We have not seen that anemic patients dying so frequently.
Sir, this study was conducted during 2017 years, actually. In the time, it is, according to this study, the anemia is associated with heart failure, and the other causes of heart failure is not considered. We are only considering association of anemia and heart failure. Other causes of heart failure is not considering, actually. We see only the association of anemia with heart failure.
Did you test serum ferritin?
Exactly.
Did you do serum ferritin in these very
Yes,
patients?
sir.
Or?
Yes, sir. Yes, sir. Serum ferritin was actually serum ferritin value was taken into consideration, but as the heart
We did
failure
not show
is
it over here. No, we do not want explanation. Was it done? If it was done, it
Yes,
should
sir.
have been
Yes, sir.
recommended
Done.
because in heart failure,
Done.
serotonin, yeah, iron
Done, but
deficiency is quite common.
yes, sir. Done, but it is not correlated. That's why it's not mentioned because the heart failure is a
It has to be correlated because almost all study has shown that heart failure shows iron deficiency. Even without anemia also, there may be some people who will have iron deficiency, and giving iron, that is now the class 1 indication, giving iron in iron deficiency below a stipulated level by ESC.
But in our
Anyway.
studies, sir, we are predominantly found
Anyway, you
normal
did not
people.
show that slide, so we are not going to argue that. Neil or
So no, I was just asking. You often get because of hemodilution, you get lower values of hemoglobin. So did you take that into consideration when you diagnosed anemia in your patients?
Exactly, sir. It's a good point that anemia patient has definitely hemodilution, but in this study, that part is not considered. That part is not evaluated.
Okay.
It should be evaluated.
Your study, one thing is not clear, as Sir also has mentioned, that whether your LV dysfunction is the cause or effect of anemia.
We are seeing only the association of anemia with heart failure in this study, basically.
you are not going to the etiological factors. So based on that
Only association
okay,
of anemia with
okay.
mortality, morbidity.
Thank you. I think there should have been some relation of iron deficiency, be it there anemia or no anemia. Anyway, thank you. We can go to the next topic, please.
Thank you, sir.
Dr. Ruby, are you ready with your presentation? We can move to Dr. Ruby Colita. She will be speaking on pericardial cardiomyopathy. Dr. Ruby, are you there?
Yeah, she is very much there.
Please go ahead, Dr. Ruby. Go ahead with your presentation.
I don't know whether she is being communicated or not. Dr. Ruby, could you hear?
Please unmute yourself, Dr. Ruby. Unmute.
It seems she. Dr. Ruby, could you hear us?
Okay, we'll get back to her after this, after the.
Okay. Okay. It is better to go to someone.
Hello, sir.
Okay.
Hello, sir.
Hello. Could you hear us?
Yes, sir. Yes, sir.
Are you ready?
Sir, yes, ready, sir.
Please go ahead.
My topic name is peripartum cardiomyopathy, clinical study in a
Show your
tertiary care
slide. Show your slide. We have not seen your slide.
Share your screen, please.
Share your screen.
You have to press the green button.
There is a share screen in the bottom
Yes,
of your.
yes.
Press that share screen.
Yeah, it is audible. It is visible now.
Go to slideshow then.
Sir, is it visible now, sir?
Yeah, very much.
My topic name is peripartum cardiomyopathy, clinical study in a tertiary care center. Peripartum cardiomyopathy is a rare form of dilated cardiomyopathy which contributes to the common causes of heart failure during pregnancy. It is an idiopathic form of cardiomyopathy presenting with the heart failure secondary to LV dysfunction where no other causes of heart failure has been identified. It is infrequent but critical disorder which is destabilized heart is diagnosed within the last month of pregnancy or early puerperium and often complicating the obstetric as well as anesthetic management. The diagnostic criteria are development of heart failure within the last month of pregnancy or the first 5 months postpartum, or absence of any identifiable causes of heart failure and absence of any recognizable heart failure during the last months of pregnancy. The additional criteria are left ventricular systolic dysfunction demonstrated by classic echocardiographic criteria like depressed ejection fraction, fractional shortening along with the dilated left ventricle. Aims and objective of the study to study the mean age of presentation of pericardium cardiomyopathy in a pregnant patients in a tertiary health care, and to study the various risk factors associated with the peripartum cardiomyopathy, and to study the maternal and fetal outcome of the patients. Definition of cardiomyopathy: it is a disease of the heart muscle leading to the cardiac dysfunction with the characteristics pathological remodeling and eventually leading to the heart failure. Cardiomyopathy is defined as a disorder characterized by morphologically and functionally abnormal myocardium in the absence of any other disease that is sufficient by itself and to cause the observed phenotype. Classification by American Heart Association 2006 classified as primary and secondary. Primary consisting of hypertrophic dilatant peripartum cardiomyopathy, and secondary cardiomyopathy is diabetes caused due to diabetes, lupus, and thyroid disorder, etc. Peripartum cardiomyopathy, it's a cardiovascular system undergoes significant structural and hemodynamic changes during the course of pregnancy. There's a major increase in cardiac output and a decrease in maternal and systemic vascular resistance. The renin-angiotensin-aldosterone system is significantly activated and the heart and vascular remodeling occurs. And this adaptation allows the fetal growth and development, and maladaptation has been associated with fetal morbidity. These are the changes in pregnancy. Cardiac output increases during the pregnancy when systemic vascular resistance decreases, heart rate increases, and BP decreases during the pregnancy. Etiology of peripartum cardiomyopathy: the increased maternal age, the high peri is important risk factor for peripartum cardiomyopathy, unlike selenium deficiency, hypertension, systemic hypertension, viral myocarditis, autoimmune mechanisms, and familial and genetic predisposition, and prolactin. Elevated prolactin occurs in nursing mother, and is cleaved 16 kilodalton N-terminal fragment of prolactin has been shown in experimental studies to produce the marked endothelial damage and cardiomyocyte dysfunction. And pre-eclampsia and vascular endothelial growth factor signaling also contribute to peripartum cardiomyopathy.
Ruby, you go to your presentation. Don't you go to your presentation? You lose time otherwise. You don't need to tell the whole.
This introductory part is not necessary. You go to your findings.
Go to your study.
Clinical presentation of dyspnea or.
No, you go to your study.
Here is the age distributions. 48% of the patients are 21 to 25 years of age. Anemia status, risk factors like anemia status. It is found that mild anemia is found in 40% patient, moderate anemia in 31% patient. Gestational diabetes is found in 8% patient, and thyroid abnormality is present in 13% patient. And multiple gestations, there is 6% patient with multiple gestations. Parity status, about 5% patients gave 4 or more birth, by para of more than 4, and there is primary parents patient was 65%, and others 2 to 3 births are 30% patient. Hypertensions, non-hypertensive 41% are without any hypertension, and 10% patient already had pre-existing hypertension, and rest pre-eclampsia and eclampsia associated 21% of patient. Most of the 75% of patient presented in the first month of postpartum, and 5% during delivery, and in second and third part postpartum 10% patient presented. Most of the presenting features, 100% presented with the dyspnea, then 71% with orthopnea, and 86% has pedal edema, anasarca in 30%, and chest pain in 25%, and palpitation in 68%. Severe dyspnea, mostly there is NIHA class 3 is 26% patients presented, and the NIHA class 4 is 38% patients presented. Maternal outcome, 5% patient presented from thromboembolism, 8% had arrhythmia, and 10% that is 6 patients died, and remaining 46% patients are uncomplicated. The causes of death mostly are heart failure. 50% patient died of heart failure, and CVA is 16%, and 33% is sudden cardiac death. Fetal outcome, 68% are live-born, and IUCR was 16%, and rest stillborn is 3%, neonatal death is 3%, and premature and prematurity is 8%. Discussion. The mean age of parentation is 25 with plus minus 4 years. Anemia and multiple gestational diabetes are commonly associated in women with peripartum cardiomyopathy. Almost all the patients at onset of system during postpartum period. TUDICO was done to confirm the diagnosis and assess the concomitant pre-existing cardiac disease. The features of dilated cardiomyopathy such as annulus, atria, ventricle, and trivial regurgitant lesions, and of mitral and tricuspid valves are seen. The thromboembolism and arrhythmias are common severe complications. Conclusions. Pericardium cardiomyopathy is a form of the systolic heart failure, which should be included in differential diagnosis of any woman presenting with dyspnea in the late pregnancy or in early puerperium. The majority of patients are young primipara presenting postnatally. The preeclampsia and coexisting hypertension appears to be strong association and play important role in pathophysiology. The other risk factors are anemia, diabetes mellitus, twin pregnancy, obesity, poor socioeconomic status, and malnutrition. The 2D echo parameters play a crucial role in early diagnosis and assess the disease severity, and early diagnosis and aggressive medical and obstetric management lead to good maternal and fetal outcome. Thank you.
How many patients you picked up? Because I have seen your entire slide, but I didn't know how many patients you picked up.
Yes, sir, 60, sir.
You did not
60.
start with that slide, the patient population. It did not start with that.
Sir, 60 patients was there.
60 patients. How did you diagnose clinically to be a peripartum cardiomyopathy? Because first you picked up clinically, then you will go for echo, because each and every patient we do not send for echo.
Mainly the patient presented with dyspnea, exertional dyspnea, edema, and orthopnea in the last pregnancy, in the last month of pregnancy, or within 5 months of after delivery.
Yeah, their duration is important, but most importantly, see, in last month of pregnancy, whatever symptoms you would see, dyspnea and exertion, sometimes even orthopnea, it may be because of the pregnancy itself also. But fortunately, peripartum cardiomyopathy in the last month of pregnancy is very less. Most of them would come in the peripartum period. So
sir, we have to rule out the other causes of
that's right. Before other causes, see, any patient who passed on a uneventful pregnancy up to the full term, there was hardly any symptoms of heart failure, delivered hemodynamically, now should be better. And at that point of time, patient after 1 month, 1.5 months, 2 months, 3 months, patient started having symptoms. That is the number one point that you should suspect that this is a patient of peripartum cardiomyopathy. You should ask, how was your past pregnancy? Last pregnancy. I was fine. Even majority of them would deliver at home. Your majority, 65% of patients were primi. How do you explain? Because literature said in the West, I do agree that it is mostly primary, because we also had a registry over here. But in West, majority of them are more than 2 para, multigravida, and age is also 30 plus. In our patients, mostly below 30. How do you explain that? Could you get my point? Dilated peripartum cardiomyopathy in your study is 65% primary gravida. But
if the
literature
patient
says,
once they have pericardium cardiomyopathy in a fast pregnancy, they are advised not to have the further pregnancy.
No, you could not get my point. Anyway, you could not get my question probably. Anyway, anyone?
Did you follow up your patients? For how long was the follow up done?
Follow up till the hospital stay was done.
So after that, you didn't follow up?
No, sir.
Because actually, then you would know how many patients are going to recover and how many are not. Because within 6 months, you get a clear picture about who are going to recover. So I think in your study, you should have also seen what are the, if you had followed up for at least 6 months, and then picked up what are the prognostic markers which give a better outcome to the patient, and which prognostic markers give a worse outcome to a patient, then your study would have been better if you had done a follow-up in 6 months.
And this is one cardiomyopathy where if you treat well, and most important treatment is of course rest. Let them have good rest and give all the evidence-based guideline directed treatment. Good number of patients can revert back to the normal ejection fraction. This is one dilated cardiomyopathy where you can have a very good prognosis. But if they do not recover their ejection fraction by about 6 months, they do go for a worse prognosis.
So in this study, you should also include things like ECG. What is the QRS width?
Yeah.
Then what is the troponin value? Because all these have prognostic markers. So those things should also be included in your, and even your LV size. What was the LV size? So LV size may be normal also, but if it is large, then it's a bad prognostic marker. So all these things would make your study more complete. Thank you.
Prabhas? Bonali?
On the questions, then proceed to the next presentation.
Okay, thank you.
Bonali has come.
Okay.
Dr. Sakil Ahmed, are you there? Dr. Sakil? Dr. Sakil, can you hear me?
Yes, ma'am. I can hear you.
Are you there?
Yeah.
Okay, then you continue. Start your presentation.
Okay, ma'am.
Make it full screen. Dr. Sakil, can you hear me?
Yes, ma'am. Good afternoon, everyone. Myself, Dr. Shakil Ahmed Khan. I am presenting clinical usefulness of angle between left main and LAD and LAD LCX for the evaluation of obstructive coronary artery disease. Background for the study was the angles between the left main coronary artery and the LAD and between the LAD LCX are important as it results in hemodynamic changes secondary to variation in shear stress that may lead to the plaque initiation in arterial system. On reviewing the literature, Malek, ChatGPT, Han, Csi et al. Morbidusi and Csi proposed that, and they demonstrated that shear stress led to coronary artery disease. Malek in 1999 suggested that molecular phenotypic switching of endothelium by shear stress offers an integrated model to explain the focal nature of atherosclerosis. ChatGPT et al. In 2008 suggested that the magnitude of low endothelial shear stress predicts the development of high-risk plaque. Han and Csi in 2010 and 2011 suggested that hemodynamic changes resulting from variation in the shear stress according to the coronary bifurcation angle have an effect on plaque initiation in the arterial system, and low shear stress is considered atherogenic. Morbidity in 2016 suggested that low and oscillatory shear stress is recognized as one of the most important determinant in plaque initiation and progression. Csi in 2000 also suggested that the evaluation of shear stress may be useful for predicting the risk of developing restenosis after coronary and peripheral angioplasty and for devising a coronary stent with the stent design less thrombogenic. Kimura observed that atheromas in the very proximal left anterior descending artery are located opposite the circumflex takeoff. Chai Hana in 2008 studied the effect of various angulations of the left coronary artery on hemodynamics based on simulated and realistic coronary models and concluded that there is a direct relationship between wide angulation in the left coronary bifurcation and hemodynamic changes such as disturbed flow and low wall shear stress and wall shear stress gradient, indicating the possible inducement of atherosclerosis. Sun et al. In 2011 found direct correlation between left bifurcation angle and formation of plaques. Malve et al. In 2015 suggested a wide LCX angle induced plaque formation in the arterial system. Temo et al. In 2016 suggested
Dr. Khan,
that the high...
Dr. Khan, why not you
Yes?
go to your findings? These are literatures.
Okay.
You have given enough
Yeah,
literatures.
okay, I will go faster. Sir, this diagram is showing this image showing it was taken from the Csi Ne study, and it was showing that various angulation has different wall shear stress, and with increasing coronary angle, wall shear stress decreases, and it is heterogenic. This image is showing the measurement of vessel diameters and angles using protector software and Philips cardiac packs. This is the biochemical and pathological findings in the study participants, and the results of the study was the mean age of study participant in our study was 57.89 years. More than half of the patients were hypertensive and about half were diabetic too. About 1/5 were smoker in our study. The mean left main to LAD angle was 39.14 degree, and the mean LAD LCX angle was 91.74 degree, and the mean left main LCX angle was 110.98 degree. The wider angle between LAD LCX was shown to have significant diagnostic relationship with the CAD. Our study results have shown that at 82.5 degree, the sensitivity of detecting CAD is 92% and specificity is 68.2% with area under the curve of 0.789 with significant p-value. The contribution of LAD LCX angle in prediction of CAD stenosis was also close to significant in multivariate analysis and there was no statistically significant correlation of vessel diameter with the amount of blockage in the vessel in our study. This is the ROC curve between left main LAD LCX, left main LCX angle with outcome variable as LAD blockage more than 50%. And area under the curve is significant for left main to LAD angle and LAD LCX angle. This is the ROC curve between left main LAD LCX and left main LCX angle with outcome variable as LCX blockade more than 50%, and the area under the curve is significant for LAD LCX angle only. In the study done by Sun et al. In 2016, mean LAD LCX angle with normal left coronary was 75.5 with the deviation of 19.8 degree, and in and with diseased left coronary artery it was 94 degree, and in my study the mean LAD LCX angle in the patients with LAD obstruction more than 50% was 101 degree, and in patients with LAD obstruction less than 50% it was 81 degree. Konisi T et al. In their study, mean left main to LAD angle in patients with in-stent restenosis was 52.2 degree, and in patients without in-stent restenosis was 32 degree. Although my patient was without stenting, and left main to LAD angle for significant stenosis was 44.16 in obstruction more than 50%, and in cases less than 50% it was 33.45% significant value. In Juan et al., mean LAD LCX angle in groups with more than 50% coronary obstruction was 87.34 degree, which is close to my study 100, and in my study it was 101, and mean LAD LCX angle in groups less than 50% coronary obstruction was 81.16 degree, and in my study the LAD LCX angle in patients with less than 50% obstruction was 81.09. So this finding was close to Juan et al. Study. I would also like to mention one point which I forget to mention, that in previous studies the coronary angle was means calculated using coronary CT angio. In my study, it was done coronary angiography, and I made the Moon et al. Study basis for my study. And Moon et al. Concluded that left main to LAD angle is more accurate predictor of LAD stenosis than LAD LCX angle. And in Moon et al., left main to LAD angle in cases of more than 50% obstruction was 49.4%, and it was 36.2 degree in cases less than 50% coronary obstruction. LAD LCX angle was 72.9 in cases more than 50% LAD obstruction, and it was 62 degree in cases less than 50% LAD obstruction. And in multivariate analysis in Moon study, LAD LCX angle greater than 60% showed a trend toward predicting significant LAD stenosis, and a left main to LAD angle greater than 40% was a significant predictor of significant LAD stenosis. The wider angle between LAD and LCX has shown to have significant diagnostic relationship with CAD in our study also. In our study, the ROC curve between left main to LAD angle and the LAD stenosis showed the cutoff value of 35.5 degree with sensitivity of 76% and specificity of 63.5%, and the area under curve of 0.747 with significant value, which was similar to that stated by Konisi et al. And this cutoff was 40 degree in study by Moon et al. At sensitivity of 88.9% and a specificity of 68.5%. Our study results
Your
show
time
that
is over again. Your time is over. You want to say some concluding remarks?
Conclusions, the result of our study has shown that higher left main LAD and LAD LCX are significant predictor of CAD, and if detected earlier, it will be helpful in planning the appropriate management for CAD patient pre and post intervention. The left main coronary bifurcation angle should be assessed as part of routine clinical practice to identify high risk patient and to prevent CAD related events. Thanks.
Thank you. I think most of the studies which you have quoted, one is that I think they don't have any Asian population, correct?
Yes, sir. No Asian
population. So Asian means Indian population is not there. Of course, some of them are Korean studies, but you don't have Indian population. So in that sense, or is there any data about Indian population also?
No, sir. There is no data for Indian population.
So that is why maybe you can expand the study and then give the data of Indian population. The second is that most of these studies, I think, have used CT angiography. Some of them may have used CT and conventional angiography, but I think most of them, so in CT angiography, you can exclude most of the human errors and even foreshortening and other things. So I'm not sure, but I think most of the studies are CT angiography studies.
Yes, sir. Most study, almost all studies was CT angio.
So the gold standard for measuring these angles is probably CT angio, not conventional angiography.
No, sir. In that studies also they used the 2D plane only to measure the coronary angle, sir. Means they have not created the 3D model to calculate the coronary angle. So I think in most study which I have quoted, they used they have taken 2D plane only for the calculating the coronary angle. It was
but it was done as a CT
models. Yeah,
it was done as a CT angiography, not as a conventional angiography.
Yes, sir. It was CT angiography, but they used 2D models only for the calculating the coronary angle, sir.
Yeah, good. It's interesting.
Yeah, it's interesting topic. Did you consider the diameter of the vessels also? Because just shear stress is not dependent only on the angles; it is also related to the diameter. And the disease in the proximal part of LAD or LCX, up to how long you would consider the disease because of related to angulations? Because if it is beyond certain distance, that shear stress will not be affecting to causation of atherosclerosis.
No, sir. First point was regarding
diameter.
First point was
diameter of the
regarding
vessel.
the diameter. Yeah, sir. Diameter in my study there was no relation between the change in diameter from left main to LAD and left main to LCX. It was non-significant in my study, and it can be explained because the blood flow is laminar. So I don't think that once it is divided, it will create any shear stress. But
what sir is asking is that mid-LAD lesions, those which are beyond proximal, are those also related to this angulation, or it's only the proximal lesions?
Yes, sir. Yes, sir. Actually, sir, this is related to angle. Suppose if there is another bifurcation because of septal or diagonal, then same theory will be applied to that place also, because this shear stress is created by the angulation. So suppose artery start first first there is bifurcation in left main, there is LCX, then LAD, then again if there.
It's okay. We got your point. We got your point. Yes. But I think that's an interesting topic and interesting point to study further. But we need actually case control device, because in this very coronary artery disease, you have multiple risk factors. All these patients must have had diabetes, hypertension, hypercholesteremia, and so on and so forth. So if
Yes,
you
sir.
have a good number of patients who had and stratify them based on the similar group of risk factors, then look for the angulations.
Confounding variables can be.
Confounding variables
Yes,
has to
sir.
be. So
Yes,
if
sir.
in the form of
Sir,
a case control study, then probably it will be better.
Yes, sir. Yes.
Anyway,
Sir,
it's
that part
good
can
that.
be, sir, that part can be explained by the fact that whatever the confounding factor is, it is applied to the whole coronary tree. But there is certain points which is disease. So suppose patient is diabetic or hypertensive.
See, when you have lot of risk factors, lot of confounding factors, you need more numbers so that you can, in the multivariate analysis, you can have a better pictures. Because with these very numbers, you won't be able to. But it's a very good point to look for. Many people have looked into this, but it is but you need more and more number of patients, because it may be a simple accidental finding also, and many a time. So if you have a good numbers, you can negate the confounding factors, and in that case, how much is the role of this angulation, we can really do see.
Sir, in one study by Csi Ne et al. In 2018, he in simulated models, he demonstrated that shear stress was decreased at the bifurcation with increased angulation, and that was the basis for
that was the basis for hypothesis. But point is, see, our coronaries are not only tube; it is a dynamic tube.
Yes.
So even with your defective angle, if it is arteries are quite dynamic, your shear stress may not be that effective. So you have to look into all those things. If there is already a disease coronary, already atherosclerotic fibrous coronary, that angulation will cause more shear stress rather than a dynamic coronary artery. Anyway.
Yes, sir. Sir,
yeah,
there was one.
We have finished our time.
One more point.
Okay.
As he said that in your conclusion, that assessment of that angle will predict the disease. Will you go for assessment of angle in the healthy population? After you have gone for angiography in a disease patient, then only you have found.
Sir.
Or you want to do the routine testing of the individual that these people are going to have coronary disease with this much of angle. You made a comment like that in your conclusion.
The patients with proximal lesions who are at risk of developing disease, because this is the bifurcation disease. So the patients who are having proximal LAD or LCX disease, and we are doing intervention in those patients. So in those patients, we may consider the coronary these bifurcation angle, because in one study it has been seen that after PTC of proximal part, the coronary angle.
No, you are not getting the proper question.
That is your observation while doing angiography or for an intervention. But can you predict? For prediction, will you do angiography for the normal handy individuals? And then you predict that he's going to have disease.
Definitely, sir. If suppose we get a patient with totally normal angiography and angle is very high, so we may consider to,
you have to follow up these patients more carefully.
Follow up these patients to look in the future that may these patients are getting.
But I don't think it's a reason that you will start doing angiography in normal patients. That is what sir is asking.
Doing angiography in every patient.
Your final conclusion appears to be in the line of what Professor Sharma has mentioned. As if we'll do angiography to find out that variable, to speculate that yes, you are at higher risk. Anyway, that's good idea to, if because of some reason or other you have gone for CT, it is a good idea to look for that very angle. Do we have any other speakers? CG Basir?
Thank you, sir. Thank you, sir.
Go ahead with the next presentation of Dr. Csi Basil. If she is ready, please go ahead, Dr. Csi. And then we have a free paper presentation by Dr. Malgia after this.
I'm presenting a paper on a study of serum vitamin D in patients having chronic obstructive pulmonary disease. COPD, chronic obstructive pulmonary disease, which includes defined condition characterized by destruction and enlargement of lung alveoli, and chronic bronchitis, which is a clinically defined condition with chronic cough and phlegm. And COPD is a preventable health importance. And the recent speculation suggests that COPD will rise from 63rd most common cause of mortality by 2020. Vitamin D is a fat soluble vitamin that regulates important number of body functions, including calcium absorption, bone metabolism, neuromuscular function, and immunity. Despite the classical role of vitamin D in skeletal health, new aspects of vitamin D have been discovered in organs other than the bones. Vitamin D deficiency is defined as having the serum levels of vitamin D less than equal to 20 nanogram per ml. Recent findings, the prevalence of vitamin D deficiency is between 33 to 77% among advanced COPD patients. Lower levels of vitamin D in these patients may be explained by the reduction in cutaneous vitamin D production by smoking and limited sunlight exposure. Other possible mechanisms include reduced vitamin D production in liver and kidney and increased vitamin D sequestration in adipose tissue. My aims of this study to assess the levels of vitamin D in patients admitted with acute exacerbation of COPD and to correlate the values with severity of the disease. Now to the materials and methods. This study is conducted in the Department of Medicine, Shiksha Medical College Hospital. The study period is study will be conducted among the indoor patients in the Department of Medicine over a period of 1st June 2019 to 31st May 2020. The study design, the present study is a hospital-based observational study. Sample size which includes 100 patients who are attending the IPD and OPD Department of Medicine, Silchar Medical College from 1st June 2019 to 31st May 2020. A detailed clinical history was taken and complete physical examination was done in all cases. Spirometry was performed on all patients along with bronchodilator. Post-bronchodilator efficacy, that is FEV1 by FEV of less than 0.7 or 70% confirm the diagnosis of COPD as per the goal 2019 guidelines. The severity of COPD was assessed using FEV1, force expirative vital capacity 1, that means in the first minute, predicted values. The axis 25 hydroxy vitamin D assay, the vitamin D level, paramagnetic particle immunoassay for the quantitative determination of 25 hydroxy vitamin D levels in human serum using axis 2 Beckman immunoassay systems. The results for which each parameter data are represented. This is the result which is shown in the bar diagram. This is the age distribution. Most common age distribution got is among 56 to 65 years, and second common is 66 to 75 years, and the third one is 46 to 55 years, and the least common age among patients are 36 to 45 years. Now to the goal severity staging of patients, which is shown in this diagram. Among 40% of the patients were in stage 4 goal classification of COPD, that is with very high severity, and 32% patients with stage 3 and 28% patients with stage 2 of goal severity. Now to the mean value of vitamin D levels. The vitamin D levels in cases were 19. The mean vitamin D levels were 19, and in controls it was 24. There was a statistically significant difference of these vitamin D levels because and the cases and control because the P value is less than 5%. Serum vitamin D levels in cases and controls according to classification less than 20 is deficient and insufficiency is from 20 to 29 and from 30 onwards is considered to be sufficient. The above table shows that 64% of COPD cases were vitamin D deficient in comparison to 32% subjects in the control group. Vitamin D deficiency was seen in 25% of the cases and 37% in control insufficiency and was seen in 11% in COPD cases and 31% in control. The final result was also statistically significant. This is the diagram showing distribution of study groups based on the vitamin D levels. The blue showing the cases and the red showing the controls. In vitamin D levels are very low in cases in comparison to the control. This is the vitamin D insufficiency. Now, the comparison to the vitamin D level according to both COPD patients. Among COPD patients group 4, that is with severe COPD, number of patients were high, but the vitamin D levels were very lowest comparing with the other groups. That is only 15. That is 15 is the P value among the severe COPD patients, because 18 in group 3 and 27 in group 2. That is less severe patients have more vitamin D levels. This table shows 28% of COPD patients were in group 2, 32% in group 3 and 40% in group 4. The vitamin D levels were lowest in the group 4, which is the severe group of patients with severe COPD. After the discussion, many similar studies have demonstrated significantly lower serum vitamin D levels in patients with COPD. That is, Janssen said Belgium Indian study observed that the serum vitamin D level was 90 and 24% in control. In 19 it is in cases and 24 were in control. That means the levels are more in control and insufficiency is more in cases. It was observed that 51% of COPD patients were high in vitamin D deficiency as compared to only 30% in the control. That is, vitamin D deficiency is more prominent among COPD patients than in control. Then another study in 2011, the prevalence of vitamin D deficiency was observed in 80% of patients compared to 20% in healthy control group. And also the vitamin D level is more significantly low in COPD patients. And the mean vitamin D levels were significantly lower in COPD patients, which is around 11, and it's around 16 in control group, which also shows that it is low in the serum vitamin D levels were showing very low in COPD.
I think your time is over, Dr. Shijok. You can give your conclusion.
Conclusion, it's concluded that from the present study, the low serum vitamin D is present in 2/3 of the subjects with COPD and more so among patients with severe form of COPD. So this is from the conclusion that deficiency of vitamin D may be a factor in the development and progression of COPD, and hence replacement therapy of vitamin D may be an effective public health intervention to improve vitamin D status in the population. And there are some limitations to my study, which is it is a hospital-based study, which is small sample size. It included only 100 patients and over a limited period of just 1 year. So to gather more detailed information, we need a broader study covering a large number of patients over a long time. And my study did not take into account a few confounding factors like dietary habits or parathyroid hormone levels, which can also influence the vitamin D. So my references.
Sir.
Yeah. What is the cause of low vitamin D in COPD patient? Do you have any idea why it is so?
Sir, so many factors.
Please brief answer only because time is going off.
Yeah, smoking is one of the major factors. This smoking can cause inflammation can release some inflammatory cells can release cytokines, which can damage the
No,
CDL
no, I am not going.
as well as.
Your answer should be very specific. What are the causes? Anyway,
Yeah.
I got your point.
Okay.
One is smoking. Any other questions?
Smoking.
You can go ahead, please.
Any other?
The first thing, my comment is that I could not hear the voice properly. I don't know about the others. The voice was
similar to me.
Voice was, we could not hear.
very much broken. Second thing is your presentation slides, you just read like a textbook. You should have presented like slide presentation. This is not readable to the audience. Everybody has to zoom at the screen. And why these patients with a vitamin D deficiency and how you just correlate with COPD. COPD patients, they prefer to rather sit on the sunlight. And why they should have vitamin D deficiency?
Sir, smoking is the major factor which can cause vitamin D deficiency.
How much you correlated the smoking and COPD in your patients?
This smoking, this smokers, this nicotine can affect the vitamin D receptors in its function.
That is okay.
Normal function.
In your patients and the control population, how many of them were smokers and non-smokers?
All my COPD 100 patients were smokers, and the other control group were not at all smokers. 100 patients in each group, sir.
Age match, age and gender match, and they are not
Age and gender. Yes, sir.
And
yes,
they are
sir.
from
Age
the
and
same.
sex.
Okay, and they are from the same community. And COPD
Yes,
patients are smoker, others are 100% non-smokers. Is it possible?
Non-smokers, sir. Yes, sir.
Maybe there
I
is
took
some
the
selection
history
bias.
from my history, I'm saying, sir.
Now, does it mean that you excluded all smokers in the control group?
Yes, sir. There were
You have
no
excluded.
smokers according to yes, sir. According to my history.
No. Suppose in the control group somebody is smoking. You have not included in your study?
No, sir. In my study, the control group were not at all smokers.
That is not possible. If you have taken 100 patients, all 100 in COPD may be possible because COPD, one of the causing factor is. But out of another 100 control, just listen to me, another 100 control, none of them are smoker. That is not possible. Anyway, but had there been some smoker, it would have been better. When in that case, in Dudbury smoker control and smoker COPD, you could have seen the value of vitamin D. In that case, whether smoking has got any relation or not, that would have been better. I think.
Yes, sir. Yes,
any
sir. That's
other
a limitation of.
Yeah, I just
Any
wanted
other
to tell Dr. Shiji that, you are a postgraduate student. It's a very good topic for a study. It was very good. But the thing is, see, you have to take some effort to make it because there are 3 professors of cardiology in the judging panel. So they deserve that respect also. So this is when you just give a presentation of scrolling down article which has been published, it is not actually good. You should have made more effort. Otherwise, your study is interesting. So, you get my point. No? This is just for your good,
sir.
I'm saying. Thank you.
Okay, sir.
Dr. Amit, is he going to be included in this very group or this is a separate paper?
It's just giving a free paper presentation. So
we should not give any marks for him, no?
Yes. Sir.
Amit, would you like me to mark
Good
you?
afternoon, sir. Good afternoon, sir. I
Good
very much
afternoon.
like to be part of the competition, sir. Farin has forcefully thrown me out, but I still want to participate, sir.
Most welcome.
See, he doesn't want to give you the 10,000 rupees.
No, not at all, sir. It's very important for me. Prize is very important.
Okay, please go ahead.
Thank you. Full screen, please. Thank you very much. Good afternoon, my respected judges and esteemed audience. I'll be presenting today one of the studies which I've conducted in NICRIMS. The title of the study is Clinical Profile and Immediate Outcomes of BMV in Low Gradient Rheumatic Mitral Stenosis. Now, many of you may not be familiar with this term, low gradient rheumatic mitral stenosis. So I'll explain it briefly, then I'll go to the study. Next slide, please. So as we all know that the major hemodynamic abnormality in mitral stenosis is that the left atrial pressure is high and there is a pressure gradient between the left atrium and the left ventricle. And by definition, severe mitral stenosis is defined when the mitral valve area is less than 1.5 centimeter square, PSD is more than 150, and the diastolic pressure gradients are high. Normally, when the mitral valve area is less than 1 centimeter square, the pressure gradient is around 10 or more. So that is the routine cases we see all the time. But there is a very distinct subgroup of severe MMS patients whose diastolic pressure gradient is less than 10, despite having severe mitral stenosis. That means if you do a echocardiography planimetry, the area is less than 1.5, the PHT may be around more than 150, but still the mean gradient across the valve is less than 10. And this distinct subgroup of patients are termed as low gradient mitral stenosis. Next slide, please. Basically, these patients can be divided in two groups. Now, all of us, we know that if mitral stenosis stands for long enough, and it is a burnt out disease, very long standing mitral stenosis can have left ventricular ejection fraction falling down below the normal level. That means they develop left ventricular dysfunction. Once they develop left ventricular dysfunction, they have the diastolic pressure of LV rises up. When the LV EDP is high, obviously the gradients will come down. So these burnt out severe mitral stenosis patients have low diastolic gradient. It is well known. But there is a distinct subgroup of patients who have normal ventricular function, normal cardiac output. Still, the gradients are below 10, and these patients are termed as low gradient MS. Based on this cardiac output and the gradient, they are divided into low flow, low gradient, or normal flow, low gradient. Low flow, low gradient means they have left ventricular dysfunction, elevated LVEDP, and subsequently they have low diastolic pressure gradient. That is, or in a common language, you can say a burnt out, long-standing chronic MS with LV dysfunction. But the second category, where the left ventricle is normal, the cardiac output is normal, still they have low gradient. So we aim, next slide, please. So we aim to study this group, normal flow, low gradient MS. And it is also now known that BMV outcomes in such group of patients is suboptimal as compared to patients whose diastolic gradients are high. Only 2 studies are there available worldwide. In fact, 3 studies which have seen this these subgroup of patient, normal flow, low gradient MS, the results of BMV or MVR, and is consistently poor outcomes as compared to patients who have high gradient. Next slide. So objective was this study was to assess clinical hemodynamic characteristic and immediate outcomes of PBMB in low gradient severe rheumatic mitral stenosis with normal cardiac index. Next slide. We included consecutive patients of severe mitral stenosis who underwent BMV, and finally we could we included 159 patients. Next slide. We excluded patients with CAD, hypertension, exposure to radiation, or multivalvular disease, or the patient whose cardiac index was less than 2.5. Means we included any patient, either clinical or subclinical LV dysfunction, to be sure that these patients really had normal ventricular function. So after exclusion, out of 200, we had 149 patients. Next. So baseline characteristic, out of 149 patient, we found that 34% patient had low gradient MS, while 65% patients had high gradient. That is the normal variety of MS we'll normally see. Low gradient patients, I will just subsequently now say LGMS and HGMS. So LGMS and HGMS baseline characteristics were similar, except that LGMS patients had lower baseline heart rates, they tend to be older, and the usage of beta blocker in patients is lesser. Next. This is the tabular form of what I already said. As you can see, the only significant difference in the baseline is that LGMS patients are older as compared to, almost 5 years older as compared to HGMS. And usage of beta blocker is lesser as compared to HGMS. Next slide. And similarly, other factors are more or less similar, including the clinical presentation and NYHA class. Next slide. Pre-BMV cardiographic findings are very interesting in these patients. Sir, I would exceed my time limit, so I would just request you to grant me 4 or 5 minutes more. So all subjects, if you see the mean gradient, diastolic gradient was around 8 in LGMS as compared to 16, almost double. So their gradients are less. Their valve area is more as compared to HGMS. Although they are all severe MS, but still the basic baseline pre-BMV valve area is higher. as compared to the HGMS, their Wilkins score is higher, means subvalvular disease is more, and they have lesser pulmonary hypertension as compared to HGMS. Next slide. Next slide, please. I've already told this. Next. And once the results of BMB, as I said, BMB was successful in both groups. Its success rate is around 95%, and there is no difference in the success of BMB in these two. But the important point to note is that once you do BMB, the increment in area, percentage increment is area is lesser in LGMS as compared to HGMS. Means if you do BMB, the increase in area will be more in HGMS patients as compared to LGMS. And we'll further discussing the reasons for it. And the fall in gradients and LA pressure immediately after procedure is much less in this low gradient mitral stenosis population as compared to the high gradient population. Next slide, please. Next. Next. The median value of percentage change in mitral valve area is 66 versus 80%. Means if suppose pre mitral valve area is 1, pre-BMB, in an LGMS patient, it will reach 1.6, whereas in HGMS patient, it will reach 1.8. Using, if supposedly you use the same technique, same balloon, everything, the mitral valve area increase is lesser. The mean gradients, LA pressure, PSP, these are significantly improved in HGMS as compared to LGMS, indicating that the response of BMB is lesser in this group of patients. Next slide. This is the slide showing the percentage changes in all these hemodynamic values of LGMS patients. And it is very clear that the response to BMB is lesser in magnitude as compared to HGMS patient. Next slide. This is the overall the overview of the study. As I said, we had chosen LGMS patients with normal cardiac index. The success of BMB is similar, but the change in parameters and the parameters of success are very different in these two groups. Next. So this is the first study of LGMS patients from India. As far as I believe, I could not find any other studies. And next slide. Next slide. Yes. The main reason why we think these patients have low gradient is because they have got extensive subvalvular disease. This extensive subvalvular disease results in somewhat elevated LV-EDP, reducing the gradient between the LA and LV and producing the similar symptoms, whereas they still have valve areas which are comparatively higher, but the symptomatology is similar because of this extensive subvalvular disease. And in the Western world, they have done some studies where they have done extensive hemodynamic studies, and they have found that these patients have the arterial elastance in these LGMS patients is higher, and the ventricular capacitance is and afterload mismatch of this patients is which is called as ventricular vascular uncoupling is more rather than the intrinsic contractile dysfunction, and that is why they are similarly symptomatic despite having little higher valve area and lower gradients. Next slide. So as I said, do these patients really represent a lesser degree of rheumatic MS? We are not very clear. But one thing is very clear, that these patients have subvalvular disease, which leads to the symptoms and decreased response to the BMV. Next slide, please. Next slide. And what is the importance of identifying these subsets of LGMS patient and further categorizing them? Because they constitute a significant proportion of real-world MS patients. They require most intense scrutiny by utilizing newer measures of assessment of ventricular function, so they can be categorized properly, whether they belong to LGMS with normal cardiac output or LGMS with reduced cardiac output. Proper pre-counseling as expected outcome may be relatively poor in long term as compared to HGMS. And besides BMV, depending upon subsequent treatment of LGMS patient might also include standard therapies for heart failure with preserved or reduced ejection fraction, which is normally not needed in HGMS patients. Next slide. Limitations of these studies, that there was a selection bias. We included patients only who are coming from outside referred for BMV. It was not all consecutive patients of severe MS. And we did not calculate some important hemodynamic data like SVR and PVR, which could have given further insights into the hemodynamics of such patients. Next slide. So low gradient MS is with preserved ejection fraction as unique entity and commonly encountered during BMV procedures, but it is frequently ignored or understudied. They have symptoms similar in severity to HGMS, but usually older, lower baseline heart rates, higher baseline MVA, more subvalvular involvement, lesser pulmonary hypertension. This low diastolic pressure gradient is a combination of factors including extensive subvalvular disease, higher effective arterial elastance, reduced ventricular capacitance, and increased chamber stiffness leading to afterload mismatch and ventricular vascular uncoupling. Next slide. And immediate success is similar to HGMS, but the response, the percentage response and fall in LA pressure is much lesser. Next slide. Thank you very much.
Nice. Very nice, Amit. Sir,
Thank you,
kya
sir.
cover?
That's
Sir,
a very
this-
good. I mean, this is a
Yes, sir.
completely new look to the very sets of mitral stenosis having, and percentage wise is quite higher group. So I think you should follow up these very patients for pretty long period
Yes,
of
sir, we are doing, sir.
Yeah.
I'm pleased to inform this paper has been accepted in JAC also, sir.
Yeah, because it is a new concept.
Because yes, but it would have been nice if we had got the LVDP measurement also, no?
Sir, we have got, sir, I did not show the data. I have got LVEDP. LVEDP is significantly higher in LGMS, almost 3 millimeters higher on an average as compared to HGMS patients.
And the second thing you could have done is you could have taken the symptomatic response, na, quality of life of the patient after
Sir,
6
that is
months.
one important limitation. We did not document the NYHA class after BMV.
So that would have made the study more
That would
complete.
have made this study much more better. That was a major limitation of our work, sir.
Secondly, looking into the fact that majority of them do have subvalvular apparatus defect.
Yes, sir.
In retrospect, do you think that, I mean, this is a theoretical discussion only, mitral valve repair would have been better than BMB?
Sir, actually, I think this must come as a some bigger studies. Then maybe BMV is not the answer for these patients, because earlier also what I have gone through, there are only 3 studies available. One with MVR, mitral valve replacement, and two studies where they have done BMV, and they have done follow up also with functional class. And they have shown that these patients fare poorly in long term. Long term means 3 years and 5-year outcomes are much more, and they remain more symptomatic. Means their NYHA class is worse even at the same valve area. So maybe surgery, mitral valve repair, or maybe a better option than doing BMV in such patients. But at present, we don't know because not much data is available.
Yeah, exactly. Since, I mean, we do not expect to have that type of data from West also, but whatever number of rheumatic heart disease with significant subvalvular apparatus defect, the mitral valve repair rather than BMV or mitral valve replacement shown to be better, having better outcome. It was presented around 2 years back in Valentine Fuster's SEC symposium.
Right,
So
sir.
that is not possible many a time in our places because of the paucity of
atrial fibrillation was more. AF was
So
more
we found that AF incidence was similar in both groups, sir.
Because number is changed, because your age group is little bit higher in this.
Sir, our age group is like mean age is around 35 in HGMS, and in LGMS 39. So according to rheumatic patients, the age, they are older rheumatic heart disease patients.
Yeah, because atrial fibrillation in
In the
rheumatic heart
Western,
disease.
actually, when Western data, their mean age is around 50, 55, because most of them, they are degenerative mitral stenosis.
Yeah.
Ours is purely rheumatic. It is younger, but if you see the rheumatic population, these are older patients of rheumatic heart disease, long-standing disease.
What about LA size? LA was larger in which population?
Sir, LA was numerically larger in LGMS, but statistically it did not come out to be significant. But the value numerically was higher in LGMS.
And LA thrombus incidence?
Sir, that data we don't have.
Atrial fibrillation in rheumatic heart disease in our country mostly dependent. One is obviously related to the valve size, but more than that, it is also related to age. Somebody may have 1.5 or more than 1.5 at the age of 40, 50. Now you do get suddenly coming with heart failure and you will file rheumatic heart disease detected on echo, and it is because of atrial fibrillation. So atrial fibrillation, since in your age group atrial fibrillation is higher, expected to have higher because their number is small. So if you follow up more and more patients, probably atrial fibrillation will come up. And atrial fibrillation itself may be a cause factor for LV dysfunctions. Which may not be, I mean, yeah. I think that's all probably. We can, thank you, Amit.
Thank you, Amit. It's a good
It's a
presentation.
new insight, and
Thank you, sir.
yeah, I hope you will carry
Yes,
on this
thank you,
one.
sir. Thank you very much. Thank you. Thank you, sir.
So should we, Neil, should we conclude?
Yeah,
Farin,
so
should
we'll
we conclude
conclude.
this session?
You're already running
Yeah.
late.
Okay, we have concluded this session, and the marks that we have given will by WhatsApp, we'll do the photocopy and we'll send it to the Farin directly.
Yes, sir.
That will be better.
Okay.
We'll compile it and then.
Send it to Farin.
I hope you are not going to manipulate.
No,
You
no,
have to
no,
give,
sir.
you have to give a vote. Okay, thank you. Thank you.
Now we are going to have a very interesting session. That is the quiz, final round quiz. And Dr. Malviya, he is still, I believe he is here. So please go ahead, Dr. Malviya and Dr. Rituparna. Let us start the final round quiz. Yeah.
Ritu, you're here.
Yeah, I'm here.
So let's start. I think you start. I'm here. Have the candidates joined?
Yes, sir. All of them joined.
We have selected 8 candidates for the final rounds.
But I can't see them here.
Sir, all of them joined. Requesting the candidates to please switch on your videos.
Please switch on the videos, candidates. Sangamitra,
Yes,
can
sir.
you hear me? After 30 seconds, the slide should go off by itself. Huh? Next slide should not show. The screen should become blank after 30 seconds. Huh?
Yes, sir.
Then once we tell the answer, you can show again. Then next question you show. The slide should become white or black, whatever, after 30 seconds.
So we can stop sharing.
You stop sharing, then again when the second question comes up, you can start sharing again.
That's it. The slides will be shared by Rituparna, sir.
Okay. So you please, I will tell Ritu.
Should I share my screen?
Dr. Ritu, just a second. Before starting, I was telling, once the 30 seconds are over, you please minimize your screen so that we can see for the answers, and then we can show the second question again later on.
Sure.
And who is marking? Somebody will be marking. No?
So you will be doing the mark.
Dr. Mahesh, sir, kindly switch on your video.
Participants, all are ready?
Dr. Kakoli, please switch on your video. Sir, rules एक बार बोल दीजिएगा. Rules for the quiz.
So the rules are very simple. We will be showing one slide which is displayed. Everybody can hear me?
Yes, sir.
So they will be display one slide at a time, and it will be displayed for 30 seconds. We will say the questions verbally. You will have 30 seconds time to think about it, and it is the first come first serve basis. The one who first answers get the chance to answer. If it is correct, it's okay. Otherwise, we go to the next question. All right.
So we can see 6 participants here.
Okay.
All participants should switch on their video.
I can see only 6.
Yes.
Mahesh
All participants.
Namaskar, should I share my screen for the first question?
Mahesh, that needs to connect to audio.
Dr. Bhavani is not here. Dr. Bhavani was here, but I cannot see him now. Should we wait for him?
So we can start. I think we can start.
Dr. Mahesh is also not here. Okay, sir.
Yes, sir. Start, Mangi.
Yes, yes, you start now. We'll start. Those who have come,
Identify this X-ray and then condition.
PAPVC?
No.
Epstein's anomaly?
No.
So is it right-sided arch of aorta, sir?
No.
Please try. You will try. What would you say?
O1. So you please tell the answer.
Yeah. So before that, should I? So you can try because you can see that the pulmonary gas shadow is on the left side, and the liver shadow on the right side is the situs solidus, and there is dextrocardia. So this is a combination of situs solidus with dextrocardia. Look at the pulmonary. So this is polycytic lung field.
So that is CCTGA. The answer is CCTGA.
Okay.
This is the answer. So we'll go on to the next question. Yes. You ask. Identify this Doppler signal.
Identify the clinical situation where you can get a Doppler signal. The Doppler is taken at the aortic valve level.
HOCM?
Wrong. So should I give a hint? This is normally seen in patients who are in cardiogenic shock.
Pulses alternates.
Who said that?
LV failure.
LV failure. Yeah.
Okay, good. Dr. Altuas. Dr. Altuas, huh? Okay,
sir.
good. You
LV
got,
failure.
you got correct
Yeah,
answer.
LV failure.
Next question, please.
Actually, that hint was pulses alternate.
This is pulses alternate. Right, you are correct. Pulses alternates.
Yeah.
Next.
Where's the slide?
Jordan. That is echocardiographic clip. Please answer.
Vertebral cardiomyopathy.
No, wrong answer.
Left atrial myxoma.
What is
Wrong answer.
wrong answer? What is
Ventricular rupture. Ventricular rupture.
what is this condition? This is pericardial effusion.
Ventricular rupture.
No, wrong answer.
That there is something injected into the pericardial space. There is something injected to the pericardial space to recognize the condition. So this is saline injected into the pericardial space to confirm.
Next. Should I share from here?
Yes, share from your side.
Okay. Is the screen visible now? Is it visible?
Yes, sir.
Yeah, please go ahead.
Okay. Now this is question number 4. Identify what structure is seen and what is the diagnosis. Time starts now.
Is it a coronary artery anomaly, sir?
Who said that?
I said,
Wasim. Okay, you are partially correct, Wasim. I'll give you marks. This is basically an anomalous coronary artery arising from right sinus and crossing the RVUT. You can see here in this first image that this is crossing here, and in the second image you can see that it is crossing just above behind the aortic valve and above the RVUT. This is anomalous coronary RCA arising from right sinus and going behind aorta and above RVUT. So that's a good answer. Now we'll go to the next question. Identify the diagnosis.
mitral stenosis, sir?
No, wrong. Any other? Who's Dr. Ramesh? What you said?
Mitral valve prolapse.
No, wrong. Anyone else? Anyone? I'll give you a hint. This is a congenital condition.
Tricuspid atresia, sir?
Double outer left ventricle.
Wrong.
Look at the number of the capillary muscles.
Tricuspid hypoplasia, sir?
No. Dr. Rituparna has given a big hint. Look at the number of capillary muscles.
Parachute valve, parachute mitral valve.
Yes, yes, very good. Right answer. Go to the next question. Identify the diagnosis.
LV thrombus, sir?
Wrong. Anyone else?
Amyloidosis.
No.
Wrong. Anyone else? Okay, time is up. This is not a
sarcoma.
No, wrong diagnosis. As you can see that the endocardial, beneath the endocardial layer, there is a free mass. This is basically a left ventricular hematoma, intramyocardial hematoma, and the endocardial lining is intact. In the thrombus, LV thrombus, you will not see this lining because thrombus is on endocardium and it is disrupted. This is basically an intramyocardial hematoma in the left ventricle. Now you read this oximetry, see the pressure data and tell the diagnosis. Timer, please.
Is it transposition?
Who said that?
Transposition.
Who said that?
Sir, me.
What is your diagnosis?
Transposition physiologist, sir.
It's partially correct. Can you diagnose more? look at the pressures.
So transposition of great arteries.
No, that is okay. TGA is correct, half correct. Can you expand your diagnosis? Look at pressures in RV and LV. Is there anything you can pick out?
The differences between LV and RV pressure difference.
Pressures in the RV are less than the.
There is significant pressure difference between RV and LV.
Is it sir?
Class position, there is significant pressure difference between LV and RV. I have given you almost the answer.
Something between RV and LV, sir.
So this is restricted BSP
BSP, yes, sir.
Go to the next question now. Please identify the diagnosis.
So, pulmonary RV angiogram suggestive of stenosis at the level of pulmonary valve with post dilatation.
Wrong.
No, this is a PA picture. It can section of the catheter and the central field and that the pulmonary circulation field. So it is only I'm giving a direct view only. The catheter is in the left side of the heart and then filling the pulmonary circulation.
Just now, Dr. Ritu has given you hint. No, the catheter is in left ventricle. And what you can see filling from left ventricle?
Pulmonary artery, sir.
So it happens when?
Total anomalous TAPVC.
No. Who said
TGA, sir. TGA, sir.
Who said TGA?
I said, sir.
TGA, okay. That's the correct answer. TGA. Next slide. This patient was taken up for PMV, right heart catheterization, but it could not be performed because the catheter was not going. Identify the diagnosis. The catheter could not be negotiated. Identify the diagnosis to the right atrium. Identify the diagnosis.
Yeah, I'm giving a clue. So you inject the contrast in the the contrast is directly entered to the RA. It is a long torsus route. So identify the diagnosis.
I suggest that participant, you mute your mics unless you have to speak because a lot of background noise is coming. Please mute unless you have to speak.
So the catheter is in the inferior vena cava and you are injecting contrast. And this contrast should directly go to the RA, but it's not going, it's taking a long tortuous route to fill the cardiac seal out. So identify this condition. Is a rare anomaly.
So that is persistent azygous vein, which is draining into the RA, and there are total occlusion of IVC. Next slide. Identify the procedure. It's a common diagnostic procedure. Just name the procedure being done. Diagnostic procedure.
Try to recognize.
Pulmonary angiogram, sir.
Yes.
Yes, who said it?
Pulmonary angiogram, sir. Me, Wasim, sir.
No, it is not pulmonary angiogram. Please refine your answer.
You are almost near to it.
You are near to it, but not exact. Where is the catheter positioned?
It's in the sir, lower distal to the pulmonary.
Should we give him marks, Ritu?
Yeah, you mentioned pulmonary, but
he has identified half. So we'll give you half marks for that. This is a wedge angiogram.
Okay, sir.
You see the pulmonary artery retrogradely as well as the pulmonary veins in the levo phase. You can see the pulmonary venous drainage in the levo phase. Okay. So this is done to see if there is any PVC or not.
Sir.
Identify the diagnosis. This is very easy one. I think everyone should tell.
So, pigtail catheter placed in the aortic sinus with
elasticification or condition.
sir, anomalous coronary arteries.
No.
See, this is a AP view or PA view, and look at the pigtail catheter where it is sitting, and then you find the answer.
Where is the cardiac apex?
The pigtail is sitting in the
right coronary sinus,
in the aortic sinus, and this is a AP view or PA view, whatever it is. Malvin, go back to the previous question.
Oh, I'm going. This is the answer. It is L post aorta with inverted coronary arteries. Distinct CCTJ. Very simple. Next. Please identify what is the diagnosis. It's a CT angio image. Just a second. We will skip to the next question. I think this one is not. Can you see my images now?
I am sharing it. No, sir. Is it visible now?
Yes, sir.
Is it visible?
Yes.
Yes.
Identify this clinical condition. The CT angio. Okay, anyway, I'll try to help it out. I'll stop this image at a certain point, and then you'll find out again. What is the diagnosis? Bhavya, could you share your screen?
Oh, I'm sharing. Can you see? Can you see now?
No, sir, you have to share the PPT.
It's
You have to share the PPT. Stop share and then share the PPT.
here again. Is it visible?
Okay.
Can you see now?
Yeah, it's visible. We maximize.
Full screen, sir.
Visible now, no?
Yes, yes.
Okay. So we go to the next question then. Please identify what is the diagnosis. Previously, we have shown you one angio, diagnostic angio. It is just a variation of that.
Look, the catheter is in the pulmonary artery, and then you try to recognize the liver phase, what is filling. So this is.
Is it partial?
Yeah, go on.
Sir, the pulmonary vein draining into the IVC in the pulmonary portal circulation?
No. This pulmonary artery, which is contrast injected and then which is the structure in the liver phase. So this is anomalous pulmonary venous connection.
Next. Timer, please.
So let us give some clues. In this particular clip, two main structures are specified. One in the initial injection and the final phase of the injection. So the first is the aorta, and the last one is the.
So, Dr. Ramesh, you are wrong. It's not PDA.
Two structures are specified in the initial phase and the last phase. First is the aorta, last is the pulmonary artery. But why it is delayed? Had it been a case of a PDA, so it would have been very early in the phase of the. I have given almost direct.
Oh, presentation time हुआ नहीं.
I think time is over. Malvir, what is the answer?
You can see you can see once the dye is given up in injected in the aorta fills up, and after a significant delay, the pulmonary arteries are filling. So had it been a PDA, pulmonary artery will fill almost immediately along with aorta because it is very near to the arch. But in this case, there's a long gap, and that gap is because the dye is reaching pulmonary artery from a communication from the carotid artery. You see the first dye is going up, it is reaching the left common carotid artery. From there, one artery is coming down, which is connected to the pulmonary artery. This is a extra cardiac left to right shunt between systemic and pulmonary circulation through common carotid artery. So this is a very, very rare cause of left to right shunt. Patient presented with congestive heart failure with a continuous murmur in the axilla, and the echo was normal. So these are very rare cases. It would have been good if you had picked up. So we'll go to the next question now. This is a patient of tetralogy of Fallot taken up for CAT study. The data for RV and NV are in front of you. Can you comment what is the diagnosis? TOF, I have already told, it's a known patient of TOF. So what is peculiar here?
Almost similar question given earlier. The pressure data. Look at the pressure differences. RV and LV.
No one.
So
this is.
Yeah, tell me.
So basically, this is TOF with restrictive VSD. In TOF, normally there's a big VSD, so RV-LV pressure should be equal. But here there's a difference of around 20-30 millimeter. That is because the VSD is restrictive. So TOF is restrictive VSD. Identify the diagnosis. It's very simple. Very simple.
You should answer it.
Concentrate on PAWP.
They are not giving clues.
Concentrate on wedge pressure. If you don't answer this, it will not qualify for any prizes. It's a clinical condition where patient is very sick.
Try to identify this waist pressure tracing. And these are the canted waves. Recognize the waves. This is a small wave followed by giant waves. And give it clues. Anybody try? Clinical condition, patient presented with pulmonary edema.
Post BMP also you sometimes see this condition.
Severe MR.
Acute severe MR. Who said that? Who said that? Litikesh. Okay, good. Next. But I'll give you only half marks because you almost 3 hints. So this is from Harrison's. What is happening here? Just tell us what is happening. We have already marked the point where you have to concentrate.
So this is dip and plateau pattern, sir?
No.
Concentrate here, this part. What is happening here?
Huh? Yes? Who said that? Answer is based on what you are saying. Based on what finding you see?
Inverse root sign.
No, it's not inverse.
Equalization of pressures, diastolic pressures.
Who said that? Wasim. Okay,
Yes, sir.
I'll give you half marks for that. It is equalization of pressures, but it is not constrictive pericarditis because all chambers are not equal. In constrictive pericarditis, diastolic pressure of all chambers will be equalized. Here only left ventricular and right ventricular diastolic pressures are same. So this is acute aortic regurgitation, but still you get half marks. Identify the diagnosis. Quick, there is no hint for this. If you don't identify this, and it's not good. It's very, very common. Every week you might see, every 3-4 weeks, patients of this condition.
Ventricular tachycardia. Acute, is it acute hyperkalemia?
Who said that?
Vaseem, sir. Dr. Vaseem.
Correct. Correct. Good answer. It's sign wave pattern, severe hyperkalemia. So this question we will skip, Ritu. This will be, I think,
Very tough one. So
tough one. But I'll just show them. See, there are bulges on the right and left side. You can see. So you can say that this is cardiomegaly. But you should always remember that the heart is a moving structure. So cardiac borders are never practically, very sharp margins. They are always hazy margins. But here you see that margins are very sharp on the right side as well as on the left side. See here, very sharp margins. Very sharp margins, whereas this is border hazy. Normally, cardiac chill out, it's hazy because it's a moving structure. So on X-ray, if it is sharp, means these structures are not moving relative to the cardiac motion. So these masses are basically these aneurysms, which are not moving much with the cardiac cycle, and that is why sharp shadow is seen. This is the left aneurysm, this is the right aneurysm. Anyway, we have now skipped this question. Identify this CT image.
there is something very unusual in the inferior.
The arrow is marked, red arrow you can see here. What is this structure? What is this? This is a cardiac CT.
Clot in the pericardium.
No, wrong. Why a clot should have such hypodense, irregular this thing? Long, such a long.
Diaphragmatic.
Yes, yes.
Hernia.
Who said that?
Diaphragmatic hernia, sir.
It could be
Hernia of what?
Of what structure?
What is the structure? What has herniated?
Looks like intestine has come into the mediastinum,
Yes,
sir.
yes, yes. Good, very good, very good. It's a bowel loop herniation in the pericardium. Good, very good. So we are done now.
Now,
We will be sending you the.
Can you go back to the CT angio? That is very interesting one.
Okay, okay, okay. CT is not being from my, I don't know, it's getting off suddenly. Can you see?
Yeah. You're seeing it. You just maximize it.
Oh yes. More fun, more common.
So this one was RCA to RV fistula with calcification.
Malka, can you stop when the left coronary artery originates from the aorta? And then that.
Tell me where to stop. Here?
No. Please run. Go back, go back, go back, go back, go back, go back. Yes, just one frame. Go back. Yeah, just stop it here. Just stop it. No, go forward. 2 frames. Yeah, just hold it. So here you can see that on the left side there is left coronary artery originates, and from the anterior there is a big coronary cameral fistula. From the right coronary artery, there is a fistula that draining to the right ventricle. So this is one of the rare anomalies, but this is very interesting case.
We will announce the result now, Ritu, or later?
I think later we just try to summarize some of these scores and then we'll find out.
So I have scored here. I will send you the scores, huh, Ritu?
Yeah, sure.
Okay. Thank you, everyone.
Thank you, sir.
Thank you, sir.
Ritu, I'm sending you or on your WhatsApp, huh?
Sure.
Okay, bye.
Oi, Rakesh.
So, Amit, is it over or like you like? Dr. Amit, Dr. Ritu Porno?
Yes.
Sorry. Over or yes?
Over. We are making the result.
Okay. Thank you, Dr. Ritu Porno and Dr. Amit.
Thank you, Varun. Thank you. We have the results. Dr. Ritu will announce the results according to the protocol. Thank you very much. Ritu, you got the results?
Yes, Malvia, I got the result. So, Farid, should we announce the winners?
Yes, please go ahead, Dr.
हेलो, सुनाई दे रहा है आप लोग को?
Yes, sir, we
Hello?
can hear you. Yes, sir, we can hear you.
After completion of the final round, we have selected 3 winners, and maximum score was done by Wasim, and it was followed by L2s, and the third one is the Liticus. So congratulations all these winners from the CSI update. Farid, over to you.
Bhasati.
Yes, Dr. Ritu Porno. Thank you. Congratulations to all the winners. The winners are requested to contact us for transfer of the money and funds. Can you hear me? Mitra, can you mute everybody?
Meeting or mattu hai na.
Yeah. Thank you, Dr. Ritu Porno. So the first winner is Dr. Wasim Faruqi, the second is Dr. Altos, and the third is Dr. Liticus, right? So all the winners, congratulations, and you are requested to contact us directly. We'll be transferring the amount to your account, and at the same time, we'll be sending you the certificate for your email. So you're requested to contact us. Thank you once again, Dr. Malviya and Dr. Rituparna for conducting the session wonderfully. And they have really worked hard to make this quiz an interesting topic. And I believe that everybody has learned from their subsets of questions. And it was a wonderful session. Thank you. Now we would like to move ahead with our next session on heart failure. I would request our moderator, Dr. Neil Bordloy, to conduct this session. He needs no introduction. He's the face of the Northeastern region in cardiology. He's the managing director and HOD of Department of Cardiology, Excel Care Hospital. And he's the president of Northeast Cardiology Society of India, Northeast Sector. So I request Dr. Neil Bordloy to conduct this session, please. Thank you.
Thank you, Dr. Farin. And after the great quiz contest, we are coming to the very important session, the heart failure session. And the chairpersons are all of them here. Madhuvira Baido Asenegi, Professor MP Das, Manohar. Is Dr. Manohar there?
Yes, sir. Good evening.
Oh, good evening. And Dr. N.K. Bhattacharya, Dada Ase?
Yes.
Dada Ase apni? I think Professor MP Das, she will join us in due course. Farin, you can ask, you can make a few calls and ask them to join.
Yes, yes, definitely.
I think we'll not waste time. I'm handing over the session to our chairpersons who are present, Manohar and I think Nirmalda also there. So I hand over the session to you to introduce the first speaker and the talk.
Yeah, can I get the slides, sir? Yeah. Good evening, everyone. And first presenter is Dr. Pranab Dekka. He is a senior interventional cardiologist. He has done his DM from AIMS, New Delhi. Presently, he is working as consultant interventional cardiologist in Narayana Super Specialty Hospital, Guwahati. With this, I welcome Dr. Pranab Dekka. Please deliver your lecture. Thank you.
May I also add that he's a extremely courageous and brave person also. Pranab?
Pranab, you unmute yourself.
Yeah.
Yeah, Pranab, you
Now
can
it is
start.
audible. Am I audible, Manohar?
Yeah,
Yes,
you're audible.
yes.
Okay. Then Neil, I'm here. Neil. Hello, Neil. Hello.
Nirmalda?
Yeah, I'm here. My video is giving little problem, but I'm here.
Yeah, no, I told you, Makalu Nirmalda assembly. Welcome, Nirmalda.
Okay, thank you.
So, Pranab, you can start your presentation. Unmute yourself. Unmute yourself.
Yeah.
Yeah. So you can do a share screening and start.
Okay. Thank you, Nilda, Manohar.
Pranab, talk is 12 minutes with this discussion, 3 minutes discussion.
Okay.
So you can just say next. I'll go through the presentation.
Am I audible?
Yes,
Hello?
your
Yeah, you're
slides
audible.
are also visible. Please go ahead, Pranab.
Oh.
So you just need to say next.
So we have a talk today on contemporary management of chronic heart failure. Today I'll briefly discuss this topic. First, let's have a look at the epidemiology of the chronic heart failure. As per clinical criteria, the prevalence of chronic heart failure is 1 to 2% all over the world. And males are more affected than females. And in 65 years above patient, the prevalence is 7%. And 50% of patients with left ventricular systolic dysfunction is asymptomatic. And heart failure with preserved ejection factor varies from 15 to 50%. And the incidence rate is 0.2 to 0.3%. And it increases with age. Now, around 62 million adults worldwide are estimated to living with a heart failure, and this number is expected to rise because of the increasing aging population, increased prevalence of various risk factors like diabetes, hypertension, and improve post-MI survival because of better management of acute coronary syndrome and STEMIs. Now, let's have a look at the natural history of this chronic heart failure. First, we start with a normal heart on the left side. After initial myocardial injury occurs, it may be SCS, it may be STEMI, then a patient may remain asymptomatic throughout. And after a few months or the undefined period, the patient may develop acute decompensation of heart failure. Then patient himself may forget the acute event when he had suffered the event. And that event may be with pulmonary edema requiring emergency admission and ICU care. And usually patient survive that first decompensation of heart failure, and subsequently he remains stable on medical therapy. But after a few months or varied period, he again suffered a decompensation as shown in a deep, as shown it is a deep here. So again he recovered with treatment. Then again he may suffer. Now each decompensation is associated with a residual damage to the heart. So there is a progressive development of the symptoms or progressive pump failure occurs with each decompensation. So, and with this recurrent decompensation, patient may finally develop end-stage heart failure and death after a few years. Now coming to the classification of heart failure, in ESC heart failure guideline of 2016, the heart failure has been divided into 3 groups. There is heart failure with preserved ejection fraction, heart failure with mid-range ejection fraction, and heart failure reduced ejection fraction. So heart failure reduced ejection fraction is defined by LVEF of less than 40% and with or without symptoms, and heart failure with mid-range ejection fraction is defined as EF of 40 to 49%. And heart failure of preserved ejection fraction is EF of around 50% with elevated level of natriuretic peptide and other clinical sign and symptoms. But subsequently, it has been reviewed, and this mid-range ejection fraction has been defined as mildly reduced ejection fraction. Heart failure with mildly emerging data, patient with heart failure ejection fraction in the mid-range between reduced and presumed, that is 41 to 50% may benefit from neurohormonal blanket like those with a lower ejection fraction. These are important differences based on patient sex, with women and with heart failure benefiting from neurohormonal blockade at higher ejection fraction than men. Recent data support defining heart failure with reduced ejection fraction as less than 40%, mildly reduced ejection fraction, and normal if ejection fraction is more than 55% for men and more than 60% for women. This is published in JAC, recently published. So prevalence, I have already covered this. So chronic heart failure is basically a devastating burden because despite the introduction of the treatment, the mortality rate for patients with chronic heart failure is about 50% at 5 years post-diagnosis. Now recently, there is a position statement has been published in European Journal of Heart Failure regarding the patient profiling in heart failure for tailoring the medical therapy. This is basically a consensus document which is followed by the ESC guideline of 2021. As per this consensus panel, it has been noted that despite guideline recommendation and available evidence, implementation of the treatment in heart failure is poor, and majority of patients are not prescribed drugs at target doses that have been proven to positively impact morbidity and mortality. Among others, tolerability issues related to low BP, heart rate, impaired renal function, or hyperkalemia are responsible. CKD plays an important role as it affects up to 50% of patients with heart failure. Also, dynamic changes in the eGFR may occur during the course of heart failure, resulting in an inappropriate dose reduction or even discontinuation of the decongestive or neurohumoral modulating therapy in clinical practice. So, as patients with heart failure are very rarely naive to pharmacological therapies, the challenge is to adequately prioritize or select the most appropriate up titration schedule according to the patient profile. The consensus document identified 9 patient profiles that may be relevant for treatment implementation in heart failure patients with a reduced ejection fraction. This profile take into account the heart rate, it may be less than 60 or more than 70, the presence of atrial fibrillation, symptomatic low BP, eGFR of less than 30 or more than 30 per square body surface area, or hyperkalemia. The pre-discharge patient frequently still congestive also addressed. Now, personalized approach according to the patient profile, adjusting the guideline directed medical therapy to the patient profile may allow to achieve a better and more comprehensive therapy for each individual patient.
Sir, I am presenting your presentation, not at your end. You need to follow the Zoom and tell me next.
Oh.
Right
Oh,
now, I'm on patient profiling in heart failure.
okay, that is our next slide. The core of heart failure treatment should be started in all patients with heart failure. So that is the core is at the center. This is dark level shown that SGLT inhibitors, beta blocker, SC inhibitor or ARB or ARNI or MRA or diuretic must be given in all patients with heart failure. Apart from that, depending on the heart rate, other therapy need to be added or discontinued. Depending on the heart rate, then BP, as well as presence or absence of atrial fibrillation, presence or absence of CKD, hyperkalemia, or presence or absence of congestion. Next slide, please. Now coming to the tailoring of medical, according to some patient characteristic, like BP, heart rate, as I already told, some drugs may be reduced or some they may be discontinued or added. The black drug that is at the center of this diagram, this drug has to be given to all patients, and red drugs that should be reduced or discontinued. Blue drug that should be added according to physical condition. Now this slide shows a common comorbidity seen in heart failure patient and impact on the use of guideline directed medical therapy. Like comorbidity like coronary artery disease, if the patient have a CAD and angina, then beta blockers and evaporating therapy may help in control symptoms of CAD as well as in heart failure symptoms. Then next, diabetes. If patient is diabetic, then GDMT has to be started, has shown similar benefit in the diabetic patient. Suppose patient have a chronic obstructive lung disease or asthma, then it may be a relative contraindication to the beta blocker. Starting with low doses of cardioselective beta blocker may allow easy use. And beta blocker should be given in patient with COPD and heart failure. Then next, coming to the comorbidity is depression. GDMT must be started in patient with depression, but depression is associated with low adherence to the medication, so compliance reduces if depression is present. Suppose if the patient have a erectile dysfunction, then thiazide, spironolactone, and beta blockers may aggravate the erectile dysfunction. But in this regard, nebivolol is quite helpful, and this may reduce the erectile dysfunction. So in this condition, nebivolol is preferred if the patient have a erectile dysfunction. Suppose patient have a iron deficiency.
Sorry to intervene, please. Your slides are not telling with your presentation. Can you share your slide from your end, one of that? You share your slide because your presentation is not telling with the whatever they are showing. So please share from your side.
Okay, okay, sorry for this.
That's okay, one of that. Please share yours.
Share screen is not coming here. Actually,
can somebody help him to share his screen?
So there will be a green button on Zoom.
Green button on Zoom, okay. Yeah. I got it. Yes. 1 second. I'm very
share
sorry.
screen to nobody open that.
Yeah. I have pressed the share screen.
Then you have to select the presentation.
Yeah. Now it is coming?
Yes.
Yeah, good.
Yes, good.
Okay,
Good to
thank
go.
you.
Please go.
This is the comorbidity slide with heart failure. Next, coming to the iron deficiency, anemia, and chronic kidney dysfunction. So, SC inhibitor, ARB, or ARNI, MRA may have some limitation in use in patient with CKD or anemia. So, diuretics may need higher doses to be effective. If the patient have a cardiac cachexia, then SC inhibitor, ARB, ARNI should be uptitrated carefully because of the orthostatic hypotension frequently seen in patient with heart failure with cachexia. Now, this is trials. This is a very congested slide actually showing various trials starting from VHAP to the galactic heart failure. Next, coming to the management of heart failure, reduce ejection fraction. So, to reduce mortality for all patients with heart failure, we need to give SC inhibitor or ARNI, then beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitors. To reduce heart failure hospitalization or mortality for selected patient, and in volume overloaded patient, diuretic need to be added. Apart from that, sinus rhythm with LVV, then more than 150 millisecond, then we need to consider for CRT or ICD, CRTP or CRTD or ICD. And there is another presentation for device therapy, so I'll not cover this. Going to the next slide. Now coming with the Emperor reduced heart trial, SGL2 inhibition with empagliflozin is effective in heart failure with reduced ejection fraction with or without diabetes. So primary endpoint was significantly reduced by 25%, and p-value is highly significant. And first secondary endpoint also reduced by 30%. Now next coming to the Vericiguat, is a newer drug, and a Victoria trial has been recently published in NEJM with over 5,000 patients with reduced heart failure with NYHA class 2 to 4. With after worsening event, it has been added with recent heart failure decompensation. So it has been shown that Vericiguat reduces the recent heart failure, hospitalization, and cardiovascular death. And the annual number needed to reduce this CV death or fast hospitalization is 24. Now coming there to the next drug, that is omecamtiv mecarbil. This is recently, this trial, this is Galactic Heart Failure trial, is presented in SCC 2021, and this trial has been conducted in over 8,000 patients, and it is basically a myosin activator. It has been shown that this drug increases the cardiac contractility, and by doing so, it reduces the composite risk of fast heart failure or cardiovascular death in patients with heart failure. The effect is especially seen in patients with ejection fraction of less than 28%. Next, coming to the, let's have a look at the guideline. Now, diuretics are recommended in patients with congestion and heart failure with mid-range ejection fraction in order to alleviate symptoms and signs. As far as 2016 guideline for patients with non-valvular AF eligible for anticoagulation based on set to VAS score, NOACs, radar and warfarin should be considered for anticoagulation as NOACs as per 2016 guideline. But according to recent 2021 guidelines, these NOACs are recommended in preference to vitamin K antagonists in patients with heart failure, except in those with moderate or severe mitral stenosis or mechanical prosthetic valves. So NOACs are recommended over VKs nowadays. So with this, I would like to thank you for patient hearing. Thank you for patient hearing. And this is the brief presentation of chronic heart failure. Thank you for giving me a chance to present this. Hello, am I audible?
Yeah, thank you, Pranabda, for your beautiful presentation.
Okay, thank you, Manohar.
If Nilda, you would like to ask any question, or we'll go to next presentation?
I think Madhumita Baidu is here if she wants to say something, and she can introduce the next speaker. Madhumita Baidu is here, I think. Baidu?
Good evening, ma'am. Welcome to our Cardiology Society.
Baidu is being extra shy. She's not.
Hello, Neil. Hello, Neil. Neil, can you hear me? This is Sangeet Datta.
Oh, Sangeet Da.
Yes.
Good evening. Good evening.
Good evening. Tell me something.
Good evening. Manohar here.
Yes. Tell me something. Why aren't you giving DOACs for those who have mitral stenosis?
DOACs?
Yes.
Not. As per trial criteria, sir. As per trial criteria, this has been not included in rheumatic, moderate to severe mitral stenosis, and even in prosthetic heart valve also, this has not been found to reduce the cardiovascular event. Like in Devigator has been tried in patient with prosthetic heart valve. So there is no significant reduction in the events. There is thrombotic event with NOACs. That's why it is usually not recommended in moderate to severe mitral stenosis or in patient with prosthetic heart valves. In prosthetic heart valve, it is still vitamin K antagonist is considered as ideal for reducing the thrombotic event.
And severe mitral stenosis also, you are using this VKA?
Yes,
As he
yes,
said,
sir.
the trials actually they don't recommend giving in prosthetic valve and in severe, probably because the chances of thrombus and thromboembolism are very high in these, and when you increase the dose of NOACs to combat that, there is a risk of bleeding. So that is why they are not recommended.
But warfarin also will have, I mean, say the other anticoagulants also will have risk of bleeding.
No, but the NOAC, the dose at which the NOACs are given for the other conditions, they do not have
Usually
that high.
non-valvular, sir, the bleeding risk are quite low. It has been shown in the trials. That's why.
Or is it that you can monitor better with this VKA and you cannot, there's no monitoring for NOACs? That's the problem?
Oh, no, that is not the problem.
That is not the thing, sir. That's
That is
because
the
of
advantage actually with NOACs. You don't need to go on monitoring.
So then you don't know if it is you're overshooting, no?
Sangeeta, that's a different. This is a heart failure
monitoring.
session. Sangeeta,
Okay, fine. Carry on. No.
Yeah.
Go on to the next session.
Can I answer this, sir?
Yeah, sure.
So actually, NOAC
You're already
is,
going behind time actually.
only depend upon the etiology of the condition. See, rheumatic heart disease and this severely mitral stenosis, the etiology is different. So in presence of continuous inflammatory process, so you cannot give the NOAC in inflammatory processes. So because of that, NOAC is not recommended in, even in prosthetic valve as well as where the continuous inflammation and deformity is there. It is only for the non-valvular fibrillation, atrial
Okay, I
fibrillation.
think whenever we are going behind time, so let us stick to the agenda.
Please go ahead.
I request Nirmalda to then introduce the next speaker and the topic. Nirmalda. Nirmalda, please unmute yourself.
Okay, am I audible now?
Yeah.
Now, I think next topic is heart failure with preserved ejection fraction. It will be presented by Dr. Chandan Mudok. He is a very renowned cardiologist, budding cardiologist, energetic cardiologist, and we definitely will be getting input from him, who will help us in this.
Thank you, sir. Thank you so much.
Are you feeling well? You are as of now you are suffering from COVID, and yet you have agreed to give the talk. Thank you so much.
But today my antigen test came negative. So can I go to Novotel now?
But no, you are not welcome.
Okay, continue.
Am I audible? Hello?
You are audible.
Yes. And my slides are visible?
Yeah, it's visible. Please go ahead.
Good evening, respected seniors, my dear colleagues. First of all, I thank Northeast CSI and all the organizing committee members for giving me the opportunity to present this topic in front of you all. My topic is heart failure with preserved ejection fraction, its diagnosis and management. As we all know that heart failure is a complex clinical syndrome that results from structural and functional impairment of either left ventricular filling or ejection of blood. So although similar clinically, the heart failure with preserved EF is different from reduced ejection fraction in several ways. For example, most of the patients are elderly, 85% of the patients are hypertensive, and female population is more common in this group. And also the structural abnormality like concentric remodeling of left ventricle is more common in preserved ejection fraction. But the coronary artery disease are more commonly seen in heart failure with reduced ejection fraction. Also, the therapies which have been proven mortality and morbidity benefit in randomized control trials has failed to show benefit in patients with heart failure with preserved ejection fraction. So this is a large area of unmet need, and it affects about 5% of the general population aged more than 60 years, and it also accounts for more than 50% of the hospitalization for heart failure. Also, the randomized control trials have shown that the mortality of heart failure with preserved ejection fraction is lower than those of reduced ejection fraction. But the epidemiology studies have shown that heart failure with preserved EF have got a devastating 5-year mortality of approximately 60% and costly morbidity in terms of 6 months hospitalization rate of about 50%. Coming to basic pathophysiology, basically diastolic dysfunction is the main cause of heart failure in heart failure with preserved ejection fraction. And the underlying mechanism is mainly left ventricular relaxation abnormality. Then there is increased stiffness of the left ventricle. So there is reduced compliance of the left ventricle. There is a structural remodeling and altered geometry of the left atrium and left ventricle. Changes in the compliance in left ventricle, systemic, pulmonary vascular system. Then skeletal muscle and endothelial dysfunction is there. And all these things are thought to be primarily occur due to some of the pro-inflammatory and pro-fibrotic cytokines released by all the antecedent and comorbid diseases which are very common in patients with heart failure and preserved ejection fraction. For example, hypertension, diabetes mellitus, insulin resistance, overweight, obesity, coronary artery disease, hyperlipidemia, aging, anemia, and CKD. These all lead to increased hemodynamic load and metabolic load, which in turn increases the sympathetic activation, and there is parasympathetic withdrawal, which again lead to renin, angiotensin, aldosterone system activation and release of interleukin 1, 6, TNF alpha, soluble ST2, then pentraxin 3, galectin 3, and TIMP1. These mediators increases the circulating hematopoietic progenitor cell, and also it affects the reactive oxygen species and leads to endothelial dysfunction because of reduced nitric oxide synthesis. Again, this leads to lower amount of soluble gonal cyclase. So there is reduced cyclic GMP and protein kinase Z activities lowered. That leads to abnormality of the titin phosphorylation and cardiomyocyte dysfunction due to abnormality of the various ion channels. There is calcium handling, and the titin isoform change from less compliant isoform, that is N2B isoform of titin. And also in the extracellular matrix, there is changes in the hemostasis. So there is more formation of fibrillar collagen, which is more stiff. So due to activation of the transformic growth factor beta, which converts fibroblast to myofibroblast, and then formation of collagen. So all these factors of changes in extracellular matrix and cardiomyocyte dysfunction leads to diastolic dysfunction. So coming to some of the secondary causes or the heart failure with preserved ejection fraction mimics, we all know that hypertrophic cardiomyopathy, restrictive cardiomyopathy, valvular heart disease, constrictive pericarditis, high output heart failure, and some other conditions like ischemic cardiomyopathy or myocarditis may lead to clinical pictures similar to heart failure with preserved ejection fraction. Now let us go to the diagnostic process. Recently, in the August 2021, ESC guideline has laid down very simple diagnostic approach that starts with a clinical assessment of pretest probability. First, take the sign and symptoms of heart failure. If they are present, then we should look for the ejection fraction. If ejection fraction is more than or equal to 50%, then we should look for the objective evidence of cardiac structure or functional abnormality which are consistent with patients with LV diastolic dysfunction, raised LV filling pressure, including raised natriuretic peptide. And stress testing and invasive measurement of elevated LA and LV pressure are needed only in cases where there is uncertainty. So these are the measures and cutoff points described by European Society of Cardiology. We will be discussing in the diagnostic criteria. So diagnostic workup starts with clinical assessment followed by ECG to look for atrial fibrillation, left ventricular hypertrophy, standard echocardiography to look for the ejection fraction and exclude significant valvopathies. Then two scoring system is there. One is Heart Failure Association PEFF score, and another is H2 FPEF score. H2 FPEF score is a very simplified score. H2 stands for heavy, that means BMI more than 30 kg per meter square, that carries 2 points. Hypertension requiring more than or equal to 2 drugs carries 1 point. F stands for atrial fibrillation, which carries 3 points. That may be paroxysmal or persistent atrial fibrillation. P carries pulmonary hypertension, that means pulmonary artery systolic pressure more than 35 millimeter of mercury on echo carries 1 point. Then elderly means age more than 60 years, 1 point. And F for filling pressure means E by E dash ratio on tissue Doppler imaging more than 9 carries 1 point. Similarly, Heart Failure Association of ESC has provided one scoring system. One is the comprehensive echocardiography that has got two domains, functional domain and morphologic domain. Functional domain contains minor criteria, that means 1 point for average E by E dash ratio if it is more than 9 and less than 14, and global longitudinal shortening if it is less than 16%. Similarly, if E by E dash ratio is more than 15, or E in the septal, that is septal E dash less than 7 centimeter per second, or lateral E dash less than 10 centimeter per second, and average E by E dash more than 15, TR peak velocity more than 2.8 meter per second, and pulmonary artery systolic pressure more than 35, then this becomes major criteria and it carries 2 points. Similarly, anti-pro-BNP criteria, major criteria is 2 points if anti-pro-BNP is more than 220 for sinus rhythm patients and more than 660 for atrial fibrillation, BNP more than 80 and 240 for sinus rhythm and atrial fibrillation respectively. And minor criteria is anti-pro-BNP 125 to 220 and 375 to 660, BNP 35 to 80 and 105 to 240. So heart failure with preserved ejection fraction probability can be assessed by these two type of scoring system. If the score is from 2 to 5 in H2P, H2FPEF score, then it is intermediate probability, and in HFA PEFF score, if it is 2 to 4, then it is intermediate. So if the score is more than 5, more than or equal to 5, then it is high probability of, and the heart failure or preserved ejection fraction diagnosis is confirmed. If the score is less than or equal to 1, then the heart failure with preserved ejection fraction is excluded. And for those intermediate probability patients, we need advanced workup of non-invasive stress testing. If with exercise the E by E dash value is more than 15 or TR velocity increases to more than 2.4, or in then it is a diagnostic. Or if invasively we can see the left ventricular endospheric pressure of more than 16 or pulmonary capillary pressure of more than 15, and with exercise if it is more than 25, then the diagnosis is confirmed. After confirmation of the diagnosis, if we suspect some secondary heart failure, secondary causes, we should advise some more investigations like cardiac MRI, cardiac biopsy, CT scan, etc. So coming to management, none of the large randomized control trials conducted so far has achieved their primary endpoint. These include PEP-CSF for pain-endopial, charm preserve for candesartan, I-preserve for irbesartan, TopCat for spironolactone, DIC-preserve for digoxin, and Paragon-ASAP trials sacubitril valsartan. Although hospitalization for heart failure was reduced by candesartan and spironolactone, but as the studies could not achieve primary endpoints, so these are only hypothesis generating findings only. Although nebivolol significantly reduced combined primary endpoint of all-cause mortality or cardiovascular hospital admission in seniors trial, this trial included only 15% with heart failure with ejection fraction more than 50%. Trials targeting the nitric oxide cyclic guanosine monophosphate pathway have also failed to improve exercise capacity, quality of life in this group of patients. For example, NEAT HFPEF for isosorbate mononitrate. Then inhaled organic nitrate was used by INDI HFPEF. Then Virisiguat was used by Vitality HFPEF, and capacity heart failure preserve used Praliciguat. So all these trials failed. So even FDA has approved sacubitril valsartan and spironolactone in those patients with LVF less than normal. That means for patients of mildly reduced EF or PSAP ejection fraction patients, because this is based on the subgroup analysis from Paragon SF study, which showed a reduction in heart failure hospitalization in those with EF less than 57%, and also meta-analysis of Paradigm heart failure and Paragon SF studies showing reduction of CV death and hospitalization in those patients with EF below normal range. Regarding spironolactone, the subgroup of individuals in the TopCat study recruited from America showed significant reduction in primary endpoint of CV death and hospitalization, and subsequent post-hoc analysis also showed that EF showed that significant reduction in outcome in those with EF less than 55%. So coming to this is the latest trial published in 27th August in NEJM. This is the Emperor PSAP trial. They have the total number of patients enrolled were 5,988. They randomized in a 1:1 fashion to either empagliflozin 10 mg or missing placebo. And the trial was stratified according to the geographic area, diabetes status, eGFR, and LV ejection fraction of either less than 50 or more than 50%. Duration of follow-up was 26.2 months median. Mean age of the patient was 72 years and 45% were female. Inclusion criteria was all the adults more than 18 years with chronic heart failure, NYC class 2 or more. PSAP ejection fraction was defined as more than 40%. Then anti-proBNP more than 300 and 900 in sinus or AF respectively. Structural heart disease confirmed within 6 months, or that is documented heart failure hospitalization within 12 months, and stable doses of diuretic if they are on diuretic. And the patients with acute coronary syndrome, stroke, transient ischemic attack within 90 days, then listed for heart transplantation or heart transplantation recipient, acute decompensated heart failure, systolic BP more than 180 or less than 100, liver or kidney disease, eGFR less than 20, and current or prior use of sodium glucose co-transporter, that is empagliflozin or other gliflozin, were excluded from the trial. And in the most of the patients had mean LVEF was 54.3%, and 51% had atrial fibrillation, and 49% had type 2 diabetes mellitus. So coming to the result, the primary outcome, that is a composite of cardiovascular death or heart failure hospitalization, was significantly reduced in the Emperor PSAP trial. So there is significant reduction of heart failure hospitalization. It was seen in 8.6% in empagliflozin group versus 11.8% in placebo, and significant reduction of heart failure hospitalization and cardiovascular death. But the cardiovascular death alone was not significantly reduced. And regarding the secondary outcome of the hospitalization, total hospitalization was reduced, and changed in mean eGFR slope per year was reduced significantly. But composite of renal outcome, all-cause mortality, new onset diabetes mellitus showed no difference between the two groups. So SGLT2 inhibition with empagliflozin led to a 21% relative risk reduction in composite of cardiovascular death or hospitalization or heart failure, which is mainly related to 29% lower risk of hospitalization for heart failure with empagliflozin. In contrast with findings in earlier trials of candesartan, spironolactone, and sacubitril valsartan, the results favored empagliflozin with hazard ratio less than 1 for primary outcome in each of the ejection fraction subgroup. The benefit was consistent across pre-specified ejection fraction subgroups and was seen in patients with or without diabetes, among patients with symptomatically stable heart failure with EF more than 40%. The benefit is primarily driven by the reduction in hospitalization only, not mortality. There was also a benefit in eGFR, but not in renal outcome per se. So to summarize, the empagliflozin is the first and only therapy achieving primary endpoint in randomized control trial. In the absence of recommendation regarding the disease-modifying therapies, treatment should be aimed at reducing symptoms of peripheral and pulmonary venous congestion with fluid and sodium restriction to less than 2 grams per day, and judicious use of diuretics. Tube diuretics are preferred, although thiazide diuretics can be used as a part of management of hypertension. And non-pharmacological intervention, for example, reducing body weight in obese patients, lifestyle intervention and increasing exercise may further improve the symptoms and exercise capacity, and should there be considered inappropriate patients. It is important to identify and treat antecedent comorbid disease and underlying etiology, because most of the patients are hypertensive, diabetic, obese. They may have atrial fibrillation and coronary artery disease. So we should manage accordingly. So to conclude, although heart failure with preserved ejection fraction pathophysiological mechanism are becoming clearer over the years, there is still no effective treatment showing clear mortality benefit. Numerous trials are underway for future successful therapies. We should not forget the importance of preventive strategies and to aggressively address associated comorbidities. To finish with the words of Samuel Beckett, ever tried, ever failed, no matter, try again, fail better. Thank you.
Thank you, Chandan, for sticking to the time, and also thank you for giving us the emperor preserved findings also. The only medicine which has been actually shown to have some benefit in this condition. So we are short of time, so if the chairpersons want to say one or two remarks, it's okay. Otherwise, we'll go off to the next presentation. Request Madhumita Baido to come in, please. Madhumita Baido, you're muted.
I'm sorry, I had some technical hitches. I joined in late. Yes, it's been a very enlightening talk, and I'm sure everyone has been benefited out of what you spoke. And I don't really have any questions. Maybe we can go on to the next subject.
Thank you.
Baido, you can introduce the next topic and the speaker, Dr. Indra Kuladipati.
Okay, Indra Kuladipati, I'm sure doesn't need much of an introduction to this audience. He is a renowned cardiologist, now practicing in, he's a consultant cardiologist now with Downtown Hospital. And he is well known in the field of cardiology to people in Assam and all over the northeastern states. And over to him for the next subject.
Yeah, thank you, Baido. Probably I'll share my slides. The technicals, can you help? Probably have to stop sharing.
You have to just press this share.
Okay, no, okay. So thank you. I think all stalwarts of cardiology from our regions are here, and thank you Medical College and Northeast CSF for the opportunity. Easy, full screen. Okay. So my topic, obviously, when we talk about viability, it's mostly in a setting of heart failure, low ejection fraction, by definition less than 40%, and many of them have multivessel CRE. Now, a couple of important points. This is a short presentation. Obviously, assessment all over familiar, may not be available the facilities, but in terms of prognosis, we know. But I think more interesting recent times, what is the importance of viability? If we do an investigation which is costly, what is the importance in terms of probably more important to the patients. So if we have viability or no viability, does it make any difference in terms of going for surgery or medical therapy, knowing that we have much more better medical therapy at recent times, including a couple of medicines that already been discussed, like RNA and SGL2. And on the reverse side, does no viability means is a dead end and patients will not benefit revascularization. And these are some of the important things. We know that is not an easy answer, and we'll couple try to address towards the end of this. Are going to recover after revascularizations. And revascularization means mostly is a case of coronary bypass surgery in a case of low ejection fraction, and stunning is a in terms of acute ischemia, although these are sometimes overlapping terms and one can lead to the other. In terms of methods that we have, obviously the gold standard is once we assess viability and we do revascularization like a bypass surgery and it recovers, then obviously that is accurate. But in terms of pre-test before going for a procedure, there are tests available, and PET scans, SPECT, echocardiography, and cardiac MR and CT scans is new modality. CT has some of the recent developments, probably will not discuss because a very recent development in the field of viability assessments. In terms of principle, you can see these are the modalities look into different aspects of viability. Like in PET scan, they look at preserved metabolic activity. They have hypoperfusions, they are dysfunctional, but they have preserved metabolic activity like the preservation of glucose uptake, which is assessed by PET scan. MRI and SPECT look at this membrane integrity because if the membrane is intact, they can uptake some of the tracers that are used in SPECT and also in MRI. And whether in echocardiography, which you look for in stress-induced myocardial dysfunctions which recover, this is a contractile reserve. And also the MR has advantage of assessing the myocardial scar, which is unique compared to other modalities. And obviously CT scans look for hyper enhancements. That's we're not discussing because they're very recent things. So just few of the important points to pick up from the investigation. PET scan we know is not available, but then is on the ideal test. And we look at the disbalance between the perfusions, which are reduced, but the metabolism is preserved at least at rest. And some of the images you can see that here, where the mismatch of perfusion and the viability is glucose uptake, which is preserved. That means the myocardial segments are viable. And these are continuous variable. And the more important is that the amount of dysfunctional, but which are preserved viability. And in either some beyond certain segments, beyond certain percentages, the benefit of revascularization probably will be present. PET has disadvantages, and I think to us obviously not available most of the places, but this is quantitative. It is better penetrations and obviously better imaging in terms compared to SPECT. But unlike MRI, you cannot differentiate between subendocardial or subepicardial, or even the degree of scar in the myocardial segments. But look at the studies of PET scan. These are old studies. These numbers of patients are small. And you can see here that the ejection fraction is the range of 30 to 40. And if you look at the segmental recovery after bypass surgery, you can see the sensitivity and specificity is in the range of 70s and specificity in the range of 80s. So 80% sensitivity and specificity in the range of 73%, which are in the older generation trial. The second modality, which are I think available more frequently compared to PET scan, is SPEC, myocardial perfusion imaging, and thallium is one of the things commonly used, and systemically is not a good agents for myocardial viability. Principle already have said that because of it, look at the integrity of the cellular membrane. So thallium is taken up by sodium, potassium, ATPase. If it is present, that means the myocardium is viable. And these are the familiar images. We know we have to do short axis and horizontal and vertical long axis. And normally, if you give thallium and due to myocardium which are viable, they will have increased redistribution beyond certain hours, 3 to 4 hours, or even as late as 24 hours. So that means if these redistributions, late myocardial images shows preserved integrity by delayed clearing from the myocardial segment, that is, they are viable. You can see here is that in the late images, the myocardial integrity is preserved by showing the hyperenhancements by thallium scans. If you look at the results, again, these are older studies. Number of patients are small in individual studies. But look at the predictable in terms of segmental recovery or improvement of the myocardial functions after surgery. Sensitivity and specificity is not very specific, 54 only in general, overall median, but the sensitivity is very high compared to PET. So SPEC have some disadvantages, obviously not available in most of the places. It is attenuation, especially in the inferior segments. And like PET scan, also it cannot differentiate epicardial from endocardial viability. Echo, I think the most commonly used is available, may not be used that much, but it certainly is available. And the hallmark of echocardiography is obviously stress-induced contractile reserve and typical biphasic response where dysfunctional myocardium, which have improvement of contraction at low dose dovitamin and which again become dysfunctional at high dose, is a hallmark of viability. Other parameters are not very specific and sensitive, but are useful because they're very easy to measure, like LV and diastolic wall thickness. If it is very less than 6 millimeters, it may not be accurate, but is one of the indicator of having actually myocardial scar. On the other hand, if the LV is too much dilated, like LV more than systolic volume is more than 130 ml, these are the patients who probably may not recover after surgery. And tissue rupture is also very exciting, and but not many data in terms of prospective studies. One of the examples in terms of viability, the biphasic response, you can see that the mid-inferior segments at low dose, the myocardial segments do recover compared to at rest images. And if we do high dose dovitamin more than 10, then again become dysfunctional, because at a very high dose of dovitamin, the myocardial segments, in that segments, the blood flow is not good enough to maintain contractility. If we see the predictive for in terms of recovery of myocardial functions after the surgery, you can see it is relatively highly specific compared to compared to SPEC images, and sensitivity in the range of 84%. Stress echo have limitations that we know. I think that is one of the limitations which are available. Is a poor acoustic window, and it is to a certain extent is more subjective compared to other images. But we look at some of the studies which have these are old studies before 2000s which have looked into the recovery of, these are not clinical endpoint, these are endpoint in terms of the imaging and then subsequent myocardial recovery after surgery. They are retrospective studies. You can see the sensitivity and specificity of different in the range of 80s and 50 to 70s. So these are some limitations. But cardiac MRI is a new, comparatively relatively new modality, and it has certain advantages in terms of diagnosis. One is LV and actually wall thickness less than 5.5 is not a very specific, but it's one of the marker of having a scar. So if it is too thin, this may be scar. An inotropic result like dobutamine stress echo, and also it also gives myocardial scar extent by late gadolinium enhancements. So somebody who for us with is enhancement with gadolinium, that means that is scar. So bright is dead, which is easy to pick up, and also the degree of scar, but is a transmural or like less than 25 or more than 75. So if the hypertension is more than 75, that means almost 2/3 is scarred. Then that probability of having recovery after surgery is less. If it's less than 25%, is recovery chances is good. Or any in between. These are continuous variables. So degree of segments involved, number of segments involved, also the percentage of the transfer will give an idea how far the surgery will be helpful. This is one of the examples. You can see the anterior segments. The myocardium is thin, and actually you can see that almost 50% of the segments actually have late gadolinium enhancements, saying that these are probably scar more than 50% and probably not going to recover after surgery. So MRI advantages. One of the advantages actually is it can have additional diagnosis, especially to differentiate from ischemic cardiomyopathy and non-ischemic and other inflammatory disease. So additional diagnosis, mechanical complications. But obviously CMR is not available, and it's a very high-end learning curve, and in our settings is not available. But one of the better modality nowadays in terms of assessment of viability. Now, if we look at some of the data in terms of, again, these are all data in the old data before 2000 in terms of recovery after surgery. You can see that these are meta-analysis. You can see those who have non-viable segments, their prognosis actually is worse. You can see that the events rate are higher, but then whether you do surgery or medical therapy, then there's no major differences. That means they have no non-viable segments, they can be sent for medical treatment. Whereas those who have viable segments, then actually they do worse with medical therapy. So this person do better with a coronary bypass surgery. But important thing is that these are the studies before 2000. And in those times, the medical therapy was not that good enough. There no beta blocker I used, and including medicines like used nowadays, like MRA and ARNI and SGLT inhibitors are not used in this time, including beta blockers. So this data probably may not be relevant in our context where medical therapy is until is better. Now, what are the clinical outcome? Probably more important to the patients is that these data that we have discussed in terms of outcome, these are retrospective. Then medical therapy was not good enough, beta blocker are not used. These are before 2000. But if you pick up some of the important studies, thesis widely quoted and all the better studies in terms of assessment of myocardial viability in LV dysfunctions with multivessel disease. Here you can see that LV ejection fraction less than 35%, where that are randomized to medical therapy alone, medical therapy plus CABG, and all third arm of medical therapy plus CABG plus surgical ventricular reconstructions, and that most of us are aware of that. You can see that whether it's a medical therapy or CABG, the primary endpoint was total mortality. So you can see the primary event was not significant. Whether these patients who have ejection fraction less than 35, whether medical therapy or CABG, their actually event or primary endpoints are similar. Although there are differences in terms of secondary endpoint. So if the patient is sent for surgery, their probability of dying from cardiovascular disease is actually lower, although p-value is less 0.05. But if you add hospitalizations for cardiovascular cause plus CV mortality, then the benefit is more in favor of CVG and a strong p-value. So probably at least if we're preventing cardiovascular death, if not total death, and then these patients are less hospitalized, which may be important for some patients. I think it was one of the better studies in terms of and done in recent times for this category of patients. But importantly, for our discussion, if you look at the viability, in the cyst, there is a sub-study of almost 50% of the patients where viability was assessed. Here, the theory was that half of the patients, roughly, the myocardial viability was assessed, and then were randomized for medical treatment versus CABG. And you can see that the SPECT and the vitamin was used, echo. And almost, you can see out of almost 1,200% of stitch, 600 patients were randomized for, not randomized, for referred for viability assessment, and half of them are randomized to surgery versus medical therapy. And you can see the one thing is that like in previous trial, if a patient have viability, this patient actually have better prognosis compared to the previous trial. But now, because in 2000 we have better medical therapy, so with viability they have better prognosis in terms of mortality, also in terms of cardiovascular mortality. Even though in multivariate analysis the events was not significant, but certainly the numbers was less with patient viable myocardium, which gives an additional prognostic importance. Similarly, if we add mortality plus hospitalizations, these are all in favor of viability, viable myocardium, they have a better prognosis. But most important is that if we randomize for viability or no viability, and then the mode of therapy, the surgery or medical treatment, there's hardly any difference. So if viability or no viability, if we send for surgery or if we do not send for surgery, the prognosis does not make any difference. So what is important is that, so whether do CABG or medical therapy, patient have LV ejection fraction less than 35, then actually viability testing is not useful on that aspect of improving prognosis, which was actually the initial hypothesis was actually not proven. So the stitch viability hypothesis that if we assess viability that are not useful in terms of giving a prognosis and to choose therapy, although there are limitation of this study because the selection or referring patients for viability was not randomized. It was based on subjective criteria at the discretion of the operator. But certainly this is one of the better studies, larger studies to decide the relatively recent medical therapy in patients who have low ejection fractions. If not only the stitch, but we have also other few recent trial where we have seen this trial where PET scan was done and then were randomized depending on the PET scan or standard of care without PET, which is the things we are doing at least in our clinical practice, not sending for PET. So PET or versus no PET and then standard of care, there hardly any difference. Again, if you see the heart failure reduction trial in 2011, patients with viable myocardium sent for medical therapy or viable myocardium, then angiogram followed by revascularizations. Actually, this trial was stopped prematurely because there's no benefit of revascularizations. So this gives an idea, probably you did not have good quality data to say that viability assessments may not have a effect in terms of choosing a therapy, whether it will be medical therapy or CABG will have additional advantages. Again, I think that is, limitation of assessment of myocardial viability, because in stitch trial, they have shown that those patients who have extensive left main disease, like extended like left main disease, three vessel disease, proximal LAD, lower EF less than 24%, high angiosolic volume. So these are the patients who actually do benefit from surgery. And one of the theories is that, like in previous trial, it's not always the myocardial recovery. It probably there are additional benefit of myocardial revascularization like CABG, because it may not be only because of improvement of myocardial function, but probably also some of the effect like future event reductions like microinfarctions and even electrical stability. So that gives an idea that probably viability assessments may be only one of the factors that has to be considered while assessing these kind of patients. So for us,
we are running behind time. So if you can finish
half
your
a minute.
presentation.
Yeah, it's the last presentation. That will be the last slide. So I think the important is that the complexities in clinical decision making, viability is one aspect. And beyond viability, you have to look at the symptoms, angina, the coronary anatomy, the age, mitral regurgitation, renal disease. And I think most important for us is that good quality medical therapy is indispensable. So we have better medical therapy that already been discussed. So last slide, obviously you have imaging modalities which can use depending on the availability, viability and prognosis. Yes, interaction is not a continuous, is not mutually exclusive. And certainly, at least we have better medical therapy to offer in patients who have heart failure, low ejection fractions with multivessel disease. Thank you.
Thank you, Indra. I think that was very well presented, and the stitch trial did show that trying to assess myocardial viability in severe LV dysfunction is not that important. Rather, most patients who do well with revascularization with if they are having LV dysfunction. So that's an important message. And over to the chairpersons for some remarks if they have, if any, and otherwise we can conclude the session. Nirmalda, Baido, Anwar.
I think a very good presentation, and basic message that you have got, it is you have to go for evaluation if required, and for that one you need not look for the viability. The clinical parts matter very much, and also maybe the echo will help us in that way. Thank you.
So if there are no more further remarks, then we can conclude this session, since we are more than half an hour behind, almost 45 minutes behind, and we have to accommodate our guest speakers also. So I hand over the mic to Farin. Congratulate all the speakers for a wonderful job done, and thank the chairpersons, and hand over the mic to Farin. Thank you.
Thank you, Nilda, for conducting the session wonderfully. Now I request our esteemed Professor Sandeep Dutta sir, who is the HOD of Medicine of Guwahati Medical College, to take over and conduct this session, which is a miscellaneous session, and we'll be having 3 talks. Dr. Sandeep Dutta, are you there?
Yes, I'm here. I'm here.
Sir, you please take over. You can conduct the session.
Tell me one thing before. Are we really running off short of time? Will be cut off or something?
No. You will not be cut off, sir.
Okay.
We just request the speakers to maintain time and complete the talk within 12 minutes.
Yeah, great. I would also welcome all the chairpersons. There are a number of chairpersons. Are they there? Are they there? Manojit Chaudhary, sir, Asane?
Yes, I'm very much here.
Good, sir. Good, sir. And Rai Burua, sir? Rai Burua? Rai Burua, no. Chinmoy Muzumdar, are you there?
Yeah, I'm here.
Great. And Major General Kamar Pathak?
Yeah, I'm here. Yes.
Great. Can we start, sir? I think so. Manojit Chaudhary, sir, you can introduce the speaker and start off, because we're running behind time, they are saying.
Sure. Hello, good evening to everyone. There are 3 deliberations this evening now in this session. The first one will be by Dr. P.C. Sharma. He will talk on the management of valvular heart disease during pregnancy. So, Dr. P.C. Sharma is a very senior cardiologist. He has been the HOD of cardiology in 600 College. So, I request Dr. Sharma to go ahead, please.
Huna.
Dr. P.C. Sharma, can you hear us?
Hello.
Prabhas, you can start. Prabhas, you can start. You are behind.
You can see my slides?
Yes. Yes, please start.
Is it coming in full screen?
Yes, it is.
Okay, thank you. First of all, I thank the organizers, the GMC and the NECSI for inviting me for this talk. I feel a problem with most of the cardiologists and physicians face every day. The management of valvular heart disease in pregnancy. This is one part of management of heart diseases in pregnancy. So heart disease complicates pregnancy. Some of the, divine pregnancies, the result of uneventful pregnancy, divine outcome. The heart disease and stroke, the #1 killer among the women. Some of the important facts, but I cannot see the timer. The health of the developed, please give me a warning after 10 minutes. health of the developing fetus is predominantly determined by the health of the mother. However, the safety of the mother is of highest priority, though we do not ignore the fetus. Drugs, diagnostic studies, and surgery should be avoided during pregnancy as far as practicable. Heart disease is the second most common cause of maternal death after suicide in Western countries. The pregnancy is complicated by maternal diseases in 1 to 4% of cases. CVDs are still the most common causes of maternal death in Europe and the Western world. There are 3 connections between the pregnancy and heart-related problems. The pregnant heart patient. A heart disease present in a lady who became pregnant. Second is gestational heart-related problems. The pregnancy has caused some of the heart diseases like pregnancy-induced hypertension, gestational diabetes, peripartum cardiomyopathy, etc. And third one is the congenital heart diseases that could develop in the fetus because the mother has congenital heart defect and that is affecting the fetus. Now I will concentrate on the number 1, the pregnant heart patient. The pregnancy is a hemodynamic overload. It is a procoagulant and prothrombotic state. It is pro-arrhythmic state. So most of the problems are related to these physiologies. We know that deep vein thrombosis is also common in pregnancy that leads to embolism. The thromboembolism is more common in some of the congenital defects, dilated atrium, arrhythmia, etc. Now, the pregnant heart patient, the heart disease may be present in that particular lady, which may be manifest or may not manifest. She may have mild symptom or may not have symptom, or she may be symptomatic already, diagnosed case or undiagnosed case. Our duty is to diagnose and to anticipate the complications and to manage the complications during the pregnancy, delivery, and postpartum period. Pregnancy is, as I said, is a hemodynamic overload. In a lady who was tolerating the heart problem, say for example, valvular heart disease during the non-pregnant state, after pregnancy, because there is tremendous increase in the blood volume, the plasma volume, stroke volume, the cardiac output, a mild or moderate type of defect that was asymptomatic now becomes symptomatic. The heart diseases can be classified according to the risk, maternal risk, low risk 0 to 1%, medium 5 to 15%, high risk, the 25 to 50%. The highest risk patients are the severe MS, severe AS, symptomatic, the pulmonary hypertension, the Eschen-Menzer syndrome, aortic coarctation with valvular involvement, Marfan's with aortic involvement. Pregnancy is a hemodynamic overload, procoagulant, prothrombotic, and proarrhythmic. I repeat, cardiovascular adaptation during pregnancy. Pregnancy is an altered physiological state. The significant hemodynamic abnormalities occur. Overload, the blood volume doubles, heart rate, stroke volume, and cardiac output rises by 40%. The red cell volume rises, but there is relative hemodilution causing anemia of pregnancy. So peripheral vascular resistance, diastolic blood pressure falls, causing widening of the pulse pressure, the collapsing pulse. From the 6th week of intrauterine, pregnancy, then gradually this hemodynamic changes occur, and at the end of the second trimester, maybe around 20 to 30 weeks of gestation, there is maximum volume overload. And during CS or during normal delivery, also the intubation, extubation, the drugs, the blood loss, and abdominal surgery, all that lead to the overloading of the heart. And this diagram shows the cardiac output rises, the heart rate rises, the stroke volume rises, systolic blood pressure rises, diastolic blood pressure rises, but less, peripheral resistance decrease, and hemoglobin concentration decreases. Though there is rise in the RBC count, but there is relative hemodilution causing anemia of pregnancy. The plasma volume rise is disproportionate to that of the whole blood and erythrocyte increase. Systolic blood pressure and cardiac output rises, but diastolic blood pressure and peripheral vascular resistance decreases. A critical period is maximum change, as I said, 20 to 30 weeks of gestation. intrapartum, during each uterine contraction, the stroke volume and blood pressure rises. Just after expulsion of the baby and the placenta, there is squeezing of blood to the maternal circulation. Peripheral fluid is reabsorbed to the circulation, and thereby there is sudden increase in the intravascular volume within 1 hour from the delivery of the baby. The second up to second week porphyrium, there is maximum risk of infection, thromboembolism, etc. Pregnancy changes mimic the cardiac diseases. Evaluate the patient if possible and during early pregnancy and follow-up. Symptoms and signs of pregnancy, the heart murmurs, I'll skip this. Some of the symptoms mimic the heart diseases. Supine hypotension syndrome, because of paucity of time, I will not go into the normal things. Only thing that in normal and abnormal conditions during pregnancy, the severe progressive dyspnea, paroxysmal nocturnal dyspnea, syncope and exertion, effort or emotional chest pain, severe peripheral edema, clubbing and cyanosis, persistent neck bendation, cardiomegaly, Ford heart sound, grade 3 or more systolic murmur, the sustained arrhythmia, these are the signs of heart disease in pregnancy. The preconception counseling, that is important. Considering the presence of heart disease, which is already treated surgically or some balloon dilatation or medically treated patients, we will have to explain that what is the risk carried during the pregnancy. If the patient needs a valve replacement before pregnancy, suppose in a young lady, then we will have to talk to them that the bioprosthetic valve is better, though it has a lesser durability, but bioprosthetic do not require lifelong anticoagulation. So during pregnancy, the problem related to the anticoagulation can be avoided. Soil or the seed, which is more important. Maternal and fetal outcome depend on the nature of the disease, the severity, the degree of sinus and hypoxia, pulmonary venous and arterial hypertension, the functional status. The unfavorable outcomes are CHF, hypertension, and arrhythmias. Fetal risk of congenital malformation, abortion, IUGR, prematurity, and perinatal mortality. This is the ACC/AHA guideline for protocol for preconception counseling. Classification of heart disease according to the maternal risk group 1, 2, or the WHO has defined class 1, 2, 3, 4. I will come into the next slide. This is the WHO classification. Class 1 to class 4. These are the milder diseases which has less complication, like the pulmonary stenosis, PDA, mitral valve prolapse, or PDA, ASD, VSD, as isolated atrial or ventricular ectopic. These are the least risky. And the class 4, the WHO class 4, the severe mitral stenosis, severe symptomatic aortic stenosis, pulmonary arterial hypertension, severe left ventricular dysfunction, EF less than 30%. History of peripartum cardiomyopathy, that is important. Once there is peripartum cardiomyopathy, no further pregnancy is allowed. Uncorrected severe coarctation, Marfan syndrome with aortic root diameter more than 40. These are the very high risk situation, class 4 situation. The WHO classification, these are elaborated in one by one slide. There are some other severity risk scoring system like the Zahara risk score, the Carpeg 2 risk predictors. These are all the clinical and anatomical, almost like the WHO classification. In general, the lesions which benefit from low peripheral lesions like AR-MR, whatever may be the severity, with normal left ventricular ejection fraction, they do better. And the left to right shunt without pulmonary hypertension, they are well tolerated during pregnancy. Mild valve stenosis, cardiomyopathy with ejection fraction of 45% or more is well tolerated. High risk conditions are severe MS, severe symptomatic AS, prior cardiac event or arrhythmia, poor ventricular functional class, cyanosis, LVOT obstruction, the hypertrophic cardiomyopathy, LV systolic dysfunction, and pulmonary arterial hypertension. Now let us talk about the few of the situations like mitral stenosis, HCM, prosthetic valve, Marfan's, Turner's, CADR. So as I have to limit my talk with the valvular heart disease, the mitral stenosis is the most common valve disease managed during pregnancy. Increased hemodynamic load and tachyarrhythmia, precipitous pulmonary edema. Management includes the physical rest, diuretics, docosas towards the last part of pregnancy. There is hemoconcentration. So that time diuretics should be restricted. The beta blockers, anticoagulation for AF, DC cardioversion. If PTMC or balloon dilatation is needed, that has to be done after 16 weeks to avoid the fetal loss, and not at the last part of pregnancy. Again, that will impose a risk of miscarriage. MVR, if necessary, those who are not suitable for PTM, mitral valve balloon dilatation, mitral valve replacement may be needed if essential, but it carries a high fetal risk of 20 to 30%. Vaginal delivery is preferred with epidural anesthesia. Assisted second stage should be cut short. CS delivery is reserved only for obstetrical indications. So in patients of mitral stenosis, say mild, moderate, or severe mitral stenosis, the risk of heart failure in mild, moderate, and severe rises, like arrhythmia, mild, moderate, severe, hospitalization. So as the severity of mitral stenosis goes towards the higher side, then complication rate is higher. Second one is the aortic stenosis, the highest risk in severe AS with aortic root diameter more than 50, in case of Marfan more than 45. AS severity generally increases after pregnancy, during repeated pregnancy. Rest, the cautious use of diuretic, the main modality of treatment. The vasodilator should be avoided. If needed, balloon valvuloplasty, not surgery. Delivery, again, vaginal delivery is preferred. Care should be taken to avoid sudden drop in preload and systemic vascular resistance in aortic stenosis. AR and MR, whatever may be the severity, the regurgitant lesions are better tolerated. They are well tolerated even if severe due to fall in the systemic vascular resistance and blood pressure. LVF during pregnancy can well be managed with diuretic vasodilators like hydralazine, nitrates, and avoiding hypotension. AC inhibitors and ARBs, as all of you know, are absolutely contraindicated in pregnancy. Again, pulmonic stenosis also well tolerated. Pulmonary regurgitation and tricuspid regurgitation are usually well tolerated. The prosthetic valve and anticoagulation, this is one important aspect. Many of the patients are with prosthetic valve. The main problem of prosthetic valve is anticoagulation and the risk of infective endocarditis. Increased hemodynamic load. Pregnancy, as I said, itself is a hypercoagulable state. Increased thromboembolic event. Teratogenic effect of anticoagulants, particularly warfarin. Heparins and low molecular heparin, they do not cross the placenta because of large molecular size, so they are preferred. The bioprosthetic valves are best choice, though there is accelerated valve degeneration. Mechanical valve causes 10% risk of thrombosis and thromboembolism, maternal mortality, the major bleeding. Warfarin is related to embryopathy, risk of miscarriage and stillbirth. So at planning pregnancy, the anticoagulation management during pregnancy, the anticoagulants should be changed to heparin up to 13 weeks. So in the second and third trimester, till say 1 or 2 weeks before delivery, the oral anticoagulant can be continued. But in the first trimester, say up to 13 weeks of pregnancy, it has to be covered by heparin. And again, heparin, it has to be changed to heparin just 2 days prior to planning vaginal delivery or planned cesarean delivery. Stop heparin at the onset of labor and reinstitute 12 to 24 after delivery. But you should not forget that after delivery, there is a severe hypercoagulable state. Restart oral anticoagulant after 24 hours, overlapping with heparin. Anticoagulant regimens, different combinations and permutations with heparin and low molecular heparin can be given. PTINR should be maintained above 2. Yeah, I will go fast. The risk of the mother and the fetus related to VK only, the high dose VK, low dose VK, combination therapies, the risk to the mother and risk to the fetus is always there. Even with good INR maintenance during pregnancy, the risk of thrombosis and embolism is the another important aspect is antibiotic prophylaxis for infective endocarditis, not during pregnancy, but before delivery, vaginal or cesarean delivery, it should be there. The cardiac drugs that are unsafe in pregnancy, we must remember ACE inhibitor ARBs, the nitroprusside, the amiodarone, the statin group of drugs are also to be avoided in pregnancy. So with this, I think I will come to the last part of my presentation. These are a list of drugs. Most of the drugs are safe, as I said, except few. These are contraindicated. Now, thank you. Thank you for your patience hearing. Over to you.
Thank you, Dr. Sharma. Chairperson Manoj, kiba kobo neki, sir?
Regarding last part of the patients with prosthetic valve with anticoagulation, we particularly our patients group, they are generally the poor socioeconomic group. They cannot afford to buy prosthetic valve, so we used to put the mechanical prosthetic valve. So during that the patient comes with when patient comes with pregnancy, our protocol we have started the first trimester. We once that detected the pregnancy is taken place, then we started a low molecular heparin LMWX 40 mg OD instead of anticoagulant whatever acetone or WAF. So first trimester we start only injectable, then second trimester and only final second semester we open for oral anticoagulants, and last trimester generally, particularly we have already delivered five baby with this protocol. The 20 days prior to the date of labor, that means delivery, we start again low molecular heparin. Then once patient delivered, then immediately we can start oral anticoagulant. That is, and our protocol is we used to 1.7 to 2.1 is the range of INR.
That is true. So oral anticoagulant can be continued just 2 days prior to planned cesarean delivery or vaginal delivery, but we do not know for normal vaginal delivery. So ideally up to 36 weeks, after 36 weeks again switch over to heparin. Then again 24 hours before planned surgery stop heparin. Immediately after delivery that heparin and
because we have to follow the PT-INR, then accordingly we will do.
Yeah, because after delivery, we should not be very happy because that is the period, the maximum procoagulant period. So after delivery, again, heparin and oral anticoagulant should be overlap. After 2 days, you continue with oral anticoagulant.
Thank you. Thank you, Dr. P.C. Sharma. It seems we are running short of time. The next chairperson, Dr. Chinmay Mazumdar, please will you take over? Can you hear? Can you hear, Dr. Chinmay Mazumdar? Yeah, please could you take over?
Yeah, we have Dr. Amit Malviya here. He will be having his presentation on leadless pacemaker. How does it fit in practice? Dr. Malviya is an assistant professor in Department of Cardiology in Eglin, Shillong. Malviya sir, you can proceed with your presentation.
Dr. Malviya, can you hear?
I think, sir, Dr. Malviya is not present.
Oh. If Dr. Malviya is not present, what do? We go on to the next speaker, is it?
Yes, sir. We'll go on to the next speaker. Next speaker.
Okay, the next speaker we have is Dr. Amya Sharma.
Yes, I am here.
So Amya Sharma, I think so, Chinmay, you should take over now. You be the chairperson for this talk.
Yeah. So I welcome Dr. Amya Sharma, the present president of Northeast CSI. Sir, you can proceed with your presentation, sir. Regarding peripheral arterial disease.
Thank you very much. Thank you very much. Thank first my respected chairperson and my friend moderator, Dr. Dotto. It's a very pleasant evening and welcome to all of you to this meeting. I had to choose this topic because of the fact that recently I have started my, I started visiting one of the, this hospital, ESI hospital over here in Guwahati, and I have seen number of cases of, this diabetic cases, especially in case of chronic liver disease with number of, this peripheral artery disease and gangrene of the foot, and that, made me, to think for this topic, which is very much common, I feel. And I feel it is neglected also to some extent, because the amount of, this importance we have to give as opposed to the coronary artery disease, probably it is less. Is it okay? Am I audible to everyone?
Yeah.
You're audible. Your PPT is not visible, sir.
PPT is not visible?
No, sir, we cannot see your presentation.
I have given the PPT to the, this, I have sent a mail also. Can you help me to get it?
Sir, can you press the share button?
Yeah, yes, sir. I'm pressing the share button also.
After that, you have to select the PPT and share.
The event organizers, please help him. Please help him, the event organizers.
Yes, sir.
I have already mailed my presentation also for any type of difficulty.
Dr. Omyoda, if you have your presentation, you can screen share.
Yeah, it is in the screen.
You can share this screen. Go to the 3 dots below. And just click there, you'll find an option, screen share. Share screen option.
Share screen. Share screen. Green color, share screen. Omyo tolot ase, tolor phale mazot.
You have shared your PPT to our mail ID?
Yeah, I have mailed it to you.
So we haven't received it, sir. Can you please open the PPT first?
One
open
second.
The PPT first, keep it open.
Yeah, I have kept it open.
Yes, then come back to Zoom.
Yeah, I'm
now
sharing.
Share screen. Multiple window will pop up. Select your presentation.
Yes, I am just.
Now again share screen.
Yes.
Select share and it will be shared.
Is it available now?
No.
No, sir.
No, Omyo, your photograph is only coming. Kibara kubat problem hoye ase.
Sangamitra, you have with you? Sangamitra?
Sangamitra, I have said.
Sir, we haven't received any.
Yes, now you're coming. Now you're coming, Omyo. Now you're coming.
It is coming?
Yes, now it's coming. Slightly better. Try again.
Is it there?
No, only now name is coming. Halke bolwa na. Ako try karsan. Try share screen.
Yes, yes, I'm trying sharing of the screen.
I think Dr. Malviya is there. We can do his presentation and then.
Yes, I think Dr. Amit, if he's available, then we can go ahead with his talk and then come back to Dr. Amit Sharma.
Okay, right. Chinmay, the chairperson, Dr. Chinmay, please could you connect with Malviya and get things started again?
Yeah. Yeah, Dr. Malviya, are you there?
Yes, yes. Am I audible?
Yeah, you're audible. Dr. Malviya, please proceed with your presentation.
Okay, okay. Thank you. I'll just start. My net connectivity is not good, so I'll just keep on my video off. Can my screen is visible? Is it visible?
No, sir. I'll just share your PPT. You just say next. Is
Okay,
that
okay. You share. I already given you my PPT,
Yes, sir.
so please.
Yes.
Please start his PPT. Yes. Yes, you're okay.
Good evening, everyone. So today we'll be discussing in brief about leadless pacemaker and what is to be expected of them. As we know that conventional pacemakers have been there. Next slide, please. Next slide, please. Conventional pacemakers have been there from a very long time. Almost it's going to be 100 years of since the invention of conventional pacemakers. And they have helped a lot of patients from last so many years and decades. But with the advancement of technology, the pacemaker technology also has improved. And from a size of a big computer box, now the pacemaker size has reduced to almost small pin, which can be implanted directly in the patient's heart without any leads. And these pacemakers are called as leadless pacemakers. So in this lecture, I'll be covering a little bit about the advantages of leadless pacemakers over the conventional pacemakers. As all of you are aware that at present, leadless pacemakers have very limited indication. And that is because they have several limitations like short battery life, and the replacements are needed more frequently than conventional pacemakers. Plus, since they are directly inserted in the endocardium of right ventricle, limited number of replacements can be done. So in young patients, it's a problem. You cannot do many replacements over their lifetime. Otherwise, there are few indications which are there for these leadless pacemakers, which I'll be discussing subsequently. Next, please. So the basic thing in a pacemaker system is a lead. So lead has got many components like the conductors, electrodes, insulation, fixation, connectors. But there are many issues with this conventional leads. Sometimes we end up with some mechanical failure like breakage of lead or failure of the insulation which is provided with the lead, leading to pacemaker malfunction. Then sometimes pacemaker lead infection happens. They need to be extracted. Extraction is a big problem, especially if it's a chronic implantation long term. The devices used for the extraction of leads are very costly. Sometimes patients cannot afford them. Then mobility restriction with the patient. Most of the patients, because the pacemaker is implanted on the shoulder side, they tend to reduce the movement. They develop frozen shoulders and so many other problems. Plus MRI incompatibility. So leads have got some issues which have been perennial and persistent. Next slide, please. So as I said, infection rate is around 1%, grossly 1% yearly infection rate, and 2 to 7% for replacement or upgrades. I mean, 1% is for new implantations and 2 to 7% is for replacement or upgradation. Then lead malfunction rates are around 2.5%, means around 3 cases out of 100 will have some or other lead malfunction, either lead fracture or loss of insulation or displacement of the lead. And sometimes, around 0.5 to 1% there redundant leads are there, which needs a device replacement. So overall, the annual complication rate related to the leads is around 5 to 6%. Next slide, please. So that thereby came the concept of leadless pacemakers, because leads were maybe still the weaker link in this almost perfect pacing system. If somehow we can have pacemaker without leads, these complications could be avoided. Next please. Second important problem was pocket infections. As we all know, I need not elaborate this. It's patient discomfort, hematomas, infections, cosmetic concerns. So if there was a way to avoid all this, that would have been great. And leadless pacemakers have come as a miracle solution to this problem. Next slide, please. So the benefits of leadless approach, as I've already discussed, reduce invasiveness, improved efficiency, and improved outcomes, because the expected complications from the pocket side and from the leads is absent because they are not there. Next. So somehow or the other, we can call it the holy grail of pacemaker technology. Next slide, please. This leadless pacemaker is basically very clear and intuitive way of delivering the pacing to patients who require them, with lot of potential benefits: least invasive, least complications, economic benefits, not in our country, but maybe in Western countries, where fewer implant procedures, less fluoroscopy, better utilization of assets for the hospital, and a great fit for a developed and growing market. Next slide, please. So leadless intracardiac, basically it right now what is available is only for right ventricle in India, but their leadless LV leads are still in development, and leadless ICDs also are in development. Very soon we can expect the leadless ICDs to be available. Next slide, please. So currently the leadless pacemaker available widely is from Medtronic companies, Micra. And basically it's right now they have two models. One is VVI and another is VVI-R. So VVI-R is basically VDD pacing. It senses the atrial activity by pressure changes and acts like a VDD pacemaker. So that is a new launch, and it is greatly useful for especially younger patients who need a leadless pacemaker for certain indications. Next slide, please. Next slide. Next. Next. So leadless pacemaker implantation is a previous slide, please. It's a very simple procedure. After femoral vein access, we go up to the mid portion of right atrium. That is a flexible delivery sheath. We orient the sheath towards the RV apex on the basal side of septum. Once it is properly oriented, the injection is given to check the orientation of device. Then the device is tethered to the RV endocardium. Then we pull it back just to see if it is properly tethered with the help of sutures, and then cut the sutures, take it out, close the wound, and it's done. If everything goes right, this procedure doesn't take more than 7 to 10 minutes to complete. Next slide, please. And it is done under complete heparinization. This is the slide showing how the Micra device adheres to the endocardium. There are 4 adherent tenets which go inside the myocardium, come back and stabilize the device. Next slide. This is the fluoroscopy image. As you can see, this how this device is delivered with the help of delivery sheath and placed at the basal part of the RV side of the septum. Next slide, please. Next slide. Basically, these slides are showing that the stability and longevity of Micra or leadless pacemaker available is as good as the conventional pacemakers. But in practical experience, we have seen the battery lasts maybe around 8 to 10 years. After that, and especially if the patient is pacing dependent, after that we need a replacement for the battery. Next slide. Next. 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 Next, please. These are all slides demonstrating the deployment of the device. But important thing which I wanted to discuss here is what are the indications of Micra? Basically, in clinical practice, Micra is good for elderly patients like who are more than 70 years of age, and they need a pacemaker support, because for them conventional pacemakers, the risk of infection is high, risk of other comorbidities are high. So for them, it is very useful. Just 1 or 2 day admission, you put Micra, then next day they can go home. Least risk of infections, least risk of complications, and they would not need more than one replacement in their lifetime. So one is, elderly patients. Second is patients who had recurrent pocket infections. There are many patients who have complement deficiency, and you put pacemaker on one side, then other side, and infections do happen again and again. For patients who have recurrent pacemaker site infection or lead infection, it is good for them. And third category is, when patients who have anatomical problems, like SVC or IVC obstruction, you cannot put the leads, or there's some other things which are structurally difficult to place a pacemaker system from the upper limb side. You can use Micra from the femoral side and place the device nicely. Next, please. I think my time is over. I'll not take much more time. Please go on to the conclusion slide. Next, please. Previous one. So in 2021, now the guidelines have come, and ESC has placed them as a 2A indication that leadless pacemaker should be considered as an alternative to transvenous pacemaker when no upper extremity venous access exists, or only when the risk of device pocket infection is particularly high, such as previous infection or patients on hemodialysis. Leadless pacemaker may be considered as an alternative to strangled single lead ventricular pacing, taking into consideration life expectancy and shared decision making. That is what I said, means elderly patients who have less life expectancy, maybe 10 or 15, high risk of infection, other comorbidities, you can consider a leadless pacemaker. Next slide, please. Thank you very much. Next, please. Thank you.
Yeah, thank you, Dr. Amit. So the indication for which the leadless pacemaker was first incorporated was CHB with atrial fibrillation. So I think this is still holds true as a indication for leadless pacemaker.
Indication for leadless pacemaker because it's a single chamber VVI pacemaker earlier. So it holds true that wherever VVI pacemaker is needed, Micra is indicated, but not in young patients, because you cannot do 3.
Yeah.
Yeah, I would like to request the moderator, sir, please.
Yeah, Amit, thank you very much. I think so. We should go on to the next speaker, which will be the chairperson will be. I think so. Rai Borua, please take over. Our AK Sharma's slides are on view.
Okay, thank you very much, sir.
Yeah, Amyo, please start. Because
Yeah, can you see my slide?
Yes, and start.
Yeah. Sorry, I'm sorry for the technical snag. Very good evening, chairpersons, and I am just going to give a brief presentation on the peripheral artery disease, which I find is to be neglected entity in comparison to the coronary heart disease and amount of interest or amount of investigations or treatment strategy we follow for the coronary artery disease. This is definitely it is less in case of this peripheral artery disease. Can you see my presentation? No.
Yes, we can see your slides. Go ahead, Amyo. Rai Borua, please. You're the chairperson for this.
Next slide too. Next slide is not moving.
So press the down arrow key.
Yeah. So if you define that this peripheral artery disease, it encompasses the disorder which affects the non-cardiac, non-intracranial arteries, and mostly it is the peripheral lower limb or upper limb arteries. And cause is mostly due to atherosclerosis, but thrombosis and embolism could be the other causes, and vasculititis sometimes, and fibromuscular dysplasia could be the other causes. In this context, I just want to give the difference between the peripheral vascular disease, which encompasses as opposed to the peripheral artery disease, which includes only the arteries, and it does not include the renal artery disease or carotid or other vascularities, as in peripheral vascular disease. So, epidemiology is, we find that based upon the abnormal, this ankle brachial index abnormality, the prevalence in India, just I find this, this statistics, it is around 41 million to 54 million people of India are affected, and between the age of the age of 60, above the age of 40 years, its prevalence is around 60%, and above the age of 60 years, it is around 50 to 29%. The men are more affected than the women, and blacks are more affected than the non-Hispanic whites. In USA, there are 8 to 10 million people with PAD, and all over the world, there are more than 200 million people who are suffering from the peripheral artery disease. A manifestation of the system, it is a manifestation of systemic atherosclerosis, already I have told, and there is increased risk of myocardial infarction, strokes, and death from the cardiovascular events. And most of the time, these symptoms are ischemic. The prevalence is in general 1 to 4.5%, 4 to 5%, and the presentation is 10 to 30% of cases. It is the claudication, which is found in case of peripheral artery disease, and critical limb ischemia is found in 1 to 2% of the people, and amputation is fine. The prevalence is around 112 to 250 per million population per year. That is the US data. It is undertreated, and which already I have told, and the commonly underdiagnosed is because 30 to 50% are less likely to receive the antiplatelet drug as opposed to this coronary artery disease, as already I have told. The statin use is very less, and smoking cessation therapy intervention, which are much less used in case of coronary artery disease, and this could be due to the less number of studies in comparison to the coronary artery disease study in case of peripheral artery disease. Though if you look at the risk factor of peripheral artery disease, it is not different from the coronary artery disease. Mostly it is the obesity and this smoking. Then increasing age is most of the cases we find more than this around 50% of cases we find this smoking. And if when there is smoking, it is 2 to 4 times higher of peripheral artery disease. Diabetes mellitus, where the distal arteries are mostly involved. And as per the National Health and Nutritional Examination Survey, the insulin resistance is found in more cases of peripheral artery disease. Even in the women health study, peripheral artery disease are common in metabolic syndrome cases. So out of that hypertension increases the risk of peripheral artery disease around 1.3 to 2.2%, and all the risk factors of coronary artery disease like LDL cholesterol, triglycerides, small little lipoprotein, then inflammatory markers like CRP, fibrinogen, leukocyte adhesion molecules are very high in case of peripheral artery disease. But in this context, I would just like to mention that bilirubin, which is found to be an endogenous antioxidant, they reduce the this prevalence of peripheral artery disease. I don't know what is the cause. I think my friend, this Dr. Songita, will be able to explain on that. The clinical presentation of peripheral artery disease is mostly it is in 50% of cases this is asymptomatic. So this is therefore the importance of early detection. And this atypical leg pain was found in 33% of cases, and claudication, which is typical of this peripheral artery disease, it is found in 50% of cases. If you look at the pathophysiology, we know that there is an imbalance between the blood supply and the nutritional demand of the skeletal muscle while in exercise, or there is local accumulation of the lactate and other metabolite which stimulate the sensory receptors and sensory nerve endings. And in chronic limb ischemia, that is CLI, proximal and distal segments are mostly affected, that they are equally affected. if you go little minutely in the, this in the pathologically, we know that the blood supply depends upon this force and this pressure gradient and the resistance. So this stenosis is that there are some typical changes in the skeletal muscle. If we examine it by this electron microscopy, there is a classical type 2 glycolytic fast twitch fibers are lost mostly due to ischemia, as opposed to the type 1 oxidative and slow twitch fibers. As a result, there is decrease in the muscle strength and less exercise capacity in case of PID. So it is specifically the type 2 fibers are affected due to the ischemia. There is increased lactate accumulation, as I have told, and which leads to the accumulation of acyl carnitine during exercise due to the slow oxygen and dissociation kinetics. So mitochondrial respiratory activity like phosphocreatine and ATP activities are reduced, and muscles which are assessed by the MR spectroscopy. This has been seen in MR spectroscopy also. So symptoms are classically described in 5P, that is pulselessness and paresthesia, then paralysis, pain, and pallor. These are the 5 cardinal signs we learned in our graduation or post-graduation days. These are the classical symptoms of this peripheral artery disease. So this presentation, it depends upon that this location of the block. So depending upon the location of the block, if the arteries are involved in around the aorta and the iliac portions, then pain is usually, or the claudication is found in the buttock, and there could be erectile dysfunction also. If the external iliac or the common femoral arteries are involved, then pain is mostly found in the thigh and the calf area. And when the superficial femoral or the popliteal arteries are involved, then mostly this pain is found in the calf area. So depending upon the location of the obstruction, pain is felt in different areas of the lower limb. So most important is the physical examination. Apart from the general examination, the examination of the peripheral pulses and auscultations for the buoy is very, very important for detection of the peripheral artery disease. Apart from that, elicitation of the pallor by elevation of the leg more than 60 degrees, then there may be the trophic changes like brittle toenails, then hair loss, smooth shiny skin, atrophy of the subcutaneous fat, pallor, cold skin, fissures, edema. These are most commonly found in case when we minutely examine the patient of peripheral artery disease. So after that, what are the tests for the peripheral artery disease? I have already talked about the ankle brachial index, but segmental pressure measurement, ankle brachial index, and treadmill exercise testing in some special cases, or the pulse volume recording, or then Doppler ultrasonography, duplex ultrasound imaging, MR angiography in some special cases, and CT angiography and contrast enhanced angiography are the tests which are done most commonly for the PAD or peripheral artery disease. Out of that, the pressure gradient of more than 20 millimeter in lower limb and more than 10 millimeter in upper limb in segmental pressure, that signifies the obstruction or the blockage of the arteries. So, but here one thing you should mention, you should remember that systolic blood pressure in toes and the fingers is 60% or systolic blood pressure of ankle and wrist. So we should remember that. So as per this ACC, this American College of Cardiology Federation and American Heart Association PAD guideline, they have also recommended the ABI. Ankle brachial index is the ideal test for detection of the peripheral artery disease. So normal range is pressure in the ankle divided by the pressure in the brachial artery. It is in the ratio of 1 to 1.4. When it is 0.91 to 0.99, it is called borderline, but it is definitely abnormal when the ratio is below 0.90 or less. And claudication is usually displayed when this ABI is 0.05 to 0.08. There is critical limb ischemia when this ABI is less than 0.5. In some diabetic cases, we find that this ratio is very high. It is more than 1.4 when there is calcification of the arteries. So very high ankle brachial index, in spite of this some ulcers or some peripheral artery disease, it could be because of the calcification of the arteries. So depending upon these symptoms and these findings, there are some classifications or categorization are done for the peripheral artery disease. One of the common classification is this Fontaine classification of peripheral artery disease, where there are 6 groups of patients from 1 to 5. That is, there are 2 groups in 2A and 2B, from asymptomatic to the necrosis of the gangrene, like intermittent. Second is intermittent claudication. 2A is the pain-free claudication, walking more than 200 meters. Pain-free when the claudication claudication distance is less than 200 meters. That is 2B. Class 3 is or stage 3 is the rest pain or nocturnal pain, and when there is necrosis of the gangrene, it is called class 4 or grade 4, stage 4. But the clinical category, another clinical categorization has divided this grading into 6 groups, depending upon the claudication. 3 from the asymptomatic to the severe claudication, and the necrosis or the ischemic symptom from ischemic rest pain to the minor tissue loss to major tissue loss. So there are total 7 categories of this patient for the management of the this PID. So if you look at the management, the objective of the management is to reduce the cardiovascular morbidity and mortality and improve the quality of this life by eliminating pain and preserving the limb. These are the main objective of peripheral treatment of or management of peripheral artery disease. It is a multidisciplinary approach. Always we need the surgeon, physician, endocrinologist, pediatrician, orthopedician, neurologists. All it is a team effort only for the management of the vascular surgeons. All these are very, very important for management of the peripheral artery disease. So most important is the management for the management of the PID is the risk factor management. Out of that, the lipid lowering is the first and foremost, as we know that this in the coronary artery disease or in HPS study where there were more than 6,700 PID patients. So it was found that there is severe mortality, cardiovascular outcome was reduced in 25% of cases by use of simvastatin. But the pooled data from the 17 lipid lowering trial has showed that 26% lowering of these cardiovascular events. So therefore, the ACCF and AHA ESC PAD guideline has recommended the diet and drug therapy to achieve the LDL cholesterol goal should be below 100 milligram per deciliter. Even in the treadmill test, that is treatment of peripheral atherosclerotic disease with moderate or intense lipid lowering study has shown that atorvastatin 80 milligram per day, they increase the pain-free walking distance 60% versus 38% by use of the placebo. So that has proved that the use of lipid lowering drug is very, very important in case of PID, like your coronary artery disease. Second is the smoking cessation is always important, even after this the vascular intervention, surgery or use of medicine. This smoking cessation is very, very important to get rid of this, because this smoking is found to be one of the important cause of peripheral artery disease. So control of diabetes is most important, but at the same time we should remember the result of ACCORD Advanced PAGT and Proactive and UKPDS study, which shows that in spite of this macrovascular complication or macrovascular events are not reduced in spite of the tight control of glucose, and there could be this risk of cardiac or other adverse events if glucose if you go for the tight blood sugar control. So current guideline even then recommended that this, as far as possible, the hemoglobin A1C should be between 6.5 to 7 in case of diabetes and PID. Blood pressure control is very, very important. HOPE trial and the on-target trial, they have shown successful result by the use of the AC inhibitors and ARBs. But one thing is that the beta blockers has the bad reputation of reducing the peripheral blood flow. But after systematic review of the 6 beta blocker study and placebo, found that there is no significant impairment of walking or intermittent claudication in spite of using the beta blocker. So beta blockers that improve symptom in case of coronary artery disease and the reduce risk in myocardial infarction in coronary artery disease. Considering that benefit, if indicated, beta blockers should not be withheld or should not be stopped in spite of having the peripheral artery disease. So that can be safely used. Now the long-acting beta blockers like metoprolol or carbidopa are used, or bisoprolol are used. Now specific drugs like antiplatelet agents, they reduce the cardiovascular events in atherosclerosis. All these studies have shown the meta-analysis of 12 studies, and out of that, it is found that this peripheral vascular revascularization is also reduced by 30%. But if the study of aspirin has shown that it doesn't have the much benefit of cardiovascular events of CV mortality. Even in POPAPET study, that is prevention of progression of arterial disease and diabetes, have shown some negative result. But the antiplatelet clopidogrel is found to be superior to your aspirin. These two study like Capri trial and the Charisma trial, like clopidogrel for high atherosclerotic risk and ischemic stabilization management and avoidance study. There is benefit of clopidogrel in and DAPT, that is double antiplatelet therapy, has reduced the incidence of myocardial infarction and hospitalization in coronary artery disease. Similarly, so current guideline is that DAPT is recommended for the symptomatic patients of PAD. Apart from that, there are some specific drugs for which are approved for reducing the ischemia or the claudication, like cilostazol is a quinolone derivative which acts by inhibiting the phosphodiesterase 3 and decrease the degradation of cyclic AMP. Also, it inhibits the platelet aggregation and cause vasodilation. But when there is this congestive heart failure, its use is contraindicated. Another new drug which has come up is the Nafronil A. It is a 5-hydroxytryptamine receptor blocker which inhibits the platelet aggregation, and it is approved in Europe. Another drug which are commonly used in very old time, it is the pentoxifylline. It is a xanthine derivative which works by its hemorrhagical properties, including ability to decrease the blood viscosity and increase RBC flexibility. So other experimental drugs, I will not go to the details, but for the interest of the this postgraduate, I would like to mention the AC inhibitors, then already serotonin inhibitor, 5-hydroxytryptamine, I have told. Alpha-adrenergic antagonists like brufenamide, another drug, then L-arginine, then carnitine derivatives, then vasodilator prostaglandin I2, and angiogenic growth factor are also explored.
Timing, please come up. Timing, please come up.
Yeah, just 2 slides only. It is. Anticoagulants, only the 2 trials have shown, that COMPASS trial and the Voyager PAD trial has shown that this rivaroxaban and ASA, that is acetylsalicylic acid, there was 50% lower incidence of acute limb ischemia and major CV events compared to acetylsalicylic alone. So they have recommended. So this is the management summary. I will not go to. So reverse vascularization is done when this medical therapy or this conservative measures fails, and the reverse surgery is also done. So in summary, PAD is an underdiagnosed disease. It needs a thorough history and clinical examination. Rest and supervised exercise is a first step in the management. Aggressive risk factor control is critical, and to the management of cardiovascular events, and treatment of intermittent claudication, improved exercise, involved exercise and drug therapy. And treatment of CLI involves the aggressive effort of revascularization, including endovascular and surgical option to prevent amputation. COMPASS and Voyager PAD trial has provided compelling evidence for use of anticoagulant plus aspirin to reduce the risk of adverse cardiovascular events and lip events as a secondary prevention, especially. So this is the brief in summary, is the flow chart for the management. I will not go to the details. So with this, I will conclude my presentation by saying that by looking at the peripheral artery disease, I would like to say that the trouble with the doctors is not that they do not know enough, but that they do not see enough. And this is definitely applicable in case of peripheral artery disease. I remember the quotation by Corrigan, James Corrigan. So with this, I thank you very much for giving me the opportunity. Thank you. Thank you very much. Over to Dr. Farin Iqbal.
Hello, the chairpersons. The chairpersons, you have anything to say? Dr. Rai Burua, do you have anything to say?
Yeah, I would like to add, if I am permitted to. I'm Dr. Kamal here.
Dr. Kamal, go ahead. Just
Yeah, I think in that multidisciplinary approach, you missed out the most important, that is the IR, the interventional radiologist, because he's the one who is going to revascularize your vessels. Nobody else. The rest will just give you medicine and leave the patient. So we are yet, maybe that is because we are very few here in Guwahati, and maybe you all don't even know that we exist. So I feel that these patients, if you want a really holistic approach, I think an IR should be included in the management of these patients. And also, I also must just want to add that for claudicants, okay, you can open up vessels which are above the knee, but below the knee, I think you should be very careful and open up only when there is tissue loss. Otherwise, you should not touch them. Otherwise, you'll make them worse than what they already are. That's all I wanted to say.
thank you, Dr. Kamal. It's a pleasure knowing that we have an interventional radiologist amongst us. And he did include a bit of it, intervention radiology, but obviously you made it more clear that you can intervene only when you have proximal vessels involved and not the distal vessels involved.
No. Even I can intervene even below the knee if there's a. I'm just saying that you intervene below the knee only when you have tissue loss. Suppose the patient is on claudication and has a one vessel runoff, then don't touch below the knee.
If there is only symptoms without tissue damage, you don't do it. If there's tissue damage, you do it.
Yeah, below the knee, yes.
Okay.
Yeah.
Thank you very much. Thank you, Dr. Farin. I don't think so. Do you have any more speakers? We should stop here.
Yes, you can.
Thank you, the organizers, for giving us this opportunity to listen to all these very useful talks. And I thank the other chairpersons who took active participation in this. And from my side, I thank all the presenters as well as these chairpersons for helping this. Thank you, and over to the organizing committee.
Yeah, thank you, Sabita. Good evening, and now we are proceeding to one of the very important sessions of this evening's program. And so we have the invited guest lecture sessions now. So we'll be having 4 eminent speakers, national speakers, who are going to talk this evening. So first, let me introduce our panel of chairpersons. So we have Professor Dr. Bornali Datta, which is a professor of cardiology at Guwahati Medical College.
Louder, please. Louder.
Yeah. Am I audible now?
Yes.
Yeah. So first of all, to introduce the co-chairpersons, we have Professor Dr. Bornali Datta, Professor of Cardiology at Guwahati Medical College. Along with us, we have Dr. Neil Bodler, who is the HOD and the Managing Director of Excel Care Hospitals. And also we have this evening's panel, the Director of Medical Education, Dr. Anup Kumar Bowman. Welcome. So first, then I would like to hand over the mic to Dr. Neil to introduce the first speaker. Am I audible? Over to Dr. Neil for introduction of our speaker.
Good evening, sir. Good evening, Mohan sir, Vinalda, and all other guests here. It's been a very lovely and productive whole day with very high quality lectures, and we want to wind it up by listening to 4 great guest lectures, which I'm going to start now. I think the first talk is by Dr. P.P. Mohanan, who is the president of CSI and a good friend of ours. He is actually the director in HOD Cardiology in Thrissur, Westford High Tech Hospital. And he has participated in so many of these landmark registries in Kerala.
Sir, your screen is not visible.
Yeah?
Sir, we are sharing on your behalf. Sir, 1 minute. We are sharing on your behalf.
No. Wait. I will try.
Okay, sir. Okay.
So he's Mohan sir actually is part of so many landmark registry trials in Kerala. That is the acute coronary syndrome and other heart failure trials. He's also awarded the Dronacharya Award. But what endears him to us actually is the fact that he's so friendly and down to earth. And I met him many years back, and he's always been that humble and friendly person. And one can never forget the help which he gave us when he organized the first large national conference in 2019. So was the pillar of strength for the organizing committee. And even Kerala, as you all know, is doing yeoman work in the field of cardiology and research. And Mohanan sir is the person actually who's the glue who's holding the whole organization together in Kerala. So without taking any more time, I request Mohanan sir to start his lecture today.
Thank you, Neil, for those kind words. Thank you, Pranab and Professor Datta, for being there and tolerating me. We are almost an hour late, and I will not anguish you with a long talk. I will try to finish my talk at the earliest possible time. I will just try to share my screen. Are you seeing it? Are you seeing it? Are you able to see my slides?
No, sir. White
Slides are not visible, sir.
Not visible. Then I think your person has to do it.
Angamitra, would you please
I've already sent it. It is with her. Yeah, it's with her. Only problem is now I have to.
You have to say next
every time. That's all. Yeah, sure. Okay. Now I honestly wish I'm physically there because I love your place. And now, thanks once again. The lipid field has flourished during the past decade with several novel therapeutic agents, either proven or under regulatory approvals. Next, please. And my intention is just to touch on some of these drugs, which some of them are really old, some of them are we have very limited access. Next. But then before I do that, before I talk anything on non-statin, I have to talk something about statin, because statin is the most wonderful drug. And we all know by the time we intervene, we are already late and more atheroma is present. And the statin is one drug which all of us has to use liberally. Next. This is the 30-year saga of lipid lowering therapy. All these initial years, you could see that belong to statin and statin and statin. And the last 10 years has seen some of the other drugs coming. Some of them are powerful. Some of them are basically, it's allegiance to our genetic concept. But then whatever it is, it was basically statin earlier. And now we have something new. Next, please. See, this is after the 2019 ESC documentaries on the lipid management. We basically are becoming more and more aggressive. Unlike the SCCHA guideline, which came almost 1 year prior, the Europeans are a little more aggressive, and they have given us these 3 figures. Now, in the high risk you can keep it your LDL at less than 70, and in the very high risk and the real high risk who has repeated myocardial maze, then you have to bring it down to less than 40. So the levels has been coming down stupendously, and we have again, thanks to the advances in the lipidology, we have more potent drugs. Next. So just remember the numbers. That's all my intention is. The 2019 ESC has again are enforcing these numbers, unlike the ACCA chain. Next, please. But then, unfortunately, what is happening is these numbers are many a time not achieved with our conventional most wonderful statins. As you could see here, this is a little busy slide, but then you could see here, even if you give them the high intensity statin, many a time you are not reaching less than 70, less than 55, or even, of course, very unlikely to reach. Of course, many a time you reach that. My LDL is about 41. I am on high intensity rosuvastatin. That's another matter. Next. Next, please. What again we have seen is the time frame of 5-year horizon. We need to bring it down. That's why the ESC has been insisting on the lowest possible level. So we need to bring down our LDL to the lowest possible level. Next. Another disadvantage. See, one thing is that many a time we are not able to bring down, even with a high intensity statin, we are not able to do that. The second part is, despite using a high intensity statin, there is a significant residual risk. Very many reasons, because we know LDL is only one part of the chain which causes atherogenesis. Next. So this is a large data of US registry, which has shown 2 out of the 3 of the patients treated statin monotherapy may not achieve the levels that I have shown you. So many a time we are forced to use combination therapy. Next, please. So this is the situation. See, these are the situation where we possibly will think about non-statins. Apart from, of course, non-statin doesn't mean that I'm always going to combine these non-statin drug with the statin. No questions asked about that. So when the target LDL is not reached, intolerance or very high, as you have seen in the 55 or 40 level, or polyvascular disease, recurrent MACE, and the familial, and another big area where we have again data from India showing that at least 25% of our own patients that we see maybe have harboring. No, it may be heterozygous. It need not necessarily be the homozygous type. But again, the triglyceride conundrum, which I will touch on at a later part. Next. So there is again, as Kaushik Ray, one of our own Indian guy who has been doing phenomenal work in lipidology. Now he was writing about the changing paradigm. People start thinking about. We have been thinking about non-statin in more of a chronic, stable coronary disease, but we are now thinking about introducing a non-statin even in acute coronary syndrome. Next, please. You have non-pharmacologic means of using non-statins, like I'm not going to concentrate on that because time will not permit me. Importance of lifestyle and food supplements, LDL apheresis. I recently heard a study from and learned that Bangalore, Dr. Iyengar was doing LDL apheresis in a few of his patients, especially with familial dyslipidemia, then of course I'm not going to touch on gene therapy. So these are the areas which we will not touch on. Next, please. I will concentrate more on the published data, not much on saroglitazar. I just included it because I'm patriotic. That's all. I'm not using it. And we have again something which we are not able to use, like bempedoic acid, inclisiran, lomitapide, and mepomazine, and of course some of those very newer agents. Next, please. Ezetimibe has been with us for almost more than 10 years. It basically is a drug which acts on the gut, and on the glucuronidation of the intestine is the one that it tackles. Next. And basically, it reduces the mean LDL level by about 15 to 22%, and maybe a marginal increase in HDL. Here again, I will not be touching more on HDL because we don't have any significant data on that. Next. But when you combine a high-intensity statin, which usually give you a 50% reduction in your LDL, when you combine another additional 10 milligram of ezetimibe with a high-intensity statin, the results looks much better. Something like a PCSK9 does alone, when you combine an ezetimibe with a high-intensity statin. Next. Of course, now we have earlier, the data was not very convincing on ezetimibe, like the SEAS and the SHARP. They were a smaller trial, but then the IMPROVE showed that adding ezetimibe with simvastatin definitely give us mortality reduction. Next, please. And these are something which you have seen an absolute risk reduction of 2%. So a significant reduction in the primary and secondary endpoints are seen. In a statistically significant reduction was seen with that particular data, and we have been using it. All of us has been using it, especially after this particular data. Next, please. Because the guideline also suggested that. If you look at the ESG guidelines, I'm quoting more often the ESG guidelines, basically because it is something just come after the ACCHA guideline, and that is something which I will like to follow. So you could see that now there are the guidelines definitely say that you can add on once you have used high intensity, and if you're not reaching the appropriate level, the add on ezetimibe. Next, please. The PCSK9 again was with us, even though we were not using it very rigorously, but then they were with us in a sizable time. Next, we have basically it acts on the LDL receptor expression, and that's why I said initially, because many of these drugs owe their allegiance, lipid reduction, to our genes, because most of these drugs, PCSK9, inclisiran, all these AGPLTT antagonists. So a lot of drugs are in which they act through the genetic expression. Next, please. One of the registry data, the Sweat Heart, showed that. This is again very interesting data, which has come not very 2020. 4 out of 5 patients with a recent MI would be eligible for escalation for further lipid lowering therapy. Look at that. So the necessity for it is there, definitely for us to use it more often. Next, please. And we have 2 tested molecules in Nevelo and alirocumab, which are used in these injectable doses every 2 weekly. Next. And which very impressive results. Here again, I don't want to spend too much of time because these data you would have seen many a time. But then both evolocumab and alirocumab gives you impressive results with a very good NNT. And the benefit looks much more impressive when we are tackling multivessel disease. That is another reason why we possibly should be using in a more sicker patient, more patient with multiple comorbidities. Next, please. This is again another of the data which showed the Evolocumab very impressive on imaging. It was found that the plaque regression is substantial. So we have again apart from the randomized control data, we have the imaging data, we have the Mendelian data. So every data is available for us to use more often PCSK9. Next, please. And whether it is the diabetic subsets of patient, whether it is the elderly subsets of patient, whether it is patient with chronic kidney disease, every subsets of patient that we see day in and day out with ACS are benefited with the proper appropriate use of PCSK9 inhibitors. Next, please. We have also data. This was an interesting data, which is again something not very old, which used, see, our usual pattern is use high intensity statin, and if the levels are not appropriate, ezetimibe, and then finally PCSK9. That has been our pattern. This is the situation where you are hitting very hard very early. ACS patients are treated with PCSK9 inhibitors, right? I mean, a smaller data, about 300 patient data, and they showed a very impressive reduction in the LDL level within a very short time in hospital. Beginning of PCSK9. Next, please. So we have more on data, and we have again the recommendations of a class 1 recommendation. Next. There were some concerns about the adverse events like a neurocognitive events, but then we have the large database. Next, please. Showed that the adverse events are not to be really worrisome. So we don't need to be, of course, we have to be. If you remember, there was a time when people thought that you could produce intracerebral hemorrhage with very low LDL, but that was not to be. If you look at the Fourier or the DC trial, we have seen patients with 20 milligrams of LDL, nothing has happened in most of patients. Next, please. The only hindrance, now even in the United States of America, this is a problem. I don't think it is different. So even though the NNT is very impressive, the estimated cost at 5 years is a whopping 1.3 crores. So the cost is something which, next please, which definitely prohibit us. And that's why, this is a very recent publication, 2021, June, and this is a large registry from United States. Even there, look at the PCSK9 usage. So the cost is a big hindrance. The insurance is a big hindrance in every part of the world. But then I'm sure, next please, we will be better off. And this is how long we have to give it. And that is a real problem. So of course, there are some studies which have been showing that you introduce the PCSK9 and then go back to the statin. And then we need to know more about that. But this is the major problem with PCSK9 inhibitor. Next, please. Now, coming to let me take you back to some of those older therapies. The fibrates, the PPAR, intracellular receptors. Next, and what is the evidence for fibrate now? Next, please. The field was one of the largest trial, nearly 10,000 people data, but no significant reduction in coronary events. Next. Again, the ACCORD lipid trial, if you remember ACCORD, hypertension arm, the lipid arm, the lipids improved in the ACCORD lipid trial, but there was no overall clinical benefits. So fibrates has been not the favorites for any of us. Next, please. And that's fine. It has been evaluated in many multiple trials. And basically, it remains at a class 2A or a class 2B recommendation. I personally use fibrates more for prevention of pancreatitis. I don't generally use because generally, I think if the triglycerides is only more than, even though there are recommendations, something that if it is more than 200, one may consider. But generally, I am more of a statin person, and possibly we can achieve a triglyceride control if we adequately control the carbohydrate part. Next, please. Niacin, well, again, something which you can forget. The only thing I just wanted to highlight is in 1986, before statin, this was the first hypolipidemic agent which has been shown to reduce mortality. But no way. The next two, next please. The AIM high and next please, and the HPS Thrive both showed niacin has absolutely no role in cardiology and dyslipidemia. Next please. Bile acid sequestrants, the resins are something which we have been studying long back, but unfortunately the accessibility next is very less. And of course, the cholesterol was the most potent amongst all the things. The availability again is rather difficult. You may get it, especially in the statin intolerant patients. After you can have a concoction of ezetimibe and colvisavilam, and that is possible. Next please. But then these are drugs that generally we don't use every day. The triglyceridemia has been a real, it's a cantankerous lipid, because there was a time it was forgotten. Now the lot of noise is being made. Is it a risk marker? Is it a risk factor? Debates are going on. Next, please. But I mean, even the 2021 SEC expert consensus decision is not very sure about what we should do about it. Next, please. Of course, there are very many agents. The EPA came earlier. Next. Then we have the DHA. Of course, the EPA and the DHA. Okay, icosapentaenoic acid and hexanoic acid. Now we have some data which showed that there could be, but then we know that the limitations of these studies. So that's why we have a newer agent. Next, please. In the form of course, all these DHA and the DPA have positive trial and negative trial. So it remains to be seen what will be the future of DPA and DHA. But in the bargain, we have the newer agent in the form of, next please, in the form of icosapentaethyl, which has been used in the reduced trial and possibly the only triglyceride risk-based non-statin therapy right now that we have to use, and when it is available. Next, please. So this was the reduced data. Next, and all of you are aware about the reduced data. Next, please. And it showed every biomarker that from the non-HDL, LDL, even the inflammatory markers seems to be reduced by the use of this particular moiety, which is a modified version of APA. Next, please. And definitely the reduced trial showed us a 20% reduction in death. 20% reduction in death, unlike the DPA and the DHA. Next, which was absolutely neutral. So where is triglyceride now? First, use statin. Remain focused on LDL. Of course, if basically if you are getting more than 150 and less than 150, then you can definitely consider icosapentaethyl. And if it is more than 500,000, then the problem of a pancreatitis then comes. That's why I have been telling you that the fibrates is not my cup of, and I don't use it generally. And whatever fibrate generally available is fenofibrate. Next, please. I think I have to run a little bit. So we have also newer drugs like evinacumab and these new molecule, ANGPTL3, which is again based its allegiance on our genes and which coming up introducing impressive results in triglyceride reduction. And we may definitely see a time when these agents are used more frequently to bring down triglyceride with impressive MACE reduction. Next, please. We have something in the anvil showing some of the phase 2, phase 3 trial has shown that. Bempedoic acid is something again which the FDA approved sometime in 2020, not yet available in India. Next, please. And it again showed that it is basically a prodrug and primarily act on the acyl-CoA. Next. We have definitely data which has shown that it definitely give us impressive reduction in, at least in MACE. The mortality reduction was something possibly it has to better in a larger trial. Next. These are again something which for completions I included. Lomitapide and next. Mipomazan. These are drugs which basically again act on our genetic basis. Injectables, something like PCSK9 and inclisiran, something like. And but then on a different, it has been already approved long ago by FDA. But then basically because of the extreme, the costlier version and something like inclisiran, as I said. Next. This is what inclisiran. We have two important data by Kaushik Ray, and you would possibly remember the social media coverage of inclisiran trials saying that 2 jabs in a year, no heart attacks. See, so that things are happening. Anyway, we are definitely all looking forward to the inclisiran's more data. Next, please, and hopefully its use. So it is approved. Definitely not DCGI. Next, please. Next again, we have more and more data. Only problem with all these drugs is now it will be a miracle when our patient can afford it. That is the only problem. Next. There are again a lot of things in the offing, and possibly we will discuss it on another evening. Next. The big B of cardiology, Braunwald, has written that the race to bottom, by meaning the lowest level of LDL, is the one which will give me the most exhilarating experience. Very interesting. Next, please. So this will be the last couple of slides. This will be the after lifestyle modification and statin. We can be tempted to use ezetimibe, bempedoic acid, PCSK9. And of course, I did not much mention about the LPA because we never had good agents to reduce LPA sizably, like 100 milligram reduction. We didn't have those agents. When it comes, maybe it may be also, we will be using it. Next, please. So again, the paradigm is gradually shifting. It could be shifting. Now, this was, we were using more statin, ezetimibe, and PCSK9. We may change our paradigm when it becomes cost effective. We may change the paradigm. Next, please. Before I closing, I just again want to emphasize on there are a lot of myth on statin intolerance. Don't believe everybody who has some myalgia has intolerance. Try to use more statin, more higher dose. Next, please. And this is again important. Abandonment of statin by physician, by each one of us is again increasing. See, look at the data. Look at the data. 25% of the patient we are at fault. Next. So don't do that. We continue to use, and combination definitely will help us in achieving dyslipidemia control in a sizable way. Next. So thank you very much. Gentlemen, I've been trying to tell you about the importance of non-statin drugs in combination, of course, with the statin drugs in the last 30 minutes. Thank you very much for the opportunity.
Thank you, sir. Thank you for your wonderful and informative, extensive talk. And we are really honored to have you in this meeting. And so we have, coming to the next talk, we have Professor Manoj Kumar Rohit, Professor of Cardiology, PGI MER Chandigarh. I'd like to request Madam Bonali Doctor to please introduce Dr. Rohit Manoj Kumar.
Good evening, everybody. Very warm welcome to all the respected guest speakers. And thank you, Mohan sir, for a very elaborate and excellent lecture. Now I request Professor Rohit Manoj sir to speak on cardiovascular manifestations in COVID-19 patients and their management, which is very much Professor Rohit Manoj is presently he is professor in the Advanced Cardiac Center in PGI Chandigarh. He has done his DM cardiology from PGI and also attained a fellowship in pediatric cardiology from Sydney, Australia, and he is also trained in electrophysiology, adult electrophysiology. And he is an excellent intervention in the two science that he does all the interventions like adult interventions, coronary, non-coronary, pediatric interventions, and also EP studies. So I would request Professor Rohit Manoj sir to deliver his lecture. Welcome, sir. Manoj sir.
Sir, are we audible, sir?
Yeah. Good evening. Can you hear me?
Yes, sir. We can hear you.
Yeah. Thank you very much. Can you see my slides, please?
Yes, sir. Yes.
Thank you, Dr. Pranam, Dr. Banali, and the organizing team for giving me the opportunity. It's wonderful to seminar. We are running late, and I will try to share my thought process on COVID thing. So we all know the COVID affects the heart and heart cell. I will try and show a few slides on how does the underlying cardiovascular disease affects COVID. What is the thought process of myocarditis and heart failure, and some arrhythmias and acute coronary syndrome. And of late, in the second wave, taught us that the thrombosis and thromboembolic events were equally important. So you can see from these slides that COVID basically has important, if you have underlying heart disease or underlying cardiovascular morbidities, increase significantly if you have underlying predictive factor like hypertension, diabetes, and obesity. Overall, there are various studies, but the primary studies from China, which highlighted that importance of cardiovascular disease, and fatality was fairly high if a patient has a comorbidity. So this is the studies which are across the world, which is various studies from 4 to 13%, and the study from Indian shows a mortality risk of almost about 13% in a comorbidity. So if you have a how does the COVID, is it simply COVID or it could be just simply cardiac disease? They both interplay. The COVID patient is susceptible if he has more susceptible and more likely to have worsened severity, likely to be worsened if the patient has underlying hypertension, coronary disease, and diabetes mellitus. And we all know that COVID itself, if it has a significant systemic inflammation, is more known to prone for long-term effect like thromboembolism, like pulmonary embolism, and a stroke is there. It also interplays among the various things, the antiarrhythmic drugs, so especially a lot of azithromycins and quinines were used, and it could have played a role in arrhythmia. The COVID per se in the Italian studies has very clearly shown to us that acute coronary syndrome is associated with COVID. And word about arrhythmias that we'll discuss a bit later. It also could be simply be manifestation. They were there and COVID was incidental, or COVID itself has also caused arrhythmia is there. So among the most important disease which has been noted in COVID is a myocarditis, or what is and it has been reported from various studies from 7 to 28%, where it depends on which center and what series and what parameters you have used. Primarily, people have used markers and point-of-care ultrasound echo to diagnose this condition. Patients with evidence of cardiac injury tend to be older, have more comorbidities like hypertension, underlying coronary disease, diabetes, and heart failure. And we all know the patient has cardiac injuries that troponin T is positive, then the chances of a death are very high in to the 5 times. We should also remember that generally it has been observed that the medium time to development acute cardiac injury is almost about 15 days there. So it probably coincides with the development of acute respiratory distress syndrome. There are multiple factors. Among the two important discrimination is that is it the oxygen supply mismatch, what we call as a type 2 myocardial infarction. Suppose patient develops hypertension because of the COVID-related complication, or he develops increased metabolic demand or hypoxia. All this could precipitate pre-existing coronary syndrome was there, and this simply just precipitate the acute myocardial infarction. Or COVID per se can introduce thromboembolic event, and patient did not have neither had hypoxia nor had metabolic demands nor hypertension, and simply a thrombotic occlusion can occur, and then patient can present as a cardiac MI. There are also microthrombi, especially in the second wave. We have learned that patients are more prone for thrombotic occlusion, or it could be some patient could become a stroke or pulmonary embolism, and that's probably been a result of direct COVID causing some thrombi, micro dysfunction, or some vasculitis which are there, which we clearly don't sometimes understand. And there could be equally stress-induced cardiomyopathy would be there. So in this study from the Wuhan, the patient has a cardiovascular disease and troponin markers are elevated. The mortality in the positive group was very high, to the almost 50 to 60% of patients who had a cardiovascular event who had a mortality in the study from this. And individual who did not have a cardiovascular risk factor or do not have troponin elevated, the mortality is very low, to the tune of less than about 10%, 13%. So, so I think the key marker to contribute or attribute that death is probably the detection of troponin and point of ultrasound showing some stress cardiomyopathy or regional valvularity or LV dysfunction is there on the. People have also used pro-BNP and CRP. And in this, you can see the patient who have a troponin elevation has a higher risk of arrhythmia, especially in a more sicker patient remaining in ICU. So this slide very clearly tells us that if you don't have cardiovascular disease, and if your troponin is normal, then mortality is almost a single digit figure is there. On other hand, you have both cardiovascular disease and elevated troponin. There you can very clearly see the mortality is almost about 60-70%. The combination of this is quite deadly, and it is the more sicker the patient with elevated troponin, the higher the chance of death is reported. You can see from this slide how the markers play on admission, and after a week or so, if you find the patient requires hospitalization, and if you tend to do a troponin T or pro-BNP, and if you can see that troponin T is elevated to hospitalization, then his chances of mortality is fairly high. You can see from this slide as there. So biomarkers were elevated in almost about 8 to 28% of the patients, and as I said earlier, and if the biomarkers are elevated, then the risk of death is almost 5 times the mortality is there in such individual is there. So in a sicker and patient requiring ICU care or showing some changes in ECG or echo, we should get markers in such patients to predict whether they are improving or they are deteriorating. You can see from the slides that basically the coronary events generally are attributed, or environment is attributed after about 10 or 15 days. And you can see from the slides that the recent involvement of say patient who do not have any risk factor and suddenly present with thrombotic MI, or who had pulmonary arterial hypertension because of the pulmonary embolism or because of the stroke, then we tend to exclude because of vasculitis or coagulopathy, and they also tend to have later on onset heart failure, probably because of the delayed failure to resolve of COVID, or worsening of COVID in the later phase of the life. Heart failure is a multifactorial, and it has been reported in a various series of various, and probably it's a multifactorial besides myocarditis, ARDS, acute kidney injury, hypervolemia, stress-induced cardiomyopathy, And on top of that, arrhythmia are multiple factors causing heart failure. And the various studies again have some various things. And if you have an elevated pro-BNP, then the mortality is almost about very high, to the 50%. These are the various studies which very clearly showed that heart failure and is well documented in intensive care setup, and the fairly good documentation is there. The clinical presentation depends on pre-existing cardiovascular morbidity. Chest imaging find heart failure like cardiomegaly, bilateral rails, pleural effusion are the utmost important in a limited setting where we tend to see patients with PPE kit. It's equally important to find out whether patient is deteriorated because of chest problem or heart. Is the point of care ultrasound extremely important besides the marker to find out whether patient has deteriorated because of ARDS or has worsened because of the cardiac problem. And point of care ultrasound was very easily tested and used in our center, and world over it has been used. And if a patient develops heart failure, then we do standard heart failure treatment. We try to give diuretics, ACE inhibitors, and beta blockers as been recommended. Now, next sets of events are arrhythmias. They are multifactorial. Basically, could be hypoxia causing some because of ARDS, myocarditis, that could be simply viral myocarditis, or secondary to because of the cardiac problem, or vascular thrombosis has a late, I said, second or third week. We expect COVID to be vasculopathy, and simply patient could be having acute MI, and you could be having throwing ventricular fibrillation. And delayed reaction could be there and causing simply myocarditis, or persisting and deteriorating is there. We also have to remember that we used to use chloroquine, azithromycin. We no longer, have learned that these drugs are not useful and not important, but we used to use, and they could cause QT prolongation. Torsades is there. We have learned that they are not that effective, and probably as and when we learn future, we will not use them as frequently. Intravascular volume and electro balance, kidney injury can cause arrhythmia. If you are not careful, your renal output is there, hyperkalemia is there. We have ventricular fibrillation could be simply because of the hyperkalemia. So arrhythmias are various arrhythmias are noted, but the most fatal arrhythmia is the ventricular fibrillation and ventricular tachycardia. And in some of the series, is almost about 10% of the death in ICU was simply attributed to ventricular arrhythmia. VTVF was the cause. Marine arrhythmia was the cause of death in the patient in ICU. Almost about 10% of them. And these studies, the various arrhythmias has been noted, and commonest cause of death was the VTVF. Coming to bradyarrhythmias, we have both seen in our setup that bradycardia could be simply because of the myocarditis, which is been there because of the COVID, or it could be simply it was there and been unmasked by incidental COVID positive. We can also be there in there, but we should also be aware of the drug, which is complicated. What we have seen is that it's possible in both ways. Patient could be simply having COVID, and he doesn't show any signs of troponins are normal. Echo is normal, and he has a heart block. So this is simply just COVID is positive, but that probably not an effect of myocarditis. In a study from Mohit Gupta et al. Have shown in 7 patients from bradycardia, 5 of them heart block, and 2 patients have sinus dysfunction. We also have patients of heart block and sinus node dysfunction in our hospital. We rarely require patient of sinus node dysfunction for pacemaker, but to complete heart block patient, we have a temporary put a pacemaker in COVID hospital, and then once they become COVID negative, and they could tolerate temporary pacemaker, we have put them on a permanent pacemaker. So heart block, complete heart block is should be more easy to observe, while sinus bradycardia is more likely not to trouble you, and you can simply avoid putting a temporary pacemaker and just simply observe and see about that. In a patient with a bradycardia, you can just try isomethylene or atropine, and we have not just sinus bradycardia. are not requiring much of the pacemaker in our experience. However, it has been reported the sinus bradycardia may turn out to be sick sinus syndrome, and we will require a pacemaker, which we can observe and reassess after the patient recovers from COVID. To summarize, the most fatal arrhythmia is intensive care is VTVF, and almost 10% of people have died in most severe intensive care because of ventricular VTVF. They could be multifactorial, they could be because of hypoxia, myocarditis, or acute thrombotic occlusion, or myocardial ischemia, acute MI is there. The other arrhythmias like heart block and sinus bradycardia are easier to manage. Sinus bradycardia, we can even simply patient can recover, and we can later on reassess. And after we have even seen patient persisting up to 3 months, and they generally recover with sinus bradycardia. But that is not the case in the patient who develop heart block. Various drugs have interaction. One should be remember, we have used a lot of this azithromycin, chloroquine, and some other drugs for them. They could interfere with your patient, and one should be aware of it, and they could prolong your QT. And if you use them, which I'm sure more and more physicians will less likely to use in future, but if you use them, then you need to have ECG so that your drug doesn't interact and doesn't cause a long QT syndrome in such patient. Coming to the acute coronary syndrome, in one of the STEMI is a small proportion of patient has been seen with COVID. Almost about 1% of the patient has been reported, but we simply do not know the amount of STEMI because of the COVID or STEMI during COVID. We simply won't know the correct data. In a series from Italy, almost 28 patients with COVID in STEMI, assessed by angiography, showed that 17 patients had evidence of culprit lesion that required revascularization. And many of them, COVID report was not available when the patient was taken for angiography. So that needs to be looked at. Now, one of the studies from India, Bangalore, they have said that in their experience, mortality is very high. We in our center, we have been more less aggressive in the form of intervention for the such patients who are stable, and we've been trying to more pharmacoinvasive, and we are more lucky and successful in managing aggressive pharmacoinvasive approach. And those who are required, we have shifted them when it has failed in our experience. So as I said, it is estimated that about 1% of the patient could have suffered acute MI. However, nobody knows the exact data. We are more likely that we would have missed the patient of the patients because of the inability to reach and multiple factors. The other point I would like to point towards is that spontaneous coronary artery dissection has also been reported in literature. We have not seen in our experience in COVID, but it is well documented beside acute thrombus that spontaneous coronary artery dissection has also been reported in this increase. And you can see from this series in acute coronary syndrome in COVID, that you can very clearly see coronary dissection was the cause of presentation in young people because of the COVID. This slides very clearly tells us that we will not know the exact situation of the acute coronary syndrome because of the COVID, but we do know that the presentation of the during the COVID, acute coronary intervention had drastically reduced even in the states like United States of America. So we do not know the exact figures of the acute myocardial infarction. As far as the treatment is concerned, as I said, in our hospital, we were more aggressive with the pharmacoinvasive therapy, and those only with very sicker and more failed with pharmacotherapy were taken up for the intervention. But there are hospitals and there are people who, and the guidelines do recommend that if you have facilities and you are prepared for completely setup, you should be very aggressive, and all patients should be treated irrespective of what is the COVID is there or not. So all high risk patients with STEMI, like hemodynamic instability, cardiogenic shock, recurrent ongoing chest pain, refractive therapy, life-threatening arrhythmia, mechanical complication, acute heart failure, recurrent ST elevation should be taken to cath lab. Immediate intervention should be done irrespective of what is the COVID status or not. Other high risk patients like established NSTMI or dynamic ECG changes, you could assess them with the COVID and then shift him to cath lab within 24 hours. That is acceptable therapy strategy as far as concerned. Other patient, you can wait and take it very easy. So all when you have an aggressive approach, your team, you should have a setup where you should have a complete PPE kit and all these things, and a large volume center will always provide you the facilities, and you can provide and do good job in primary PCI. And merely because patient is COVID and patient deserves a primary MI, you can salvage LV. One should not be denied the primary PCI in such patient. So, and a word about ACE inhibitors. We know that COVID basically has acts on attachment. This says activation TMR SS2 and AC receptor angiotensin converting enzyme 2. So we have learned that ACE inhibitors are quite safe to use in this patient. The patient is continuing to use ACE inhibitor. We should not stop that. We should not withdraw it. And the patient is what deserves the ACE inhibitor because of LV dysfunction and patient is stable. We should give it. That we have learned in this two phase that quite safe to use this both thing. And these are the studies which has very clearly shown there was some initial confusion because of the action of the coronavirus and ACE inhibitor, but it's been very clearly shown that there is no confusion of, or there is, one should not be denied to use ACE inhibitor or ARBs, and there will be no interaction with them. In the second phase, second COVID, we did not see in first phase thrombotic presentation. In the second phase, we see a lot of patients with thrombotic presentation like pulmonary embolism, stroke, and very rarely acute MI with thrombosis. So who are the people at a risk factor? Acute illness, bedridden, genetics, fever, diarrhea, sepsis, multiple reasons could be there. We still don't understand who were the prone for it, and that, but we should remember that this does causes this thrombotic presentation, and it's important to suspect and monitor. This will happen when the patient is likely to recover from ARDS or sick COVID, and you may take a lower regard. No, he's recovering, he's fine. Then suddenly he's through the stroke, or he becomes pulmonary thrombolism. So it's important to monitor D-dimer, prothrombin, and platelet counts during recovery phase of the sick patient to prevent or detect venous thrombolism, like acute myocardial infarction in such thing. That generally happens in the end of the second week or beginning of third week. So there's a cascade of which works on Virchow's triad. We all know that it basically immobilization, viral anemia would cause some inflammation, a cytokine storm, and that would probably cause some hypercoagulable state, increased TNF, protein C, and AC depending binding and shedding will be there. There are series which now has clearly shown that there are increasing incidence of venous thromboembolism as far as pulmonary and stroke is concerned, and then that various series have reported various percentage wise. The more sicker the patient, the higher the chance of thrombotic event is likely to be there within sicker patient rather than more. And the algorithm should be very same as the normal, that you need to have a high risk group should be managed like PT is there, then you need to have an angiogram to confirm the diagnosis, whether you want to thrombolize or you want to do angiography. And if you need, then you basically you may have to give long-term anticoagulation for that. That should be very good. Extended thrombolysis may be required. You documented thrombosis there. Then one could use low molecular heparin or Novax for about 6 weeks or so. People have used it about 45 days. But then it also needs to take into account the risk of increased bleeding, and it's basically the sometimes difficult situation. But then you probably will be interested in high risk patient, comorbidities such as active cancer or D-dimers are very elevated. Then one would probably go in for prolonged therapy for about 45 days or so. Coming to the long-term chronic COVID beyond 2 weeks, the major cardiovascular complication, but we have noticed is the bradycardia and palpitation. And we have also noticed some of the patients could be having myocarditis. We have rarely seen a patient of pericarditis with a heart failure. So routine investigation, we would recommend patient to have a serial ECG and echo, and active sports or activity back to normal. Generally, patient has suffered myocarditis from the time, should be abstained about 3 to 6 months, depending on the level of involvement of. And if you have facility, you should get cardiac MRI and before clear them for active sports as well. So thank you very much for your kind attention, and thank you for the opportunity. Thank you.
Excellent talk. And this is an invited guest lecture. We really don't have a question and answer session, but if anybody is interested in knowing something from Dr. Professor Manoj Kumar Rohit, we can give you 1 or 2 minutes. Or otherwise, we take the
Thank you.
Good evening. After that brilliant talk from Professor Rohit from PGI Chandigarh, it's my great pleasure to invite our past president of CSI, Dr. Minal Kanti Das, to deliver the next guest lecture on NOACs in CAD and PCA. Dr. Minal Kanti Das needs no introduction. He and he has always been associated with CSI for the past few decades, right from being a member to holding important positions to doing human service for CSI and to take the organization forward and to greater heights. And besides that, for people of Northeast, he is actually, we call him our own Minalda because he studied in Assam Medical College. And whenever we converse with anybody, any cardiologist from the region, Minalda always speaks in Assamese. And so he's really endeared himself to all of us. So he's just like our brother, and we are really happy to have him here to deliver the second lecture. Over to Minalda.
Thank you very much. May I share the screen?
Yes, sir.
Yeah, good evening. Sobe tumaloke bhala sa? Neil, Pranab, Dipakda. Good evening, everyone. And it's a pleasure for me to speak on a very, very important subject today, NOACs in CAD and PCI, an overview. Am I audible? Dipakda, am I audible?
Yeah, you're
Neil?
audible. You're audible, yeah.
Yes. This is very important because of the fact that the NOACs, which is also known as the novel oral anticoagulants, and also known as direct oral anticoagulants. And these are coming very much in a big way in the recent management of coronary artery disease, PAD, as well as in PCI. Now, what is important for all of us to know that where we require the NOACs in coronary artery disease, there are few cohort of patients which actually might be associated with NOACs or DOACs and de novo, or they might be having to be added later on. And these cohorts could be a patient with atrial fibrillation receiving an oral anticoagulation who now needs PCI and antiplatelet agents. And then a patient on this APT, and he has developed or she has developed new onset atrial fibrillation, and naturally the WESI is being started, and that patient requires the the PCI. Then there is also the chronic coronary syndrome patient who are now being benefited with the oral anticoagulation, that is DOACs or NOACs, and they might need the PCI. And similarly, the patients who are already on NOACs due to DVT and MT or IMT, and they might require also a PCI because of CCS or ACS. So these are some of the cohorts actually which can require both the DOACs and PCI. Now, what is the burden of the disease is that the WESI is indicated in almost 1.6 million people, and the CAD is there in almost 4.8 million people, and revascularization may be required in about 1 to 2 million of people. And you know that the atrial fibrillation is a very, very burning problem, and there are also some important points which need to be discussed while discussing the DOACs in CAD. The 1 in 4 individuals will develop AF during their lifetime, and AFBT might require PCI, and they have historically been treated with WESI and DAPT, and this is called TAPT or TAT, triple antiplatelet therapy. Now, AF increases the risk of stroke by 4 to 5-fold and accounts for 15% to 20% of ischemic strokes. And addition of SAPT to an OSC actually increase the risk of bleeding, which I'll come to in a little bit detail later on. Now, what is very much well-known fact that dual antiplatelet agent is the most important armamentarium in the coronary stent implantation, whereas the oral anticoagulation is very, very important in atrial fibrillation with the complications in the form of stroke or others. And when we combine these two, that is dual antiplatelet agents plus oral anticoagulation, this is known as TAT or TAPT, and this can actually lead to a very important complication, that is bleeding. Now, why we should be concerned about the bleeding? Because of the fact that bleeding increases the chance of developing anemia, cardiogenic shock, hypotension, and subsequent requirement of transfusion. And of course, the APT interruption, that is antiplatelet agents interruption, which actually are the responsible risk factors for developing ischemia, inflammation, and concurrent stent thrombosis in a patient who is already on stent. And all these factors actually may lead to the increased mortality. And that is why this is very, very important that we must have a very much balanced sort of equation while managing the risk of thrombotic events versus the risk of bleeding. And this is already known that when antiplatelet agents, they are very much important in preventing the stent thrombosis, whereas the oral anticoagulation is very much increasing the bleeding episode, but reducing the stroke. But the combination can increase the chance of bleeding. That is why we must take care of the combination in a very, very definitive way. Now, very interesting points that have come up recently. We know the ischemic cascade as well as the anticoagulation cascade. And we know that the plaque disruption followed by the various reactions resulting into platelet aggregation and activation, ultimately they cause the formation of the thrombus. Mind it, this is actually a white thrombus. and related to mostly the related to the platelets. But of late, we have come to know that the NOACs, they are also coming into the interplay with the platelet aggregation through the thrombin 2A, and they actually can also reduce the platelet aggregation and also they increase the platelet aggregation and formation of the thrombus, which can be actually reversed by the newer oral anticoagulant agents like rivaroxaban, apixaban, edoxaban, and dabigatran, and also the subsequent ones. And what is also important that DOACs reduce the atherosclerotic plaque formation and progression of the plaques and stenosis, and also there are multiple pleiotropic effects which are responsible for preventing the further thrombosis or instantaneous stenosis. Now, these are some of the historical trials of NOACs in CAD. I won't go into the detail of it, but definitely it's very interesting that COMPASS has been tried with the combination of rivaroxaban plus aspirin, and they have been tried in the stable coronary artery disease, PAD, and others, and they have shown significant result, which I'll be talking a little bit in detail. But this Atlas TIMI 51 trial actually showed the efficacy of the combination of the antiplatelet agents with rivaroxaban plus aspirin, and they showed non-inferior results. And similarly, in the COMPASS trial also, they have shown non-inferior results in terms of reducing the MACE as well as the mortality, and when they were combined with the rivaroxaban plus PTY2 inhibitor plus aspirin. These are some of the historical trials for NOACs in PCI. These are already discussed, I believe. Pioneer atrial fibrillation, Redual PCI, Augustus. This one with the rivaroxaban. This one with the dabigatran, and Augustus with the apixaban. And they have shown really very good results in terms of reducing the events, though there was a little bit of increase in the chance of the bleeding. All the trials, the Pioneer AF, Redual PCI, Augustus, Entrust AF, which used the edoxaban. And overall result was actually beneficial when the NOAC was used along with the single antiplatelet agents. And similarly, the trial-defined clinical significant bleeding was also studied, and that showed the reduction in the cumulative incidence when the NOAC plus SAPT was used as compared to the VKA, that is vitamin K antagonist, plus DAPT, that is triple antiplatelet agents. And similarly, the risk of the patients were also much reduced. Now, there was good information regarding the subgroup analysis. When the age was concerned, the MACE was reduced favoring the TAT, but in elderly. And when the bleeding was concerned, the NOAC plus the single antiplatelet agent actually was favored in the elderly as well as the non-elderly. So this is a very important message. Similarly, in the sex also, you can see that the TAT overall message was more in favor of the DAT than in the TAT. And of course, in case of bleeding, it was same with the male as well as female. It was more favorable with the DAT than compared to the TAT. TAT means triple antiplatelet agents. Same with the clinical presentation in chronic coronary syndrome as well as the acute coronary syndrome. And in, of course, the bleeding, it was a little bit more favoring the triple dual antiplatelet therapy. When the CHAT-VAS score was considered and the Hasbled scoring system were considered, again, the TAT was more favorable in case of bleeding, reducing the bleeding risk as compared to the DAT. Now, I am not going further in the detail of these. What I'll be trying to show you that considering all the facts related to the DAT and TAT and the algorithm that have been put forward by both the ESC as well as the American Heart Association, then European Heart Rhythm Society, they have come to somewhat consensus level, which I'm going to show you. These are based on CHA2DS2-VASc score as well as the Hasbled score. And there are different steps based on the different risk strata. And then you have to go from step 1 to step 2 to step 3 and ultimately the step 4. And the various risks, as per the risk factors, actually you can go to the first one based on the CHA2DS2-VASc score, that is the low risk thrombosis with the low risk bleeding. So if both are low, then you can try with the combination of the oral anticoagulation plus antiplatelet agents plus clopidogrel for about 1 month. Then, of course, after 6 months, you have to assess, and then you should go for DAT, that is oral plus one of the antiplatelet agents, that is an aspirin or clopidogrel. And after 12 months, then only the monotherapy with the oral anticoagulation can be tried. And same way, with the low thrombotic risk, with the high bleeding risk, actually one can go for the this oral anticoagulation plus combination of the clopidogrel, that is the antiplatelet P2Y12 inhibitor for about 6 months. And after 6 months, you can go extend up to 12 months based upon the bleeding risk. And beyond 12 months, you should go with the only one therapy, that is the oral anticoagulation. As compared to this, the high thrombotic risk with low bleeding risk, one should try with the triple antiplatelet agents for maximum up to the 3 to 6 months, and thereafter the 6 months oral plus and one antiplatelet agents beyond 6 months up to 12 months, and after that only oral anticoagulation. Same way with the high risk thrombotic and the high risk bleeding group, one should try with the triple antiplatelet agents only for 1 month, and after that the dual antiplatelet agents for about the 6 months, and after that, of course, one should go for the oral anticoagulation beyond 6 months. Then there are certain data that have come out in the recently by the North American Perspective Group. They have published the 2021 update, which actually recommended that the dual antiplatelet therapy with aspirin and P2Y12 inhibitor should be given to all patients during the peri-PCI period and during inpatient stay until the time of discharge, that is up to 1 week after PCI at the discretion of the treating physician, after which the default strategy is to stop aspirin and continue with the P2Y12 inhibitor. So this 2021 update actually recommends the triple antiplatelet therapy for about 1 week, and thereafter the dual antiplatelet therapy combining the DOAC plus the antiplatelet agent, and that should be continued for 12 months. And after that, of course, the single antiplatelet agents, anticoagulation, that is the DOAC, should be continued after 12 months. Same way, the EHRS, European Heart Rhythm Society 2021, they also recommended us almost a similar kind of thing with the triple therapy for about 1 to 7 days. And after that, based on the risk, one can go up to 1 month to 3 months. And beyond that, they can go based on the bleeding risk and thrombotic risk, one can go up to 6 months. And of course, with the ACI, with PCI, with the ACS, one should go for the triple therapy for about 1 month, and beyond 1 month dual therapy, and after 12 months, of course, the oral anticoagulation. Only in very, very high risk patients, one can try with the triple anticoagulation patient for only 1 week. So these are some of the information which are very, very important to think about the various aspects of the DOAC therapy in PCI or in CAD, but no talk will finish in the corona pandemic situation if we don't talk about the action trial, which has been presented in the SEC 21, and where the rivaroxaban was tried, and there was no significant benefit with this particular molecule during the COVID-19 infection presenting with the STEMI, and major bleeding was increased. That was the reason the trial has to be stopped, and it is not being tried right now. Of course, there are trials going on freshly by taking some of the cues from the trial that showed a negative result. So let us go to the take-home message from my whole talk, which is based on the ESC and ACC guideline 2020 mostly. Mind it, in 21, there has not been major change, because most of the findings that were there in the guidelines of ESC and ACC in 2020, they are the continuing recommendations even in 21. Now, one of the points that I should give emphasis is that when aspirin is used, the daily dose should not be over 100 milligram. So this is a very, very important point. And post-PCI patients eligible for DOAC therapy, either apixaban 5 milligram twice daily or dabigatran 150 milligram twice daily, edoxaban 60 milligram once daily, or rivaroxaban 20 milligram once daily, is used in preference to VKA when it is recommended with the antiplatelet therapy. Antiplatelet therapy means either aspirin or the P2Y12 inhibitor. And this is recommendation 1A. Second is where APT or OSE are indicated. Recommendation is that default strategy after the recent antithrombotic therapy consisting of anticoagulation and P2Y12 inhibitor should be the strategy of choice, and not triple therapy. The triple therapy is to be considered only for high thrombotic risk patients, only for high thrombotic risk patients, as I mentioned here, and not with the low risk patients. And in the setting of recent PCI, less than 6 months of stable coronary artery disease and less than 12 months of acute coronary syndrome, the preferred antiplatelet agent is, of course, the clopidogrel, not the ticagrelor or the prasugrel, because of the more chance of bleeding, especially the prasugrel. When long-term OS is warranted for stable coronary artery disease, and PCI is recommended, the preferred antiplatelet agent is to be given for 6 months, and it can be extended beyond 6 months. But after 1 year, only one agent, that is the oral anticoagulation, should be continued. PCI on DOAC, periprocedural clopidogrel over other stronger P2Y12 is recommended, and that is class 1 recommendation. Post-PCI, stopping the drugs at less than 1 week for aspirin and continuation of dual therapy with an oral anticoagulation with clopidogrel should be considered if the risk of stent thrombosis is very, very low, especially in stable coronary artery disease with a single coronary artery stenosis. One may try with this, that it can be the aspirin can be stopped just after day 1. But mind it, this has not come yet to the recommendation level. And post-PCI, triple therapy with aspirin, clopidogrel, and an oral oral anticoagulant for more than 1 month should be considered when the risk of stent thrombosis outweighs the bleeding risk, with a total duration less than 6 months decided according to assessment of the risk, and this is class 2A recommendation. So, ladies and gentlemen, this is a very, very important topic in the sense that all the drugs, that is NOACs, that is apixaban, then rivaroxaban, and dabigatran especially, and of course not the edoxaban, they are available in India and they are being used quite frequently, and we must use it more frequently than what we are doing now, and especially with the COMPASS trial, mind it, the use of the DOAC has increased. Even without any atrial fibrillation, one can use the DOAC straight away, and these patients might require PCI, and in that background, you'll have to continue the DOAC along with the single antiplatelet agent if there is no bleeding risk, and of course you will continue the various duration weighing the bleeding risk versus thrombotic risk. That is, thrombotic risk means it's related to the stent thrombosis as well as the stroke and other thrombosis, DVT and all. And if you can consider all these facets, definitely the overall management of the patients of coronary artery disease with PCI will be the best one to our mind. Thank you all for patient hearing.
Thank you, sir. Thank you for your wonderful deliberation. Am I audible? Hello.
Thank you, Vinalda. Very lucid presentation as usual. And because of paucity of time, I think we can't take questions. Our next speaker, our professor and sir, Professor K.K. Talwar sir is also waiting. So I think Vinalda, giving a lot of thanks to you. Hope to see you soon. Physical.
Thank you and namaskar.
Thank you, sir.
Over to Pranam.
Good evening.
Hello.
By Professor K.K. Talwar. Sir, am I audible, sir?
Yes, am I audible, Pranam, to you?
Yes, sir. You are clear, sir. Clear.
Thank you, sir.
So, Professor Talwar needs no introduction actually, and he is Padma Bhushan awardee. Professor K.K. Talwar is a renowned cardiologist and the former chairman of the Medical Council of India. He was the former head of Department of Cardiology at All India Institute of Medical Sciences, New Delhi, and director of PGI-MER Chandigarh. And it is very interesting that to know that, I mean, people will be interested in knowing, he is credited to have performed the first implantation of implantable cardioverter defibrillator therapy in South Asia, for which he has been, his name has been featured in the Limca Book of World Records in 1997. He is also credited with introduction of CRT in India, and for which he has also been listed in the Limca Book of World Records. He is the recipient of several honors, including the prestigious B.C. Roy Award, the highest Indian award in the medical category. He was the former president of the National Academy of Medical Sciences, NAMS, and the fellow of the National Science Academy. And the government of India awarded him the third highest civilian award of Padma Bhushan in 2006 for his contributions to medicine. And his works on cardiac arrhythmia helped develop it as a specialty in India, and developed heart failure and heart transplant program at All India Institute of Medical Sciences, New Delhi. And his work has been documented, well documented by way of several publications in a huge body of publication in national and international peer-reviewed journals. And important chapters in various medical textbooks. So without wasting further time,
So I would just like to say that you are also our guru of Gornali, Pranav and me.
All three of us, sir.
All three of us. And whatever you have learned in cardiology, you have been our examiner and you are the one who has guided us and made us cardiologists. So for that, sir, we are eternally grateful to you and always, sir.
So I'd like to request sir to kindly proceed with your presentation, sir.
Thank you so much, Dr. Pranav, Dr. Baroli, Dr. Niels. I think it's a really pleasure to see all of you. I think it has been a very difficult time with this pandemic that we all have faced, but I'm sure that we are all coming out of it. So it's really sort of great to see all of you again. And I hope that everyone is fine and everyone is fine in the family. Now, can I share my presentation, Dr. Pranav?
Yes, sir. Sanghamitra, would you please share sir's presentation?
I just presentation. Now you excuse me, I'm little not very sort of knowledgeable as far as using this. My grandson is helping me.
Yes, sir. Yes, sir. The slides are visible, sir.
Okay, thank you so much. I think I'll share with you what is the current status of CRT and ICD in heart failure. And I think we all know that as far as the heart failure, the mode of death is either because of the sudden death or because of the pump failure. And in class 2 and 3 patients, mostly it is sudden death. And where I think we know that ICD may be helpful. And of course, in class 4 patient is a more of pump failure. And in some situation, CRT is a treatment of help and choice. We have now 21 European guidelines for the both treatment of acute and chronic heart failure, as well as the sort of indication for ICD. If I just share with you that we know that as far as these are the medications that we all know, and a optimal medical therapy with ACE inhibitor, RNA, beta blockers, MRA, epagliflozin or empagliflozin, loop diuretics are very important for every patient. And then when we sort of go patients who have a low ejection fraction, usually it considered below 35% and have a QRS interval which is less than 130 millisecond, and there can be indication for ICD. I'll come to it, and both non-ischemic and ischemic background. And if a person has a low ejection, more than 35 ejection fraction, continue medical therapy. Of course, if somebody has a QRS which is prolonged than 130 millisecond and has a low ejection fraction, of course, there comes the role for a CRTD or CRTP. If we look at this recommendation of the recent European Society of Cardiology, of course, the secondary prevention, we all know that anybody who has ventricular tachyarrhythmias causing hemodynamic instability, they are a class 1A indication. Of course, we have to make sure that it is not in the first 48 hours of acute MI. But when we come to the primary prevention, it is the ICD, which is a patient who has a low ejection fraction, as I mentioned, below 35%. And he's not acute MI in the first 40 days and have ejection fraction less than 35%. And with optimal 3 months medical therapy, I think that's important. That person, I mean, some of them can recover. So I think we should not rush. And in that situation is the class 1A recommendation for ICD. And if we go on to the non-ischemic variety, there again, class 2 or 3, low ejection fraction, optimum therapy for 3 months. It is now class 2A recommendation, which used to be earlier class 1B. So I think there is some change. I'll come to it later on. And of course, I think the patients who have a generator replacement, I think we should evaluate at that time whether he now needs the sort of ICD or not. And that's why class 2A kind of recommendation. So these are the kind of ICD recommendations. Of course, we should also know that where we should not give ICD, that's within the first 40 days of acute MI, as this is not helpful, the studies have shown. So it's a class 3 recommendation. And also if a patient is very sick, class 4, unless you are visualizing transplant or assist devices or maybe CRT, you should not give a ICD implant in this kind of a case. I think we look at the Indian aspect. The issue is that, of course, ICD is useful in these cases, but very expensive. And I think why not in our setup, we must look at that how we can identify some high risk group, which may be really benefited and where we should be. So I will share with you some of the observation which might guide us that I think this patient we should certainly try to impress upon that he should have a ICD, whereas others we can be little because of the cost issue, we can avoid. If you look at the non-invasive, non-ischemic cardiomyopathy first, I think it is now class 2A indication as I mentioned, and it was class 1B indication earlier. And I must say the data about this is not very robust. I'll come to it. Danish study in 2016 showed no overall survival benefit of prophylactic ICD in non-ischemic cardiomyopathy. Of course, the meta-analysis did show there is some benefit, but we also know from various studies that only 20% of non-ischemic cardiomyopathy patients with prophylactic ICD have appropriate therapy. So there's the issue of inappropriate and also other problem of the ICD, some infection issues. So I think we need to have more kind of a solid data to be sure about this. And this is the Danish study that we all know that there was no significant benefit of ICD. And of course, they did found some total mortality was not altered, no benefit. Younger patient had some benefit below the age of 60. Certain cardiac death was less in ICD group, but total mortality was not altered. And if you look at the meta-analysis, that some of these 6 studies, which is ICD and as a primary prophylaxis, I think 2 studies did not show benefit. But if you look at the further analysis of these, whether you look at Danish study, the optimum use of medication was more perfect. ACE inhibitor was in 96-7% patients, beta blocker in over 90%, and MRA in over 50% of the patients. And of course, more than 50% also were eligible for CRT. But if you look at certain cardiac death heart failure study, which had shown some benefit even in his non-ischemic, there was beta blocker use, ACE inhibitor use, and MRA was in 1/3. So I think the optimum medical therapy was not given in these studies. So I think if you give a better medical therapy, CRT were indicated, and of course, increasing age, we know cardiac bicycle death can occur because of other cause. So I think then we may not avoid in these cases. The only issue is younger patient and how to identify them that who can be real at certain cardiac death risk, and we should give ICD. This is a MRI study, I think, which was done, published in 2017, that late gadolinium's enhancement indicating fibrosis. If you look at the patient with low ejection fraction or even more than 35%, patients who had a fibrosis had higher mortality issues as compared to those patients who had no fibrosis. This is another study which is trying to emphasize on this point that fibrosis with mortality and sudden cardiac death in patients with non-ischemic cardiomyopathy. This is published in JAMA in 2013. And if you look at the fibrosis, a present identified better way of all-cause mortality as compared to LBF, and no fibrosis mortality was less. Similarly, cardiovascular mortality or transplantation issue. And this summarizes that all-cause mortality, cardiovascular mortality, or sudden cardiac death, and heart failure, death, hospitalization, and transplant. If you look at that, those who had a positive fibrosis issue on MRI, they were more prone to sudden death as compared to those who did not have. So I think this modality, if we have to, that late gadolinium CMRI in the risk, it helps in risk stratification of the dilated cardiomyopathy who may require further investigation or maybe ICD. So I think these are the, I mean, some observations. Of course, we need to have kind of a randomized studies, but they do indicate that this group of patients may be the really risk for in this. And this is another study published in 2018, reduction in mortality from implantable ICDs in non-ischemic cardiomyopathy is dependent on the presence of left ventricle scar. And if you look at the, if there is no scar, no benefit of ICD implant, no difference between the non-ICD and ICD group as far as the mortality goes. But if you look at those who had fibrosis and ICD and non-ICD, there's significant difference. So these studies do indicate that I think a cardiac MRI and doing late gadolinium enhancement for fibrosis may be useful modality to find out a high risk and non-ischemic group where we probably will have to advise ICD as a prophylaxis. So if you have to summarize, a patient who, I mean, secondary, of course, is different. If somebody is a tachyarrhythmia, he has to go for ICD. But patient for a primary prophylaxis, I think younger age group, do MRI, and if there is a fibrosis present, I think we may consider a ICD in them. So for elderly people, probably we may realize that they may, as such, there may not be much benefit. But I think we have to have a set randomized studies. And this is the study which has been now CMR guide study. We are trying to address to this issue that I mentioned, a randomized study which is going on. But only thing, they have taken patients who are ejection fraction from 36 to 50%. They have not taken patients below 35. So I think let us see what are the outcome. That's one way I think we can identify a high-risk patient. Of course, in ischemic cardiomyopathy, I think again in our setup, every patient will be very difficult to give a prophylactic ICD. And I think we may prioritize the high-risk group. LBF may not be considered as the only indication for ICD in these kind of, I mean, if you want to a high-risk group. And of course, we should optimum therapy, revascularization, that will certainly help. And I think these are some of the MED2 sub-analysis indicating which are the high-risk factor, like patient who is elderly, very low ejection fraction below 35, AF, New York heart classification class 3, creatinine 1.4 or more, and QRS 1.3 second, little wide QRS. And if you take a scoring, patients who have a 0 score, the hazard ratio was not much. But those who have 1 or 2 risk factor, I think they may be, or 3 risk factor, more than 3, as such they may be prone to death. So I think this may help us to identify a high risk subgroup in them also, where probably ICD may be really indicated and helpful. Of course, this is another question that always that bothers me now. Why after 40 days MI you should have a sort of a prophylactic ICD? Why not 3 months at you have given for other patients? So I think we don't have much data on this. But if you look at the MEDIT data, sorry for the spelling, MEDIT data, that most of the patients, 80% of patients which were included in the study were more than 6 months MI. So I think that's indicate that there were very few patients who are between the 40 and 90 days. In the Japanese studies, the data was not consistent with the MEDIT data. So I'll say we should give optimal medical therapy, revascularize if needed be, and wait for some time if the ejection fraction improves. But I think I leave it to, because the guidelines do indicate, but we need to always evaluate in our own mind and try to find out what is the right thing. Now, if I go to now the CRT and the heart failure, I think we all know that in patient with heart failure, that about 1/3 or more than them have a wide QRS. There's a ventricle dyschrony. And this is very important data, which is quite old, but it does indicate that age, creatinine, low ejection fraction, heart rate, QRS duration, they are independent predictors of mortality. And what has been seen that if you compare the sort of narrow QRS and the wide QRS, in the wide QRS, the mortality may be 5 times greater than the narrowest QRS. So it indicates there's a more dyschroning in patients who have wide QRS, and if we can improve this dyschroning, we may be able to help these patients. So if we look at the indication for CRT device, class 3 or 4 patients, maybe class 2 patient also, symptomatic, despite optimal medical therapy, low ejection fraction below 35%, wide QRS, I think is now indication. I'll come to the European guidelines, which have been, I mentioned, recently published, and CRT plus ICDs, same ICD if indicated, you should add to CRTD rather than CRTP. Now this is, if you look at the European Society guidelines, again, LBB more than 150 millisecond, low ejection fraction, I think optimal medical therapy for 3 months. I think optimal medical therapy patients and still continuing like this, class 1A. And if a QRS duration is 130 to 149, it becomes class 1B. But if somebody has non-LBB and the QRS duration is more than 150, it's class 2AB. And of course, if it is the 130 to 140 non-LBB, it is a class 2 and B level of evidence. Patients who are sort of CRT rather than RV pacing is recommended. Patients who have low ejection fraction, regardless of the N/HA class or QRS bed, but are indications for ventricular pacing. I think now these days, if somebody needs a pacing, have a low ejection fraction, I think maybe you should prefer CRT rather than the RV pacing. And this may also include patients with atrial fibrillation. Of course, when I think somebody is on conventional pacemaker on ICD and needs a change of generator, look at the now ejection fraction. If it is improved, I think you can avoid it. It's like a class 2A. And if the QRS duration is less than 130 millisecond, even if the echo shows some dyschroning, it's a class 3 indication, they should not be given CRT. It just shows some of the, I mean, this is a coronary sun. These are some of the our earlier cases. I think first few cases you see coronary sinus lead and RB lead. And the wider the distance between the two, wider benefit you may get. This is just to emphasize that sometimes it's very easy to go to great cardiac vein. And this is just across the septum, RB, and the LB lead. And these patients do not sort of benefit, rather they may sometimes even deteriorate. So it's very important that when you're putting the LB lead, you should go to the lateral veins and not go into the great cardiac veins, because it may be easier to go. I think you have to make effort to go the lateral area rather than to this particular side. Of course, just to share with you, one our patient who developed dissection. These were the initial days of our implants, and I think coronary sinus were dissected. We followed it after 2 months again. It was still like that. Then we have to give a epicardial lead to this lady. Of course, sometimes the coronary sinus is very tortuous, small, and you have to might do some kind of maneuvers, sometimes ballooning that area to really make sure that you get the lead to the right position. So I think the CRT challenges we also should understand. CRT sort of phrenic nerve stimulation issues, high pacing thresholds in issues, lead dislodgement is an issue, and surgical lead revision that causes increased risk of pocket re-entry infection. And of course, there is a trade-off between lead stability and optimal pacing location and for the CRT efficacy. So I think these are challenges. I think when you do for positioning of the lead to get the best benefit will depend upon the position of the LB lead. Aim for good anatomical and electrical sort of anatomical is a separation with the RB and the LB lead. The wider it is, to get better benefit. And as per this, I showed you earlier also great cardiac veins, and we should avoid going to this vein. And electrical optimization, make sure the LB lead plays as late as possible in the QRS complex and RB lead as possible in the earlier phase. And if the difference between the two interval is more than 100, I mean nearly 100, it's very good. So I think we should try to have wider a difference between the two to get the better outcome. We also have now the quadripolar leads, and I think which can help you to have a sort of more option for pacing and also avoiding the phrenic nerve stimulations. This is just to show you the meta-analysis. Dr. Cleland, who was author of the CARE heart failure study, which really showed first time the mortality benefit of CRT. And then again, we show that overall effect of cardiac resync therapy, I think it's beneficial both for all-cause mortality as well as heart failure and hospitalizations. Of course, I think optimum CRT, you may reduce the mitral regurgitation, and that is again helpful in remodeling. Short up time will not permit me to go into more details. This is one of our very earlier case. You look very large heart when we started in AIMS, and you see within a 6 month or so, December to July, heart has almost shrunken. This was another patient, just to share with you, 2014. He had a coronary disease, LBB dysfunction. Surgery was done. His LV ejection fraction improved somewhat within 6 weeks. Then we had to go for CRT. We gave a P. His ejection fraction improved to 50, and now I think he came a few months back. Is still persisting ejection fraction around 50%. Of course, we know that there are responder, there are super responder, there are non-responder, and I think there are 30% patients who do not respond to this therapy, and whereas the various reasons for non-responder may be prior MI, absence of significant mitral regurgitation, ischemic cardiomyopathy, or DCM patients usually have a very good response, and some of them may have a super responder kind of a group. I think this is a new area which is coming, very exciting, very stimulating, but we need to have, we'll see how it matures into is a conduction system pacing for CRT kind of therapy. And that we know that we are 4th site that has been like either do is bundle pacing, you do left bundle pacing, septal pacing, or you and the epicardial lead. So you have these are the 4th site. So you have a his bundle pacing CRT phenomena, which they say maybe as good as biventricular pacing. You have a LBB pacing CRT, or biventricular or hot CRT, that is his optimization CRT, or left bundle optimization CRT. I think these are the areas being evaluated, because we have 1/3 of the patient, and some patients with right bundle branch block who do not benefit with CRT. Can they be benefited by these kind of approaches? I think there are few studies whereas his bundle pacing in left bundle branch block have shown benefit, and that more safe as well as a beneficial effect. Similarly, his bundle pacing in the right bundle branch block studies, or left bundle branch pacing. So we have some data which is very encouraging, but we need to have a more of a randomized studies to be very sure. This is a hot CRT, his bundle and times cardiac resync therapy, and shows that small study, 25 or 27 patients, I think they were successful in these. So similarly, you have the, I think, left bundle lot CRT again showing. So I think that data is very stimulating, very encouraging, but we'll have to wait for the time to be sure that how beneficial it is going to be compared to the biventricular pacing. So I think just to summarize, I think we now have option, even the right bundle branch block, left bundle of course, and IVCD, that we have different options that we can have a resynchronization to probably improve the LV function. Just to summarize, I think the mechanism of RCRT is it improves intraventricular synergy, which is improves DBTT, ejection fraction, cardiac output, decreases mitral regurgitations, and atrioventricular synchrony, and then interventricular synchrony. So all this results in our reverse remodeling, and that's why significant number of patients may show significant benefit. So I think I like to close, and I thank you so much, all of you, Dr. Pranav, Dr. Vanoli, Dr. Neil, really deeply pleased to see all of you after a long time. So virtually, I am sure that things will pass and we will be able to meet each other soon. Thank you so much for this invitation.
Thank you, sir. Thank you for the wonderful talk. And I think any comments from our board chairpersons?
Sir, it's a pleasure seeing you and having the sight of you. So, mentor for us, and we have learned so many things from you. And just wish your good health, sir. And
Good. I think nice to see all of you are looking very, very sort of fresh. That's good to see. But now, and Niels, I learned, Lean, you went through some difficult time with the COVID, huh? You look fresh back. I learned that you had gone through some.
Yeah, I was not with COVID, but recovered with some extra 10 kilos more, sir. 10 kilos of
Good, I
fat.
think we are all now warriors of COVID, eh? That's right. Thank you, Pranam. So,
Thank you, sir. Thank you, sir. It's really an honor, sir, you joined us.
That's so great.
Yes. And so for us, you still, I mean, still.
we need your blessings, sir.
We need your blessing.
no, I think to me it freshens my old days. It's nice of AIMS and PGI seeing all of you. Good.
Thank you, sir. Good night.
Thank you. Good night. Good night. Thank you. Thank you so much.
And I think we, no, I think we finished. So we have come to the end of the last session. And now we'd like to announce the results for the free paper session, the prize money free paper session, which was held this afternoon. And so coming from the bottom to the top, we have for the third position, we have a joint winner, Ananya Goswami and Aditya Narayan. So we really congratulate them. They are postgraduate students from Guwahati Medical College, postgraduate MD medicine students. In the second prize, we have Dr. Shakil Ahmed Khan. He is a DM senior resident in Negrim, Shillong. And for the first prize, the first prize goes to Dr. Wasim Faruqi. He is a senior resident, DM Cardiology, Guwahati Medical College. So these are the winners, and I'd like to request them to please contact the organizing committee to receive their prizes as well as the cash award, and the certificates will be mailed to their registered email IDs. So congratulations once again. And I think we come to the end of this Northeast CSI Update 2021. And now I'd like to request the members of the Northeast CSI to please, I would like to request Dr. Professor Csi Ne sir and Deepak Sharma sir, Dr. PC Sharma sir, and all esteemed members of Northeast CSI
For a brief
and Dr. M.K. Das, Minalda, if you would like to please have a few last words, encouraging words for us, it will be very good.
Minalda Asaniki.
Just a minute.
Deepak, I think we start with Minalda is here.
I think we should start, yeah.
Deepak da ko.
Moi kobo lagi ase, tumi kobo lage?
No, apni kobo.
No, you have a valedictory function too. Tumi to come
and mane enoka bhalo hoise conference really. Sabak dekhi paisu ako Dr. PC Sharma, Barnali, Pranab Jyoti, Kukreja ji, kenoka? Neil, really ভাল লাগিছে সবক দেখি, and really thankful to all of you for giving me the opportunity to speak, and really CSI any chapter should grow to a very, very greater height. That's my wish, and I think the team, the new team that is building up under the leadership of Dr. Deepak Sharma and all others who are really working hard will definitely do the CSI NIC any chapter proud of their activities. Over to the organizing committee. Thanks, everyone.
Bye.
PC, mute হৈ আছা? তোমাৰ মোৰ আৰু ভাৰতৰ তিনিটাৰ ৰিফ্লেক্টৰ কেইটা বেছ তৰতৰকে জিলিকি আছে।
কিন্তু আপোনাৰ ৰিফ্লেকশনটো বেষ্ট।
ৰিফ্লেক্টৰ ভাল জিলিকি আছে আমাৰ। প্ৰণৱ আৰম্ভ কৰা আৰু ভালকৈ।
Dada, so coming to the general meeting, I think I leave the podium to you with the proceedings.
জেনেৰেল মিটিং আৰু কি? জেনেৰেল মিটিং মানে এইটো হেৰি কৰা, এই মানে ভ্যালিডিক্টৰি আৰু জেনেৰেল মিটিং একেলগে হৈ যাব সব। এজেণ্ডা কৰিবা জানো? যিহেতু জেনেৰেল মিটিঙৰ টাইম নাই ন সব থাকিবৰ কাৰণে, গতিকে ভ্যালিডিক্টৰি হোৱাই ভাল হ'ব নেকি আজি?
যেহেতু জেনারেল মিটিং হয়েছে, মই গুড নাইট জনাইছো সবক।
ঠিক আছে, থ্যাংক ইউ।
ওকে ওকে বাই।
জেনারেল মিটিং খনৰ এজেণ্ডা আছে নেকি অমিয়তৰ?
জেনারেল মিটিং খনৰ এজেণ্ডাটা পঠিয়াইছিলো।
অলিয়া তই প্ৰেসিডেন্ট, তই জেনারেল মিটিং যদি তই প্ৰিজাইড কৰিব লাগিব, মিটিংখন প্ৰিজাইড কৰ।
এটা ফাৰিনে এটা ভোটৰ থ্যাঙ্কস দিব ফাৰিনে। ফাৰিন
ভোটটো পিছতহে দিয়ে।
No,
validatory voter thanks.
Two lines. I think we had wonderful 2 days of academic extravaganza. This was really, very. It was a learning experience for us, for everyone, because first time we held a conference virtually. That is, we had to depend on the technology. And end of the day, I think everything turned out to be very nice. 2 days of excellent academic feast. And for the very first time, we had successfully arranged competitive section, especially for the postgraduates and the DM students, where we had 3 sessions of competitive CD presentation, the paper presentation, as well as the open house quiz competition, and we had extensive participation from all quarters. So that was really a good experience. And over and above this meeting, in this day and times of COVID pandemic, and holding a meeting of this magnitude with a galaxy of regional and national speakers, I think this is a well appreciated meeting. And apart from that, it is being accredited by the Assam Council of Medical Registration for CME credit points. And that is also, I think, one of the plus points of this meeting, because apart from attending this meeting as a delegate or a faculty or participating in any of the competitive sessions, everybody has been earning CME credit points, which will definitely add to their CV and also to their maintenance of certificate, which will, I think, it has already come in.
Actually, it was a meeting of very high standard, actually, and literally, actually, we were just an hour behind. By our standard, it is fantastic. I think because it's for the first time we held a meeting on a virtual platform, some kind of hiccup was expected and acceptable, I think. But we have literally kind of finished on time, so there's no grouch about it. No, I think nobody can complain about it. I think the